Hi friends, so in this video we shall be doing a rapid revision of the subject of radiology. So this is meant for the exam going students who are appearing for the PG entrance examinations. What I would personally recommend is combine this particular video with the snapshot video, alright. So see both of them such that you have a good grasp of the subject, particularly the images. So most of the questions that you now expect from the subject of radiology will be clinical vignettes. So they'll give you a clinical scenario and they'll have a radiological image which is attached with that, and you'll have to either make the diagnosis or suggest the next step. So those are mainly the kind of questions that you now expect from radiology. So you have to be very confident about the images. In addition, radiological anatomy is again something where you have to pay extra attention because you get tested a lot, particularly the FMG students. You always get questions from radiological anatomy. That is also something which is very important. In particular, as far as systemic radiology goes, emergencies in general are going to be very important, alright. So always pay extra attention irrespective of the subject, that emergencies are going to be a major testing area for you guys. And finally, just to conclude, what I would like to tell you how this video is designed is, first we shall be looking at general radiology, then we'll look at systemic radiology, and finally we end with nuclear medicine and radiotherapy. So general radiology, you get questions which are quite direct and one-liners, right? So in case you get these questions, do not miss out on them because those are easy marks for you. Okay, so just we'll go through the general radio portion quite quickly, and then we focus mainly on systemic radio where you get a major chunk of your questions from. And radiotherapy, nuclear medicine, just like general radio, you get a few one-liner questions which are quite high yielding and scoring. Okay, so that should be your approach for the last minute revision. In addition, one more video I would recommend you to watch is the thumb rules video, wherein I want you to just go through that video very quickly, maybe on 2x, such that you are able to grasp that concept of when to do which investigation, so that you get a lot of such questions wherein they'll give you a scenario and they'll ask you what will you do next, how to approach the patient. So when to do which investigation is again conceptual. I don't want you memorizing lists about which is the investigation of choice, which is the gold standard. I want you to have the concept of logically solving these questions of when you would want to do which investigation, right? And the thumb rules video will definitely help you do that. Alright, so that is how you should now base your preparation. After all of this, let's begin a rapid revision of radiology with general radio. So the first thing that we want to do here is look at the names of the scientists very quickly. This is something, again, you don't get too many questions from this, but just to cover all our bases, we'll be looking at this. So who discovered gamma knife? Remember, it is Lars Lexell who's the person behind gamma knife. So this is the list that we want to look at. So W.C. Röntgen or Wilhelm Conrad Röntgen is the father of radiology. Remember, he's been credited with being the father of radiology. He discovered X-rays on 8th of November 1895. This is the only date that I want you to remember, which is 8th of November, because it is celebrated as the International Day of Radiology. It's celebrated as International Day of Radiology, and in 1901 he went on to receive the Nobel Prize for the same. Okay, so this is about Wilhelm Conrad Röntgen. Moving on, Godfrey Hounsfield, Alan Cormack. These are the people who discovered the CT scanner, the computed tomography scanner, which uses X-ray in a 3D manner to take these cross-sectional multiplanar images, right? So this is the CT scanner computed tomography, and based on Hounsfield's name, we also have the Hounsfield unit, right? So you must have read this Hounsfield unit, which is the number that we give to the density of how black or how white something is. That is referred to as Hounsfield unit. Peter Mansfield and Paul Lauterbach discovered MRI, alright. So they discovered magnetic resonance imaging, which doesn't use any ionizing radiation. It uses radio frequency waves and a large magnetic field. Okay. Bloch and Purcell are the people who discovered the concept behind MRI, which is called NMR. So this is the concept of MRI, which is called NMR, which is nuclear magnetic resonance. So this concept is based on the fact that all the protons that we have in our body are going to be spinning on their axis like this. Okay, so they're constantly spinning. Now, when I keep these protons, or when I keep the body in a large magnetic field, these spinning protons are all going to now align in one direction, are going to align in a similar direction, and this is what helps us generate the MRI signal. Okay, so this concept, which is nuclear magnetic resonance, where we use the nuclear movement of the protons, that is something which is responsible for MRI images without any radiation, right? So remember, MRI, no ionizing radiation. Charles' daughter is been credited with the father of interventional radiology. Alright, so the intervention aspect of radiology, daughter is the father of it. Henry Becquerel is the father of radioactivity. Alright, so radioactivity, you must be aware of this from +2, where he is the father of radioactivity. Lars Lexell is the one who discovered the technique of gamma knife, and this has very high chances of being asked. Gamma knife is a very important topic which we shall discuss in radiotherapy, and this is also referred to as stereotactic radiosurgery. John Wilde is the one who discovered medical ultrasound. He is the one who is responsible for the discovery of medical ultrasound, and Ian Donald is the one who further described obstetric ultrasound. Alright, so he described obstetric ultrasound scans. So these are all the scientists in a nutshell that you need to know in radiology. Going ahead to the next basic concept, which is all of the following investigations use ionizing radiation except. So technetium-99 DMSA. Remember, this is a scan which is used for the kidney. For a morphological static scan of the kidney, we use the DMSA scan. And the fact I want you to remember, anytime we have technetium-99M, it suggests that it's a nuclear medicine scan that uses gamma rays. So technetium-99M releases gamma rays, and do gamma rays constitute ionizing radiation? Yes, most definitely. So this uses ionizing radiation. HSG, hysterosalpingography, wherein we inject contrast into the uterus, into the fallopian tubes, and we see the patency of the fallopian tubes. This is usually done under X-rays, right? So this is usually done under fluoroscopy. This is a video of the X-ray, and we know X-rays are also ionizing radiation. X-ray of the ankle, again ionizing radiation. FAST. So what is FAST? Again, the full form has been tested a bunch of times. So FAST is basically focused assessment. So do not confuse it with the word fast or abdomen. It's not that. It is focused assessment sonography in trauma. Alright, so this is what FAST stands for, and as the name suggests, this is basically an ultrasound technique that we do at the bedside for patients with trauma as a part of their workup in the primary survey. Okay, so this is sonography, and remember, sonography is something which does not use ionizing radiation. So going ahead, in a nutshell, if I have to summarize, there are a whole bunch of things which utilize ionizing radiation. So I might just remember two things which do not have ionizing radiation. So remember, any sort of MRI sequence that they give you will not have ionizing radiation. Any sort of ultrasound mode that they might give you, which is B mode, M mode, Doppler, any of it will not have ionizing radiation. And something just for completion's sake, which doesn't have ionizing radiation, not used very routinely in practice now, is thermography. So thermography is also something which doesn't have ionizing radiation, but no longer used too much in practice. Alright, so these are the things which do not have ionizing radiation. Everything else, which is X-rays, CT scanner, any fluoroscopy that we are doing, or any nuclear medicine investigation is going to constitute ionizing radiation. So now when we talk about what constitutes ionizing radiation, remember we have electromagnetic spectrum and we have the particulate radiation. So out of the electromagnetic rays, we have X-rays, gamma rays and cosmic rays which contribute to ionization. X-rays and gamma rays are what are used for diagnosis, whereas cosmic rays are predominantly what constitutes the background radiation, right? So this is not something we use for diagnostic purposes. Particulate matter, we have alpha, beta, proton and neutrons which all have ionizing radiation, and these will come into play in treatment. They are not used for diagnostic purposes, but they are used in radiotherapy, right? So going ahead, which out of these are the most penetrating rays? So when we talk about rays, remember it's the gamma rays which is the most penetrating radiation. But if your option doesn't include the word rays, if it just asks you what is the most penetrating form of ionizing radiation, remember neutrons have a higher penetrating power than gamma rays, alright. So, neutrons do have a higher penetrating power. So, let's summarize this with the help of a table. So, when we look here, ionization power is the same, remember it's the same as linear energy transfer or damaging power. Any of these words are used in the question, they mean the same thing, or they could ask penetrating power. Alright, so you can have 4 questions being framed from this topic, this table. So, what are the particles which have the maximum damaging or ionization power? It's gonna be the alpha particles. Remember, it's gonna be the alpha particles which have the maximum damaging power, and because they are so heavy, do you think they're going to be able to penetrate too much? No. So, that is why it also explains why they have the minimum penetrating power, right? So, they have the minimum penetrating power. When we talk about maximum penetrating power, I want you to remember that the maximum penetrating power is with neutrons. So, here we have to remember neutrons followed by gamma rays depending on the question being asked. And what has the minimum ionization power? It's going to be the gamma rays, alright. So, out of this we have the gamma rays which have the minimum ionization power or damaging power. Okay. So, this is a table which is going to be very, very important for us to remember. Now, we talk about ionizing radiation and all the harm and all the damage that it causes. Now, what is the mechanism by which it acts at a cellular level? So, remember, first mechanism is it causes DNA damage. So, it causes DNA damage. Predominantly, the most common type is going to be the double-stranded DNA breaks that it causes, alright. So, double-stranded DNA breaks. Apart from this, it also causes free radical mediated damage. Because of all the ionization that is happening, free radicals are going to be generated, and free radical mediated damage is going to occur because of the ionizing radiation. So, these are 2 mechanisms by which ionizing radiation is going to act, and it's going to be harmful to us. So, now let's talk about the effects of radiation. So, effects of radiation may be divided into stochastic and deterministic effects. Alright, so how to remember them? So, remember, stochastic effects are effects which occur by chance. They are a chance incidents which are not planned. They do not have a threshold at which they are going to act. Alright, so these are side effects which are occurring by chance. So, if you remember the examples, other things become much easier to understand. So, remember, stochastic is cancer. Alright, so any mutation or any cancer that can occur as a result of radiation is a chance effect. There is no fixed dose at which I will say that this patient is going to develop cancer future in his life. Okay, so this is an event that occurs by chance. It's a stochastic effect. So, does it have a threshold? No, there is no threshold here. What is the function of dose? So, the function of dose, that what likelihood increases as he receives more and more dose of radiation, is going to be the probability of this developing. So, the probability of developing a cancer is going to increase with the amount of radiation, right? So, probability is a function of the dose, and is it going to be an immediate side effect or a delayed side effect? So, this is going to be a delayed side effect. On the other hand, deterministic effects. So, these are effects which can be determined, which we know are going to happen beyond a certain threshold. So, effects like erythema, effects like loss of hair, effects like sterility. So, all of these are deterministic effects which have a threshold, that beyond this radiation dose, you will have these side effects. And as the dose keeps increasing, what becomes a function of the dose? It is the severity. So, when you receive more radiation, you will have more severe erythema. If you do not receive so much radiation but have crossed the threshold, you will have less severe erythema. Alright, so that is how severity is a function of dose. Timing, this is going to be immediate, right? So, this is going to be an immediate side effect that you are going to have. So, these are the stochastic and deterministic side effects. Now, talking about unit of radiation exposure. So, we have these 4 units, and you are being asked which is the unit of radiation exposure. So, here remember, it's Roentgen, that is the unit of radiation exposure. So, this is again something which is a very volatile topic. So, this is something that must be revised one more time before your exam. So, I want you to put this on a piece of paper or a book wherein you have your volatile stuff consolidated and it goes into your final revision. So, all of these radiation units can be divided into the standard international unit and the conventional unit. So, We'll have various tricks which will help you remember this. So there are these 5 entities that we need to remember the units for. First is radioactivity. Now radioactivity is a different concept. It's something that deals with radioactivity, radiotherapy, nuclear medicine. So we'll keep this separate, and then we have all the others which are going to be dealing with our general diagnostic radiation. Okay, so radioactivity, when I talk about it, the SI unit. So remember, the SI unit is going to be the father of radioactivity that we've already been through. So the SI unit is going to be becquerel. So becquerel is the SI unit of radioactivity, and it's the same. 1 becquerel equals 1 disintegration per second. Okay. Conventional unit, I want you to remember C for Curie. So Curie is the conventional unit. How are they related? 1 Curie is equal to 3.7 into 10 raised to 10 times becquerel. So this is much higher. Okay, so you can remember females have much more power than males. So you can remember it is 10 raised to 10 times the power of becquerel. Okay, so now going ahead, so it's not meant for any offense to be taken, just a joke and a trick to remember, right? So now talking about the units of radiation related things and how it's going to affect. So the very first entity, which is the exposure, which describes that the moment radiation is released, how much is the ionization it does to matter. Okay, so exposure SI unit. So if you remember ionization per unit matter mass, we'll call it Coulomb per kg. Alright, so the SI unit is Coulomb per kg and the conventional unit. Now the trick begins. So remember here that for all conventional units, for X-ray related stuff, for all the upcoming entities are going to be starting with an R. So all of these are going to be starting with an R, which is conventional unit. So here, because it's the first thing that X-ray is doing to the mass. So the conventional unit here is going to be Roentgen. So Roentgen is the conventional unit of exposure. Now going to the next thing, which is absorbed dose or the air karma. It's also referred to as air karma. So as the name suggests, the moment it goes to the skin, how much is the absorption which is happening. So here remember the mnemonic ABG rad. So remember ABG rad, wherein AB for absorbed, gray is the SI unit, and rad here, R for rad, is going to be the conventional unit. So ABG rad, gray and rad. Finally, we have 2 entities. First is the equivalent dose. So now here we are basically equalizing all the radiation by a radiation weighing unit. So we have seen that alpha particles is going to be much more damaging or have much more ionization power than gamma rays. So if I have to basically equalize this, we will be using an equivalent dose term where we'll give it an additional radiation weighing factor. Okay, so that is the equivalent dose whose SI unit, S for SI, is going to be sievert. So this is going to be sievert, whereas the conventional unit, again starting with R, is going to be rem. Okay, same thing, easy, goes for effective dose. Now this effective dose is going to be tissue weighing factor. What is the effect that this radiation has on different tissues is going to be given by the tissue weighing factor. Okay, so here we have the same units, sievert and rem. So when I ask you which is the most useful terms of expression of radiation, it's going to be effective dose. So remember here, this is the most useful. Alright, and I've also given you the conversion factors for each of them, which are not frequently asked, but you can just remember these two. 1 gray equals 100 rad, 1 sievert equals 100 rem. So these are the units that we need to remember. Identify the incorrect pair of maximum radiation exposure limit according to AERB guidelines. So AERB is the Atomic Energy Regulatory Board of our country, which regulates all of these timelines, alright, it regulates all of these definitions of what are the various cutoffs. So here, general public 1 millisievert per year, this is true. Occupational worker 2 millisievert per year, this is definitely wrong. Length of occupational worker is 150, skin is of general public is 50. So let's try and figure out a way to remember all of these values. So this is a table summarizing all the values that have been put up by AERB. So we divide them into occupational workers, so whoever are involved in the radiation technology, whether it's the technicians or radiologists, will be counted as occupational exposure, whereas then you have the general public. So overall for occupational exposure, Remember, the value they have given is 20 millisievert per year when it's averaged over 5 years. So in short, in 5 years, you need to have an exposure of total 100 millisieverts. Okay, that is what is allowed. So when we average it, it becomes 20 millisievert per year. But in one calendar year, it is 30 millisieverts in any single year. So remember this, that you can have either of these two values which are being asked. In 1 year, 1 calendar year, 30. But when you sum it out for 5 years, the total thing allowed is 20 millisievert per year. Public, it's 1. Remember, single number 1 millisievert per year for general public overall exposure. Now we have lens exposure guidelines which are given separately. So for occupational worker, it's 150. Just remove a 0, it becomes 15 for public exposure. A higher cutoff is given for skin and extremities, wherein it is 500 millisieverts for occupational worker, and you remove a 0, it becomes 50 for public. Then when we talk about pregnancy, this is where you get your bunch of your questions from, wherein in pregnant occupational female, remember, it is 2 millisievert per year for a pregnant occupational worker. But when you talk about a general pregnant female, it's the same. It's the same as general public, alright? So nothing different. But in a pregnant female, it is 1/10 of your normal occupational worker, which is 2 millisieverts per year, and the fetus will get 1 millisievert per year here. So the standard rule is fetus gets half the radiation exposure. So if they ask you what is the radiation allowed for the fetus, you say 1 millisievert per year for occupational pregnant female or 0.5 for public or a standard general fetus. Okay, so these are the values that you need to remember. So now talking about X-ray tubes. So all of the following are true about modern X-ray tube except. So one, rotating cathode is used. No, this is wrong, right? We have the rotating anode. Remember, the cathode is just a filament, which is a thin filament of tungsten which is used, but the anode is actually a disc that is made, which is frequently rotating. Alright, so it's a tungsten disc that rotates. So we have a rotating anode, also called as the target. Okay. Second, target is made up of tungsten and rhenium. So yes, the tungsten here in the target is alloyed with rhenium. Filter is made up of 2.5 equivalent of copper plus aluminium. This is also true. Outer protective housing is made of lead. This is also a true statement. Alright, so this is the wrong statement here. So now let's quickly discuss the formation of X-ray tube. So here, as we have discussed, the outer tube is going to be made up of lead. So this is the outer protective housing which basically houses your X-ray tube, which doesn't allow the leakage of radiation. We don't want radiation leaking from the X-ray tube, right? So all of it is absorbed by the lead, which acts as a protective housing. Now coming to the glass tube per se. So this is the X-ray tube which is made up of glass, which is referred to as Pyrex glass. Okay, so that's a heat resistant glass that you have, which forms the X-ray tube, and you have oil which is circulating. You have oil which is circulating around the glass tube so that some amount of heat can be conducted away. Now we go to the cathode and anode. So here I want you to remember the mnemonic. CT is an art, alright. So interpreting CT is not easy. CT is an art. So cathode and anode, both are made up of tungsten. That is common. Both of them are made up of tungsten, but cathode is made up of tungsten which is alloyed with thorium. So CT, whereas anode is made up of tungsten which is alloyed with rhenium. So ART. So tungsten and rhenium in the anode. Alright, so again, why is tungsten chosen here? Because it has a very high melting point. It can be alloyed into this filament. Alright, and again, it has a very high heat capacity. So that is why it can be used for cathode and anode with some help from the alloys. Okay, so this cathode is the negatively charged filament that we have, wherein you have these electrons which are released. So when you heat the cathode, okay, you have a process called thermionic emission. Thermi means heat, ionic means the electrons are released, emission means they are released. So thermionic emission is the release of electrons from the cathode when you heat it up. Okay, so that is what we are going to be seeing. And when these electrons will strike the anode, being electrons negatively charged, they're going to strike the positively charged anode, and this interaction of the electrons with the anode is going to result in the formation of these X-rays. So this is how X-rays are going to be produced, and these X-rays will now be released from the window. Okay, so this window here is a thinned out glass tube. This is just the glass itself which is thinned here, and that allows the X-rays to escape, and finally before they reach the patient, they are filtered. So the filter here is made up of aluminium and copper. Okay, so this is the filter which will absorb the low energy rays which are not going to do you any benefit but are only going to cause radiation exposure. Okay, so that is the job of the filter. Here you have one more thing, which is the focusing cup. So you have a focusing cup here which is made up of nickel that doesn't allow electrons to go haywire. Okay, it will keep it directed into one streamline which can hit on the anode. So this is the X-ray tube. Just to sum up very quickly, what is the X-ray tube made up of? So it's made up of Pyrex glass. What is the negatively charged cathode made up of? So that's made up of tungsten plus thorium alloy. Anode, or the positively charged target, which is a rotating anode, remember most commonly, that is made up of tungsten plus a rhenium alloy, right? What about the window? So the window is made up of glass itself. We have a filter which is made up of aluminium plus copper, 2.5 millimeters equivalent. Grid, so there is also a grid which is used behind the patient. Alright, so remember, if this is the patient, this is the X-ray tube which is producing the X-ray. In between the image receptor or the film, we have something called as the grid. So this is where the grid comes in, and it will basically not allow any radiation which is going in an off-focused manner. So anything which is not perpendicular will be absorbed by this grid. Okay, so it basically improves the quality of the resultant X-ray. So it improves the quality, it improves the contrast of the image, but the radiation is also a bit higher. So it also causes more exposure, but in turn improves the quality of the X-ray film. This grid is made up of lead strips. So it is made up of lead strips plus aluminium strips. Okay, so there are these linear bands of aluminium and lead which are separated by each other. The protective housing is again made up of lead which absorbs any stray radiation. Okay, very quickly, mammographic X-ray tube versus normal X-ray tube. So there are a few changes between the two. So in radiography, we have seen that the target is made up of tungsten plus rhenium. Here in mammography, M for molybdenum. Remember, molybdenum is what makes the target. The window in the radiograph was made up of glass itself, thinned out glass. Whereas here, it's going to be made up of beryllium. So it's made up of beryllium here. When we talk about the filter, in radiography, we saw that it was an aluminium plus copper filter. Whereas here, it's again going to be a molybdenum filter. Okay, so you have M and B in mammography X-ray tube. Everything else is the same. These are the only changes that you have. So now continuing our discussion with contrast media. So this is something again very volatile that you must revise right before your exams. Alright, so here I am showing you images of 4 contrast media which are frequently used in various investigation modalities. So let's start here. So in the bottom right corner, what we have here is OmniPac. Now I want you to remember this trade name in particular because OmniPac is one of the most frequently used contrast agents that we use for CT. Alright, so this is actually a iodinated contrast agent that is useful, one, for CECT whenever we are doing a contrast enhanced CT. This is the contrast media that we shall inject intravenously. Secondly, you also want to remember anywhere in an oral study when you have barium which is contraindicated. Alright, so anytime barium is contraindicated, such as when you have a tracheoesophageal fistula, or there is a post-operative patient where we want to see post-op stricture or post-op fistula, again we can give OmniPac. Okay. Apart from this, this can also be used in various investigations such as hysterosalpingography, ERCP, myelography. So in all of these we can use iodinated contrast agents. Alright. So remember, OmniPac is what it comes as a trade name. So just remember here one more MRI trade name that we have for an MRI contrast agent is OmniScan. Okay, so do not confuse OmniPac with OmniScan. Apart from that, one commonly used contrast media for MRI is what is called as multi-hands, and H here I want you to remember, it's a hepatocyte specific contrast agent. So this is something which is particularly useful when we are imaging for hepatocellular carcinomas. Okay, so these are all gadolinium based. Alright, so if you see this gadobinate demiglobin, these are all gadolinium chelates. So we chelate the gadolinium ion with various compounds such that it no longer remains toxic. Okay, so these are all gadolinium contrast media which are used for MRI. Okay. Right, what do we have here? We have sonoview. So this is again something which is a very important potential question, which is an ultrasound contrast agent. So sonoview here is an ultrasound contrast agent. The biggest advantage, this is the only IV contrast media that can be safe, alright, which will be safe in patients who have renal failure. So in patients with deranged renal functions, you will have gadolinium which is contraindicated, you will have iodinated contrast which is contraindicated, but sonoview is going to be safe, okay, because it consists of these micro bubbles. It is made up of these very tiny micro bubbles which are excreted through the lungs. So that is why it can be easily given in patients with renal failure. And finally, microbar. This is actually barium sulfate. The barium sulfate that is used for GI studies. So this is used for various GI studies. It is a compound which is not absorbed into the circulation, remember. So we'll administer it either orally or through the perrectal route, and it is never absorbed, alright. So we will see it in the lumen, we will see various pathologies like strictures, like carcinomas where you have irregularity, alright. So all of those of the bubble loops from the mouth to the rectum, we can evaluate using barium sulfate. So now let's quickly talk about barium studies in some detail because you get a lot of questions. So when we talk about barium sulfate and barium studies, there are a few contraindications. So barium is very safe as long as it remains intraluminal. The moment it leaks out into any cavity, whether it's peritoneal cavity, mediastinum, lungs, it will cause a lot of harm. So it causes chemical peritonitis. Alright, it causes chemical peritonitis, chemical mediastinitis, it causes pulmonary edema. So anywhere where you have a risk of leakage of barium, it becomes a contraindication. For example, when you have an X-ray wherein you are seeing this air under the diaphragm, this is an X-ray that nobody has to miss in the exam. Air under the diaphragm, right side, this is the first thing that your eye straight away goes to anytime you see any chest X-ray. And remember this rule for life, okay, not just for exams, that this is the first thing you want to rule out, because if this is there, patient goes straight to the OT. And more importantly, it means that there is free air in the peritoneum, there is pneumoperitoneum, and it indicates perforation. And in such cases, barium is a complete contraindication. Similarly, when you see dilated bowel loops, you have a picture of obstruction, intestinal obstruction. Barium is again completely contraindicated. Similarly, in cases where you have tracheoesophageal fistula, do not give barium. In cases of post-operative patients, do not give barium because it can leak out through the post-op anastomosis sites. Alright, so these are the contraindications of barium. Now talking about the various names of barium procedures. So what do we see here? So this is a zoomed image of barium. So here you can see these complete mucosal folds. We see this coiled spring kind of appearance, this concertina kind of appearance. So this is both suggestive of barium meal follow through, which is basically done for small intestinal loops. And these complete mucosal folds, this valvulae conniventis, alright. So when we see these complete mucosal folds, they are referred to as valvulae conniventis, which are a feature of the jejunum. Alright, so in jejunum, we are going to be seeing these complete folds, and when we are evaluating the small intestine, we call it barium meal follow through. So we have 4 barium investigations. This is barium swallow, this is barium meal, this is barium meal follow through, and this is barium enema. So for the first 3 investigations, we ask the patient to swallow the barium. Alright, so whenever we are looking at the esophagus, that is barium swallow. When we look at the stomach, that is called the barium meal. when we look at the small intestine, so again, how to identify the parts? There's the duodenum based on the shape, crossing over to the left side at the DJ flexure, something which is very, very important, will be absent in cases of malrotation. And all of these feathery loops that you are seeing, alright, all of these feathery loops, which are because of the valvulae conniventis we just saw, will be the jejunal loops, whereas these loops which do not have any marked feature, alright, or are typically described as featureless, are the ileal loops, right. So this, when we study the small intestine, this barium will follow through. And finally, when I inject the barium per rectally, that study is called barium enema. Now, one concept about barium, it can either be a single contrast barium or a double contrast barium. In single contrast barium, we just give barium alone. So, as you can see here and here, we are only giving barium to the patient. But when I give barium as well as air, so that I get a good intrinsic contrast wherein barium will be white and air will be black, right. So, here if you see that this is the barium and this is the air, basically because of the mucosal coating of the barium and then air distending it, you have this very good mucosal detail. So, that is where we use double contrast, and the advantage is it provides better mucosal detail, alright. So, this is again an example showing you double contrast where you have air also, you have barium also within the lumen. Okay, so these are the two kinds of barium studies that we can do. Going ahead to iodinated contrast media. So, now talking about iodinated contrast media, here the classification is again something that gets you a few direct questions. So, you can have ionic contrast media or non-ionic contrast media, which are further classified into monomers and dimers, Alright, so now when we talk about osmolarity and iodine particle ratio for each, I want you to remember a very, very simple concept here. Okay, so basically, this is the functional unit of any iodinated contrast media, which is a benzene ring with 3 iodines. Alright, so this is how a monomer is going to appear. Right. So, if I ask you that one monomer has 3 iodines, so if there were a dimer of this, how many iodines would be there? Quite simple, there will be 6 iodines. So, whether a compound is a monomer or dimer will determine the number of iodines. When we decide the number of particles, that will be dependent on whether it's ionic or it's non-ionic. Anytime the iodinated contrast media is ionic, it will have one ion and it will have a sodium particle attached. So, in total, there are 2 particles in an ionic media, whereas in a non-ionic media, there's just the single functional unit. Okay, so number of particles is going to be decided by ionic and non-ionic media. Do you agree? So, now when I calculate the iodine particle ratio of different things, it's going to be pretty easy, nothing that I have to memorize. So, when they ask me ionic monomer, iodine particle ratio, because it is a monomer, how many iodines will it have? It will have 3 iodines. Because it is ionic, how many particles does it have? 1 benzene, 1 sodium. So, 2 particles. So, the iodine particle ratio becomes 3:2. When I talk about ionic dimer, a dimer, how many iodines? 6. How many particles in an ionic agent? 2. So, it is 6:2 or 3:1. When I go on to non-ionic monomer, being a monomer, 3 iodines, non-ionic, so only 1 particle. So, the ratio becomes 3:1. When I go to non-ionic dimer, because it's a dimer, number of iodines, 6. Because it is non-ionic, just the 1 particle. So, now when we analyze the iodine particle ratio, we realize that this non-ionic dimer has the maximum number of iodines and the minimum number of particles. So, this is something which is going to have the least osmolarity. Somewhere this osmolarity is iso-osmolar to the plasma, and hence these contrast media are called iso-osmolar. They are the safest in renal failure. When we talk about these two which have the same iodine particle ratio, they also happen to have the same osmolarity of 600, and they are referred to as low osmolar contrast media because relative to the ionic monomers which have an osmolarity of 1200, which are called high osmolar contrast media, these are much lower, and hence the misnomer that it's LOCM, it's low osmolar, whereas we have a contrast media which is even lower than it. Okay, so these are the various osmolarities that we want to remember. Talking about examples, remember anything which is ionic is going to end with 8. The name is going to end with 8 because it's a salt, whereas non-ionic and alcohol will end with ol. Okay, so that is how we can identify. Ionic monomer, the compound I want you to remember is called diatrazoate. Okay, the compound ionic dimer I want you to remember, ioxaglate. One trick, anything apart from ioxaglate which ends with 8 is there in your option, it goes here. It's an ionic monomer. Alright, so remember this trick. Non-ionic monomer, most common, iohexol, which comes under the trade name of Omnipac that we had seen. Non-ionic dimer comes as iodixanol or the trade name of Visipac. One more trick, any compound that ends with OL given in your option which is not iodixanol will be non-ionic monomer. Okay, so you can remember that trick. So these are all the iodinated contrast media that we want to remember. Now let's talk about contrast induced nephropathy. Now the iodinated contrast media have this adverse effect of producing nephropathy. Alright, they have this adverse effect on the kidneys. So now how is it defined? So contrast induced nephropathy is defined as an increase in the creatinine by more than 0.5 mg per dl, absolute increase, or if we know the baseline value, there is a relative increase by 25%. Okay, so 25% or 0.5 increase within 48 hours and you have ruled out any other cause of this acute nephropathy, acute kidney injury. So any other cause has to be ruled out and these are the values. It has to happen within 48 hours of contrast administration and this is called CIN. So now how to prevent CIN? So if you have a patient who already has diabetes or hypertension or is on nephrotoxic drugs who has an increased risk of CIN, how will you prevent it? So the only evidence-based medicine method proven to reduce the risk of CIN is actually hydration. Alright, so hydration or pre-hydration before the patient gets the contrast, pre-hydrating the patient is something which is the best method proven to reduce the risk of contrast-induced nephropathy. And when we have to choose the contrast media, as we saw, we are going to prefer non-ionic over ionic because they have a lower osmolarity, right? So we are going to prefer non-ionic media over ionic media. Going ahead, so out of all the IV contrast media, remember iodinated gadolinium, not safe in renal failure. This one causes contrast-induced nephropathy if given in patients with renal failure or deranged renal parameters. Gadolinium when given in renal failure is even more harmful. It causes a phenomenon called NSF, which stands for nephrogenic systemic fibrosis. Alright, so it causes nephrogenic systemic fibrosis. But Sonoview, which is the ultrasound contrast media, consists of microbubbles. So this is actually made up of sulfur hexafluoride gas in a phospholipid shell. So these are these tiny air bubbles. Because they are excreted through the lungs, remember it is safe in renal failure. It's the only IV contrast agent that's safe in renal failure. Remember this. Now let's talk about two parameters which determine the X-ray features. Alright, so one we have KVP and one we have MAS. So here I just want you to remember the relationship. So KVP basically kilo voltage peak determines the voltage difference between the cathode and anode. Alright, and this is something which is directly proportional to penetration. So if you have an obese patient, alright, so and they ask you what is the parameter that you will have to change, you will say that I will need to increase the KVP because we need to increase the penetration of X-ray beams because now there is a larger surface area at play. Alright, so that is something that we want to do. And the other relationship will be that it's inversely proportional to contrast. So whenever you increase KVP, the contrast will reduce in turn. So now if we keep the same example going of this obese patient, he's come to you for an X-ray, we have increased the KVP because penetration increasing is a must. Now in that process, we have made the contrast of the X-ray very low and that is something which is not acceptable. So how do we work around it? So we have another tool which is MAS, which is milliamperage second. So if you remember, ampere is the unit of current. So this actually determines how many number of electrons are actually coursing from cathode to anode, you know, and this determines, this is directly proportional to the contrast. So can I say in this obese person, where I want to increase the contrast, the other parameter I can also increase is increase the MAS. So you increase the KVP also, you increase the MAS also, and you can in turn make up for the contrast, right? But overall it determines the blackening. If I go on increasing the MAS, it becomes more and more darker overall. Okay, so when asked what is the best determinant of contrast, it will be KVP. Remember, KVP is the chief determinant of contrast. MAS is just a secondary parameter that we can use in such cases to compensate. Alright, so now talking about lead apron, again a question that figures in very commonly. So this is how it looks. This is a lead apron. The minimum thickness by AERB that this lead apron must be is 0.25 millimeters, and most commonly, remember, we use a thickness of 0.5 millimeters. Similar to the lead apron, we have lead gloves, we have lead goggles also, which are used to shield basically the workers from radiation. Apart from that, one more tool to monitor the amount of radiation exposure to radiation personnel is this instrument called TLD badge. It's a personal dosimeter that every radiologist, radiographer will get. This is called TLD, which stands for thermoluminescent dosimeter. So that stands for thermoluminescent dosimeter based on its principle of thermoluminescence, where it undergoes this luminescence when we heat it up. Alright, so this is the badge that everybody gets, and you're supposed to wear it on your collar above the lead apron or below it. So obviously, logically, we have to wear it below the lead apron so that we know that after the lead apron protection, how much exposure am I getting, and that gets calculated, right? So it's worn below the lead apron, remember, at the collar level. And what is the compound that it is made up of? Remember, it is made up of calcium sulfate, which is loaded with dysprosium. This is what it is made up of in India. Apart from this, lithium fluoride can also be used. That's one more option that we have, but this is what we use in India. And remember, this dosimeter every 3 monthly we have to send it, alright. So every 3 monthly the calculation happens that this is the radiation that you've been exposed to. Alright, so this is the usage of personal dosimeter or a thermoluminescent badge. Now let's quickly go through the thumb rules for various investigations. So we've been talking about X-rays. Remember, X-ray, something very routinely available, will be the initial investigation for any emergency, right? For all orthopedic pathologies, X-ray remains the initial investigation of choice, whether it's fractures, evaluating foreign bodies, evaluating bone tumors. And to know the position of medical device, again X-ray is the investigation of choice. So now again, if you are seeing here, the one thing that I have told you never to miss, this is free air under the diaphragm, pneumoperitoneum, any emergency, X-ray will be your initial investigation of choice. Going ahead to CT. So on CT, we have various Hounsfield units that we need to know. So now talking about Hounsfield units on CT. Alright, so this is a measure of the density. In turn, how black or how white a structure is going to look on the CT is going to be determined by the density of that compound, by the density of that substance, and that can be given a numerical value in Hounsfield units as described here. Okay, so these are the 4 values that we have. Air, yes, it is the blackest. So anywhere you see a negative HU, that means that it's going to be hypodense. It's going to be black in general terms, right? So air is the blackest thing that you will see. It's the most hypodense thing. It is definitely minus 800 to minus 1000. Fat is not 0 to 20. So fat is again the other thing with a negative HU. There are only 2 things which have a negative HU. One is air, the other is fat. So fat is going to have an HU of somewhere around minus 20 to minus 100. Okay. Whereas air is going to be minus 800 to minus 1000. Okay. So these are the HUs that you can remember. So this is wrong. Acute hemorrhage is going to be hyperdense. It's going to be white. So it will have an HU of 80 to 90. This bone is going to be very, very white, hyperdense, which have this high Hounsfield unit. So just to represent it on a scale, Remember, the reference is going to be distilled water. So this is distilled water, which is this kind of color, which is this kind of density. So can I say, if this is the reference, anything which is whiter than this, anything which is brighter than this will get a positive Hounsfield unit. Anything which is darker than this, you will get a negative Hounsfield unit. So here I am showing you two cross sections of the CT. Let's try and evaluate. So two things which are black, which are hypodense. One is the air. So this air here will have a Hounsfield unit of -1000. There's -10 to -100. This is the fat that you are seeing, subcutaneous fat, mesenteric fat, again quite hypodense. So remember this very, very important concept, and on the basis of this, if they show you a renal tumor with this hypodense thing or a negative Hounsfield unit, will you be able to guess the mass? Yes, a renal mass with fat, angiomyolipoma. Similarly, if you see a mediastinal mass with fat, calcification, think of a teratoma. Okay, so that is how we can approach. When we go to 20 to 30, remember now we are into the positive side of things. We are into positive, brighter things. Okay, so 20 to 30, it's going to be the muscles and the soft tissue. So muscle, soft tissue have a Hounsfield unit of 20 to 30. 60 to 90 will be acute hemorrhage. So remember, acute hemorrhage is much more hyperdense than soft tissue, and that is why anytime we want to look at acute hemorrhage, we will do a non-contrast CT as investigation of choice. Remember this thumb rule. 200 to 300 will be the contrast that we inject. So whenever you see vessels appearing white, that is the contrast that we have administered into the IV circulation, which has this high density. And the thing which is the whitest or the brightest will be the bones or calcification, which will have a Hounsfield unit of 1000. So if you look at the bones here, anytime this is a starting point, you see the bones are white, it's a CT. Okay, so bones calcification will be hyperdense. And if you have a metallic foreign body that even exceeds this range, alright, so it will be whiter than bone, it will be so white. Okay, so remember, metallic foreign body also hyperdense. So now based on this, can I say non-contrast CT can be used for anything which is white, anything which is a positive HU or basically appears bright on a CT? Yes. So one, anywhere I want to look at acute hemorrhage, anywhere I want to look at calcification, anywhere I want to look at bone, particularly the cortex of the bone is going to be very, very hyperdense, right? Not the medulla. So anytime I want to look at cortex, it will be this. So based on this, let's see. For head and spine trauma, I want to see fractures, I want to see acute hemorrhage, NCCT, investigation of choice. Acute subarachnoid hemorrhage, again acute hemorrhage, NCCT. Calcification, whether it's intracranial or it's in the form of renal calculi, we again want to rely on NCCT. Then I want to look at a foreign body, a metallic intraocular foreign body. Remember, investigation of choice, NCCT. So just a disclaimer, intraocular foreign body, very important question. So initial investigation for any foreign body, remember, was X-ray. Investigation of choice, CT. What is contraindicated is what I want to know. So remember, MRI is contraindicated in suspected cases of intraocular foreign body because MRI is a magnet. When you have a metallic foreign body in your eye, that is going to be attracted to the huge magnetic field and it can cause irreversible damage to the patient, and that is something that you must be very, very careful of. So remember, never ever do MRI before ruling out any sort of foreign body. Okay, that is a life lesson for everybody. Okay, going ahead, I want to see cortex, I want to see fractures, except for stress fractures, which will be best diagnosed on MR. Everywhere else, NCCT. Anytime I want to look at stroke, initial investigation in stroke, the first thing when we want to rule out a hemorrhagic stroke, answer will be NCCT again. So this is the order, very, very important thumb rule for NCCT. What is this CT? So this is a CT which is showing you a high resolution CT of the lung. Here I want you to remember two thumb rules. HRCT lung is the investigation of choice for interstitial lung disease, and it's also the investigation of choice for bronchiectasis. And this is a question that has been repeated over and over again. So now let's just quickly learn the difference between how to recognize a CT scan and an MRI. Alright, both of them you will be given axial sections. Predominantly the head scans, you need to know how to differentiate them very well. Okay, so first starting point, very simple. Always look at the bone. So if you find that the bone is hyperdense, right, you know that it's a CT scan. And if you find that the bone, particularly the cortex, alright, look at the cortex. If the cortex is black, then it is MRI. Okay, so that is how we basically use our approach to distinguish whether it's a CT scan or MR based on the density of bone. If bone is white, CT, bones are black, it's MR, as simple as that. So now in MRI, we further have various sequences. So here we have two main sequences, which is the T1 weighted sequence, T2 weighted sequence. How to identify? Again, very simple rule, which is World War II. So on a T2 weighted sequence, you will have water as white. You will have the CSF appearing hyper intense as you are seeing here. Okay. Then when we look at the gray matter, white matter on a T2 weighted, can you notice here how the gray matter is hyper intense? It is whiter, while white matter is hypo intense relatively. But on T1, the fluid, the CSF is going to be dark. But the gray matter, white matter will follow its name. So you will have that the gray matter is indeed gray or hypo, whereas white matter is indeed bright or hyper intense. So it follows its name. So one trick to remember here is, anytime you want to look at any pathology, it will elicit edema. So what is my sequence of choice when I want to see pathologies? It's going to be T2, right? So remember, T2 is the sequence of choice when I want to look at any edema, any pathology, right? But there are certain things which are T1 bright. Most pathologies T2 bright, but a few specific things are bright on T1. So what are those substances and then the related pathologies? First thing, melanin. Remember melanin, and hence all melanomas will be T1 bright. Anything which is very rich in protein. So anything which is rich in protein like keratin. So when you have keratin containing lesions like craniopharyngioma, or there are keratocystic odontogenic tumors in the jaws which are called KOTs, will also be T1 hyperintense. Cholesteatoma again will be T1 hyperintense. Epidermoid cyst again will be T1 hyperintense. This is a very useful list that we are building here. All of these tumors will be T1 hyperintense, and that's a very useful diagnostic feature. Apart from that, remember posterior pituitary also has neurosecretory granules that make it posterior pituitary hotspot on T1. So it appears as a white spot on T1, whereas the anterior pituitary will be dark. So this is referred to as posterior pituitary hotspot. Apart from this, also remember gadolinium will be T1 bright. So anytime you give gadolinium, you do a T1 weighted sequence. Alright, so this is the gist of T1 versus T2. Coming to the thumb rules for MRI. So remember, MRI has a much better soft tissue resolution. Do you see the soft tissue contrast resolution? It's much better than CT. So anything that I want to evaluate in the brain, any brain pathology or any spine or any nerve pathology, anything to do with the central and peripheral nervous system, my answer will be MR. Alright, so brain tumor, spine tumor, nerve tumors, MR. Pancreas tumors involve the brachial plexus, right? So if I want to see the nerves again, brachial plexus, MRI. If I want to see posterior mediastinal mass, remember all the other mediastinal masses, CT is the investigation of choice. But posterior mediastinal mass, the most common posterior mediastinal mass is actually a neurogenic tumor. And that is why, because again, a nerve, answer will be MRI. Chronic SH. So again, now changing gears into hemorrhage. So we just discussed that acute hemorrhage is going to be hyperdense on CT. So anytime I want to see chronic SH, remember MRI is the answer. Diffuse axonal injury. Again, one exception to head trauma. If you remember head trauma, investigation of choice, NCCT. But one exception is diffuse axonal injury where CT can be normal and you need MRI, particularly a gradient sequence called susceptibility weighted imaging. And For stroke, again, initial investigation of stroke is going to be NCCT. But when you want to know the investigation of choice for ischemic stroke, so for hemorrhage, we could see NCCT. But for ischemic stroke, answer is going to be diffusion weighted imaging in MRI. So MRI or diffusion weighted imaging in MR is the most sensitive investigation. Apart from this, when we talk about orthopedics, we saw cortex CT, but bone marrow pathology or bone marrow edema in osteomyelitis, MRI. Any ligament, any cartilage, any spinal cord or IV disc pathology I want to see, I will do MRI. Soft tissue sarcomas, again MR. Choledocholithiasis. So remember, for CBD calculi, again we want to rely on MRI as investigation of choice, but here remember the gold standard is going to be ERCP, right? Because it can diagnose as well as treat. And remember one more thing, CA rectum, investigation of choice for staging is going to be MR. So these are the thumb rules for MR that we want to remember. So now talking about ultrasound. So remember, on ultrasound, basically we again do not use ionizing radiation. We use sound waves. So we use something called as piezoelectric crystals here, alright? We use piezoelectric crystals which are made up of lead, zirconate, titanate, alright? So PZT, lead, zirconate, titanate are the crystals that basically we use in these probes. So what these crystals will do is, the electrical energy that the probes are getting, will convert it. These crystals will vibrate and they'll convert into sound waves, alright? So they'll convert it into sound waves, and these sound waves are emitted from the probe into the body, and that is what we'll see as images. Okay, so all of these probes are used depending on the frequency of the vibration, and that is how we use various applications. So here you have a low frequency probe which is a 2 to 5 megahertz. One more fact to remember, what is the frequency of medical ultrasound? So it ranges from 2 to 20 megahertz that we use. So here the low frequency probe 2 to 5 megahertz. So remember here, frequency of the probe is directly proportional to the resolution, and it is inversely proportional to the depth. So when I have a low frequency probe, it's going to offer me a deeper view, but it will have relatively lower resolution. Okay, so when I want to see deeper structures like the abdomen or like the pelvis, alright, so we will use a curvilinear probe. On the other hand, this is a high frequency probe, 16 to 15 megahertz, right? So this is 16 to 15 megahertz, wherein you get a higher resolution, but the superficial structures can be evaluated. So anytime I want to evaluate the thyroid, the scrotum, or the breast, alright, so all superficial structures are evaluated with the linear probe. This is the linear probe. We have 3 more probes which you need to know. So this, as you can see, is shaped like this. So this is an endocavitary probe which can go into cavities, such as transvaginal sonography. So this can do TVS and this can do transrectal sonography. Alright, so these 2 sonographies can be done with this special endocavitary probe. This is a phased array probe which is used for echo. So this is also called as echo probe at times, but it's called a phased array probe. Again, it is a low frequency probe which can again have a very large depth. So this is used to evaluate the heart, and it has a small footprint. Do you see how it has a smaller footprint? So it will fit in the intercostal space. If these are the 2 ribs, so this small footprint of the probe will fit into the intercostal space. And finally, when we see this, this is shaped like a hockey stick. So this is a recent advance where we use this hockey stick probe for various musculoskeletal applications like nerve imaging and all. Okay, so this is the hockey stick probe. Again, it's a high frequency probe. Okay, so these are the various probes. Now 2 artifacts I want to show you on ultrasound which are very, very useful. So when you see this kind of an appearance, where this is the gallbladder, and within the gallbladder you have this very white hyperechoic structure which produces what? Behind it. Do you see there's this shadow behind it? So this is referred to as posterior acoustic shadowing, which would be produced by any dense structure. So any dense structure like air or calculi, remember, or bone, It's basically gonna produce shadowing, where bone and calculi will produce this pitch dark shadow, while air will produce these dirty kind of shadowing that is referred to as dirty shadowing. So all three of these produce this posterior acoustic shadowing. Okay, this is something which is very, very useful for visualization of GB calculi, and that is why investigation of choice for GB calculi is going to be ultrasound. On the other hand, look at this, the completely black structure, which is called an anechoic structure, right? It is not having any echo, so black, anechoic. But look behind it, it's producing this brightness, which is called posterior acoustic enhancement. Just like you saw shadowing, the exact opposite is posterior acoustic enhancement, which is seen in cystic lesions. Anything which is filled with fluid will show you this appearance. So coming to thumb rules for ultrasound. So remember, gallstones, ultrasound is the investigation of choice. In case they ask you most accurate, alright, so highest sensitivity plus specificity theoretically is in the HIDA scan, but investigation of choice, ultrasound. Acute cholecystitis, again ultrasound. Any kind of fluid we want to see, any cyst or any fluid, again ultrasound. So hydatid cyst of the liver, ultrasound, investigation of choice. Minimal pleural pericardial effusion, ultrasound. We want to see hemoperitoneum. So in blunt trauma abdomen, we do the FAST scan, right? Now we do the EFA scan. So remember, ultrasound. Pregnancy, again we want no ionizing radiation, so ultrasound and MRI at our disposal, out of which, because ultrasound is more readily available, so when faced with an emergency situation in pregnancy, that would be your go-to investigation. And also remember, in children, in CHPS, which is congenital hypertrophic pyloric stenosis, or IHPS, again ultrasound is the investigation of choice. Quickly looking at all the machines. So whenever you see this tunnel, this very long tunnel, this is how an MRI machine is going to look. When you see this gantry, a smaller sort of a tunnel, wherein this table is going to go inside this gantry, which consists of an X-ray tube, and you have a series of detectors here. This is how a CT scanner looks. Okay, so this is your X-ray machine, wherein you have a standing detector, and you have this lying down detector for supine use as well. Okay, so this is an X-ray machine, and when you see this C-shaped unit, wherein the X-ray tube and the detector can move in any direction, 360 degree. This is called a C-arm fluoroscopy unit. So this is a video of the X-ray. So this is a C-arm fluoroscopy unit that can be used for fluoroscopy interventions or digital subtraction angiography. Okay. Similarly, this is a machine you must have seen in your life. This is an ultrasound machine. This is a mammography machine. This is something which is very, very important image, wherein you see these compression paddles. So this is the X-ray tube, and these are the paddles you will use for compression. Okay, so this is the mammography unit, and here what you can see is the DEXA machine. Alright, so when you see this kind of an appearance, this is a DEXA scanner, which is the investigation of choice for osteoporosis. So dual energy X-ray absorptiometry for osteoporosis. Finally, talking about a few important radiation values that you need to remember. So now this is the most important one. What is the radiation of chest X-ray? Is one value that you must memorize, the 0.02 millisieverts. Especially in today's time when there's so much controversy going on in how much radiation a CT has as compared to X-ray, right? So here you have the numbers right in front of you. So chest X-ray 0.02 millisievert. When we talk about CT, it will depend on the volume of the part. So CT head 2 millisieverts. So that is equal to 100 chest X-rays. Can you see this? Whereas a CT chest is double of that. So a CT chest is almost equivalent to 200 to 250 times chest X-rays, right? So that is the relation that you need to remember here. So CT chest 5, whereas CT abdomen will be 10 millisieverts. Abdominal X-ray has a lot of radiation as compared to chest X-ray. So does a skull X-ray. Okay, so these are two values which you need not remember. The ones which are highlighted are important. And remember, mammography is 0.5 to 0.7. This is also something which is important. Okay, so a mammography has 0.5 to 0.7 millisievert radiation. A PET has, because a PET CT usually will have a full body CT which is done along with the PET. So we usually do a hybrid PET CT. So if both PET and CT are done, it will have the maximum radiation, wherein it will have PET ka 10 to 12 millisievert plus the whole body CT ka around 10 millisieverts. So it around 20 to 25 millisieverts in total. Okay, so remember this will have the highest radiation exposure. A barium meal follow through will have 7 to 8 millisieverts. So this is also too much. So when we compare it, it's almost equivalent to CT abdomen. That is why in today's time, these barium investigations are very rarely performed, okay, because of this very high radiation. IVP is 2 to 3. It's okay if you don't remember this. So the highlighted ones are very important. So this was a quick recap on general radiology. So now we continue with the portion of musculoskeletal radiology. Here, the first thing we are going to discuss are bone tumors. Alright, so anytime you look at a bone tumor in a question or otherwise, you first have to build a pattern-based approach. Alright, so the age is going to be very important, the bone which is involved is going to be very important, and finally, where in the bone is it located? Okay, so let's begin with this part of the discussion, wherein let's see if it is within a long bone and what part of the long bone is the tumor lie. Does it lie in the epiphysis? Does it lie in the metaphysis, or does it lie in the shaft of the bone? And this will help us narrow down a lot of these differentials. So when we talk about epiphyseal tumors, remember the mnemonic ECG. Alright, so epiphyseal tumors, you need to remember two tumors here. Okay, so the first tumor is going to be chondroblastoma, and the second one is going to be a giant cell tumor. Okay, so now a chondroblastoma, remember, will be seen in a child, C for a child, wherein the growth plate is not yet fused. So that is one more way to look at the age while looking at the radiograph, that the growth plate is not going to be fused. So the growth plate is not going to be fused. Whereas in a GCT, it is usually seen in a middle-aged adult. Alright, so it will be seen somewhere between 20 to 40 years of age, wherein the growth plate is going to be fused. Okay, so this is how we distinguish chondroblastoma from GCT. So now let's look at the images. So here, when we remember epiphyseal tumors, two things, chondroblastoma and giant cell tumor. So right here, if you see this is a child, you can see that the growth plate here is not fused. You can see that the epiphysis is yet to fuse with the metaphysis. Okay, so this is an example of how a chondroblastoma would appear. Do you see this epiphyseal lytic lesion, which is very well defined? A lot of times you can also find calcification here, which pathologically is described as chicken wire calcification. Okay, so this is chondroblastoma. On the other hand, this is a very favored site of a GCT, which is the distal end of radius. Okay, so this is again something which will be a big clue if you see this in the exam, wherein you see this. First of all, skeletally mature adult, growth plates are fused, and you see this typical soap bubble appearance, right? So you see the soap bubble appearance in the tumor, which is extending from the epiphysis growing towards the metaphysis. Right, so this very typical trabeculations that you see, soap bubble appearance, is indicative of a giant cell tumor. Going ahead to diaphyseal tumors. So when we talk about diaphyseal tumors, remember the three vowels. So all the three vowels are sticking together in the diaphyseal region, and you would have these three differentials. So A for adamantinoma. Alright, so A for adamantinoma, E for Ewing's sarcoma, and O for osteoid osteoma. So these are three lesions which are all diaphyseal in nature. Okay, so let's have a look at the first diaphyseal tumor. So here, when they give you that the person can belong to any age, so it can be an adolescent or a middle-aged adult who has nocturnal pain which is relieved on NSAIDs. So this is a typical history that you will get here in the case of osteoid osteoma. So when you hear this clinical history, you look at the X-ray and what do you find? You find that there is a diaphyseal lesion, there is a shaft of a long bone here, and you can find that there is this sclerotic region, right? So there is a cortical based lesion here that you are seeing, which is predominantly eccentric towards the cortex and has this central lucency. So this central lucency that you see here is referred to as the nidus. Alright, so this is the central nidus with a predominant solid periosteal thickening, and it is cortical based. So all of these features go in the favor of an osteoid osteoma. And why does he have this typical scenario? It's because this nidus, this central lucent nidus that you are seeing, it actually releases prostaglandins, and because of the direct blockade of NSAIDs of these prostaglandins, the pain gets relieved. And remember, the treatment of choice for osteoid osteoma, it's going to be CT guided radiofrequency ablation. So under CT guidance, we'll basically put a probe into the nidus and we will ablate it using radiofrequency waves, and this treatment is called CT guided radiofrequency ablation. So looking at the next diaphyseal tumor, here you will get a history of a young child 0 to 20 years of age, more commonly in the first decade relatively. So the history will have that the child has fever, the child has a swelling which has erythema, a large soft tissue component, which will make you think is it infective or inflammatory. But when you look at the X-ray, you would find that there is this large permeative lesion. So it's such a destructive lesion, it infiltrates into the bone. So this is called a permeative diaphyseal lesion with an incomplete periosteal reaction. Do you see these lifted up bone which have these lamellae? So this is referred to as the onion peel periosteal reaction, and look at the large soft tissue that you are seeing. All of these features go in the favor of an Ewing sarcoma. So remember, the second diaphyseal lesion after osteoid osteoma, Ewing sarcoma, very aggressive lesion, aggressive periosteal reaction in the form of onion peel. Or one general principle that you have to remember, onion peel reaction, sunburst reaction, Codman triangle, all of these are examples of aggressive periosteal reaction. It doesn't mean that it's Ewing sarcoma equals onion peel and osteosarcoma equals sunburst or Codman's. It can be interchangeable. All of these periosteal reactions tell us one thing, that the tumor is growing at a very quick rate. It's an aggressive tumor. Alright, so this is Ewing sarcoma. Now the third one, a rarer tumor that you will have, wherein tibia is the chief bone which is affected, right? So tibia is very typically involved in this tumor, which is adamantinoma. Alright, so when you have a tibial diaphyseal tumor with associated bowing of the bone, you find that the bone is bent and it does have malignant potential. Alright, so this is how adamantinoma appears. It has these lytic sclerotic areas associated with bowing of the bone. Adamantinoma, a rarer lesion. And also remember the histopathological counterpart. Same histopathological features that we will see in adamantinoma will also be noted in ameloblastoma of the jaw. Okay, so remember, ameloblastoma in the jaw will have the same histopathological features as in adamantinoma. Talking about metaphyseal tumors next. So here again a very typical example of where a proximal humeral end would be given to you, and you see this very well defined geographical lytic lesion. Okay, and what is this fragment? You see that there is a pathological fracture here and the fragment is fallen into the lesion. Alright, so this is referred to as the fallen fragment or the fallen leaf sign, and in the first decade, no septations. This is a simple bone cyst. So metaphyseal lesion, centrally located, associated pathological fracture, no septations, simple bone cyst. On the other hand, second decade or older patient with multiple septations. Alright, so you are finding that now it's no longer a simple cyst. There are these multiple trabeculations that you are seeing within the lesion, again giving you a soap bubble kind of appearance. This is an aneurysmal bone cyst, and when we do the MRI of an aneurysmal bone cyst, what are we going to find? Remember, we are going to find multiple blood levels. Alright, so blood or blood fluid levels, which tell us that there is some sort of bleeding which is going on inside the lesion. Okay, so these levels, which are your blood fluid levels or fluid levels, variably referred, will have these multiple pockets, will have these multiple locules, and within these locules you will find that there are these multiple levels which are getting formed. Alright, so you will have these levels of fluid which are getting formed, and whenever we see these kind of fluid levels, these are all our differentials that we need to consider. So one, aneurysmal bone cyst has to be ruled out. Secondly, a giant cell tumor, again which had trabeculations, epiphyseal tumor can also have fluid levels within. One very important variant of osteosarcoma is this telangiectatic OS, which again has bleeding within it. So as the name suggests, this is one variation, one variant of osteosarcoma with fluid levels and metastasis. What kind of metastasis? Again, mets which are very vascular. So remember, hypervascular metastasis again will show us these fluid levels. Predominantly primaries like RCC, clear cell RCC, which is very vascular, follicular thyroid C again, which is very vascular, will show you these fluid levels. Looking at the next entity here, what do we see? We see that there is this bony outgrowth, right? You see that there is this bony outgrowth which is growing away from the joint. So this entity, this is not a true bony tumor. What is this? This is actually an osteochondroma. This is an osteochondroma, also referred to as exostosis, right? So this is osteochondroma or exostosis, wherein we see this lesion which is growing away from the joint outside the bone. Okay, and anytime you see multiple such lesions, it's referred to as diaphyseal aclasis. It's called diaphyseal aclasis, or it's also called hereditary multiple exostosis, HME. Quite a simple self-explanatory name. So now, what is the importance? Anytime it is multiple, remember the risk of this lesion turning malignant increases. So in a single osteochondroma, first of all, what kind of malignancy will it turn into? Osteosarcoma or chondrosarcoma? So remember, it has a risk of developing chondrosarcoma. And how will I pick up that chondrosarcoma? Tell me, how do we look at the cartilage? Is the cartilage visualized on an X-ray? No, not really. So the investigation of choice, if you remember the thumb rules for cartilage, is going to be an MRI. Alright, so when I want to see that this cartilage cap is thickening, it's producing this malignancy, I need to do an MRI to rule out chondrosarcoma, to rule out malignancy, and the thickness we take is going to be more than 1.5, some books write 2. Okay, so 1.5 to 2 centimeters the thickness that we use to say that okay, it might be turning into chondrosarcoma, right? Apart from that, so the risk of this turning malignant is higher in diaphyseal aclasis. So in a standard solitary exostosis, the risk is somewhere around 1%. But when there are multiple lesions, the risk increase from 5 to 20%. Okay, so there is a much higher risk of chondrosarcoma in a familial multiple hereditary exostosis syndrome. Talking about this metaphyseal tumor, something which has the highest chances of getting asked, what do we see? So there is this very infiltrative, permeative tumor in the metaphysis, which is growing from the bone. You see this periosteal reaction and this lifting up. This lifting up of the periosteum is referred to as the Codman's triangle. And you also see these new bony spicules which are growing perpendicular to the bone. This is called as the sunburst reaction. Now, what is the Codman's tumor? Remember Codman's triangle versus the tumor. So, Codman's tumor was our epiphyseal tumor starting with a C. So, that is chondroblastoma. So, it's chondroblastoma which is actually called the Codman's tumor. Do remember this trivia. Okay, so this is your aggressive metaphyseal tumor. How do I know it's osteosarcoma? It will have this dense matrix. You see how dense it looks? That is suggestive of new bone formation. Right, so this is how osteosarcoma will appear. The age group is again 0 to 20 years, more in the second decade. Okay, so this is about osteosarcoma, a very important image. So now looking at this set of images in this MCQ, what are we seeing? We are seeing that the hand bones are completely deformed. All the hand short tubular bones are affected and a few of them are expanded and they have this very stippled sort of calcification. Can you see they have these white foci? In addition, what do I see? I see that the soft tissue has these multiple bluish lesions. So in this context, this is likely to be hand enchondroma. So anytime you're shown the X-ray of the hand and you see the tubular bones getting expanded, it may be a solitary lesion or multiple lesions. That is suggestive of enchondromas. Again, chondro meaning cartilaginous matrix, so it will have calcification which is very stippled, dotted, so that is the hallmark of enchondromas. Short tubular bones of the hand will be a very big clue. And now when I see these hemangiomas, these bluish lesions actually represent hemangiomas. So now when I see the clinical picture, I see these bluish lesions. So these are actually hemangiomas. A lot of times on the X-ray itself, you will see these calcifications, these soft tissue calcifications which are called as phlebolytes. So these are seen in hemangiomas and vascular malformations which are vascular calcifications. Alright, so these are phlebolytes that you are seeing. So enchondromas plus soft tissue hemangioma constitutes the Maffucci syndrome. Okay, so anytime you see these multiple enchondromas, again see this different X-ray, can you see the short tubular bones of the hand being expanded with these dots, with these stippled sort of calcification? This is the hallmark of enchondroma. And when you see only multiple enchondromas, so O for only multiple enchondromas, it is O for Olier's disease. Wherein if you see multiple enchondromas, in addition there are these soft tissue hemangiomas like the last case, that is called as Maffucci disease. Alright, so that is called as Maffucci. So remember the two syndromes with multiple enchondromas. Going ahead, anytime we see a ground glass matrix, so particularly the femoral neck is the region, the femoral metaphysis is the region that gets affected here. So whenever you see this sort of a matrix wherein you have this not very white, not very black, so it's not a lytic lesion, it's not a very sclerotic newborn forming lesion, it's in between. So this is called as ground glass matrix. And if again you have a pathological fracture which is associated with it, you will see this deformity wherein the femur is bent. It's bent like a shepherd crook. So this is called as shepherd crook deformity. And the lesion that it typically describes is called the fibrous dysplasia. So this is fibrous dysplasia. And one more sign we will see here is called the Rind sign. And this Rind sign describes this sclerotic rim. Do you see this lesion again in the femoral neck which has this sclerotic rim around it? So a central ground glass matrix and a rim around it, the Rind sign, all features of fibrous dysplasia. Now again, fibrous dysplasia can involve multiple bones. So a polyostotic FD is associated with two important syndromes that I want you to know. One, when they give you associated history of precocious puberty, endocrinopathies, I want you to think of McCune-Albright. So McCune-Albright syndrome will have this associated anomalies. On the other hand, when you see multifocal soft tissue myxomas, this is something which is seen with Mazabraud's. This is something which is seen with Mazabraud syndrome. Okay, so remember these two syndromes which are associated with polyostotic or multiple fibrous dysplasias. Now, looking at the vertebrae, so remember the most common benign lesion of the vertebral body is this lesion, which is the spinal hemangioma. So here we will see these two signs. When I look at a sagittal image, you will see that all of these bony trabeculations are prominent. So this is described as the jail bar or a quadroid cloth appearance. If I take a cross section through this, again you will see the bony trabeculations getting very prominent. This is referred to as the polka dot sign. Okay, so these are two signs which are seen with spinal hemangiomas. So now starting with arthritis. So here again I give you the hallmark features that you have to look out for in the radiology and the diagnosis becomes pretty evident. Again, clinical picture will be very important here. So we'll try to incorporate everything. Okay, so when you have this sort of an image wherein the large joints are affected more than the small joints, you have a clinical picture wherein there is this chronic history, large joints getting affected, it is quite asymmetrical, there is no morning stiffness. All of these features tell you that something degenerative is happening, right? So now we are discussing osteoarthritis. Alright, so now let's discuss the features of osteoarthritis or degenerative arthritis. So in this, first of all, the larger joints are going to be affected. There's going to be asymmetrical involvement. So asymmetricity will be in the sides as well, wherein right and left will not be completely symmetrical. Plus, the joint that is involved will also be asymmetrically involved, wherein you don't have a symmetrical complete joint space reduction. You find here that the lateral part, the lateral joint space is more involved rather than the medial joint space. So that is how it will be asymmetrical within the joint as well. Apart from that, you will find that there are new bones which are formed, which are called osteophytes. So these triangular projections that you are seeing, that is called as osteophytes, which is new bone formation. And also you will find around the bone, do you see this whiteness here? This is called subchondral sclerosis. So asymmetrical involvement, large joints getting involved, subchondral sclerosis and osteophytes. All of these are hallmarks of a degenerative disease such as osteoarthritis. Exact polar opposite when you have a younger female with a history wherein she has morning stiffness, wherein there is stiffness and it improves with activity, worsens with rest, all of these features tell you what? That we are dealing with an inflammatory arthritis. And when we look at the imaging, again we would find the small joints getting involved more frequently. X-ray of the hand would be given, wherein the most common joint to be involved in inflammatory arthritis, the prototype of which we are discussing, that is rheumatoid arthritis, most common joint to be involved is metacarpophalangeal joint. So they'll give you the X-ray of MCP joint, or they'll give you the X-ray of the wrist. Okay, so here we'll find that the joint space involvement, the joint space reduction, the bones to be involved, it's very symmetrical, all the bones are involved. Plus, in contrast to the osteophytes seen in degenerative arthritis, here we are seeing erosions. We are seeing that the bones are all eaten up. There are these various eaten up areas which are referred to as erosions, which are marginal. So you see erosions at the margins here. Plus, instead of subchondral sclerosis that was happening in osteoarthritis, here you would find that the bone density goes low. Because of the constant inflammation, you have synovial proliferation, which is called as pannus. Because of the hyperemia, you have the bone density getting lost. So that is why you will have this periarticular osteopenia here, okay? And also the hallmark, the joints to be spared here will be DIP. So remember, DIP sparing again goes in favor of rheumatoid arthritis, and eventually in long-standing disease you will find deformities. So deformities such as swan neck, Bottomnose deformity, Z deformity, all of these will be seen. Hitchhiker's thumb, windswept deformity. So these are all the terms that we study in medicine which are associated with rheumatoid arthritis in the later stages. So radiological hallmark, symmetrical, marginal erosions, periarticular osteopenia. Going ahead, so this is a special view that we do for rheumatoid arthritis, which is called the ball catcher's view. So this is a ball catcher's view wherein the hands are kept like this, such that the joint which is most commonly affected, which is the metacarpophalangeal joint, becomes quite prominent. So you see here that these joints are best visualized on this view, and that is why we do this view for rheumatoid arthritis. One more name that they can give you, this is also referred to as the Bruverton's view. Okay, this is also called as Bruverton's view. So looking at the next disease here, what do we find? First of all, let's have a look here. Here we can find that there is this gross destruction of the joint space. Do you see this? That there's this gross destruction such that the bone is telescoping into the bone, right? So there is telescoping at the joint space, also called as pencil in cup. So it looks like this tapered pencil within a cup, and both of these are hallmarks of psoriatic arthritis. So remember, in psoriatic arthritis, you have a lot of destruction of bone which goes on, plus the history would be very, very typical wherein you will have associated skin changes, nail changes in the form of the erythematous plaques with those silvery scales, and oil pitting and other nail changes we find in psoriatic arthritis. In addition, if you see that there's complete destruction in advanced stages, resembles something like this, wherein all the joints are affected here, and clinically it looks like an opera glass. It looks like opera glass sign, which is a very destructive form of psoriatic arthritis, referred to as arthritis mutilans. So remember, psoriatic arthritis, a very destructive arthritis, and the most common joint to be affected here is going to be DIP. So DIP sparing in RA, but DIP getting involved most commonly in psoriatic arthritis. Going ahead, you will get the history of an older male who's been binge drinking and suddenly complains of pain of the foot at the first metatarsophalangeal joint, which is the most common one to be involved. You know that we are talking about gout, a very, very typical clinical scenario. So the radiological picture of gout, you are going to be seeing these very large erosions. Do you see these very large erosions, which are referred to as rat bite erosions, and they have these overhanging margins. You would find that the margins are overhanging from the erosions. This is referred to as the Martel G sign. So this is the Martel G sign, and one advanced CT that we can do here is a dual energy CT. So a dual energy CT can actually characterize the presence of uric acid in the joint, in the soft tissue, which is nothing but the tophi. So it can identify uric acid deposition in the subcutaneous and the joint space, and it looks something like this. So if I show you a 3D volumetric reconstruction, which is called VRT, which is volumetric reconstruction technique of the CT, wherein we produce these 3D images, you will find that there is this deposition of uric acid crystals here around the joint. Do you see these green crystals? Nothing but the depiction of uric acid crystals by a dual energy CT. So remember, dual energy CT, two applications. One is again the application of gout, wherein we can see uric acid crystals. Plus, if you have calculi, if you have renal calculi or ureteric calculi, again dual energy CT can tell us whether it's a calcium oxalate stone, or it's a uric acid stone, or it's a cysteine stone. So again, it can characterize the renal calculi further. Okay, so these are the two advantages of dual energy CT that you should remember. Going ahead to the next part here, so what do we see? We see that there is a typical history which is given here, that it looks very bad, the joint looks very destroyed, it looks very edematous, distended, but the patient tells you that I am feeling fine, I do not have so many symptoms like you are saying. So it looks bad on the X-ray, but the patient feels okay. So X-ray clinical picture, quite scary, but patient doesn't have pain. So why doesn't he have pain? That is because all his sensation is lost. So that is why this type of joint is called the neuropathic joint. This is referred to as neuropathic joint or Charcot joint. Okay, and this occurs in patients who have a neuropathy. Most commonly we see it in diabetic patients, and the area to be involved is again the foot, which will be most commonly involved. The mid-tarsal joint is something which is most commonly involved. Apart from that, other causes can be any causes of neuropathy such as leprosy. Alright, a lot of times syringomyelia will also lead to loss of sensation in a cape-like distribution. That is the buzzword for syringomyelia. So you will have bilateral elbows, shoulders getting affected in syringomyelia. Apart from that, any neuropathic cause basically can lead to it. So looking at the X-ray, so it's described as having these 6 typical Ds. So the 6 Ds of neuropathic joint are: 1, it will be distended. That means that there will be joint effusion. Second, it will be very dense. The density is going to be increased here. So if you look carefully, first of all, can you see the distension here? This is a joint effusion, and the bones look quite sclerotic. They look whiter. So this is suggestive of increased density. Plus, there is this gross destruction. The bones are markedly destroyed. So you have destruction, you have a lot of debris which is there. Joint dislocation can also happen, and overall there is disorganization. So all of these bad D words which indicate that the joint is in a bad state, this tells you that it's likely a case of neuropathic Charcot joints, particularly if the patient tells you that it's not very painful. Okay, so this is neuropathic joint. Now, just to get a few one-liners out of the way which are frequently tested, what is the disease wherein you see epiphyseal enlargement? So here, remember, you have juvenile idiopathic arthritis. So in juvenile idiopathic arthritis, we see that one epiphysis will be asymmetrically enlarged. Where do you have epiphyseal dysgenesis? So this condition wherein the epiphyses are not formed is something which is seen in congenital hypothyroidism. So remember, in hypothyroidism, because of epiphyseal dysgenesis, we'll find that the baby will have short stature, right? And widened intercondylar notch. So when you find that in the femur you have the intercondylar notch which has become very wide, this is something which is seen in hemophilia. So there is a feature of hemophilic arthropathy. Okay, so remember this. So these are all the one-liners that I want you to remember which have been asked previously. In addition, hemophilic arthropathy, also remember there is squaring of patella. Patella becomes square-like. Okay, so these are two features that we see with hemophilia. So now continuing with our discussion, we have a 30-year-old male who presented with diffuse back pain since 3 months. The pain surprisingly resolves when he works out at the gym. The spine X-ray is shown here. What is the diagnosis? So before looking at the image here, when you analyze the question, you find that there is pain which resolves when he works out, which means that it resolves with activity. So this is a very typical feature of inflammatory arthritis, right? So here, because we have back pain, we'll call it inflammatory spondyloarthritis. And remember, the prototype of inflammatory spondyloarthropathy is going to be ankylosing spondylitis. All right. Now, when we see the X-ray, we can see that here the complete spine is fused anteriorly, posteriorly as well. So we are seeing pan joint fusion. In fact, the posterior elements are also fused. So when you see this pan spinal fusion, this is something which is seen in the ankylosing spondylitis. Alright, so now let's discuss angspond. Just a quick word, DISH, as we have studied in our detailed lectures, remember diffuse idiopathic skeletal hyperostosis, you would have newborn formation along the ALL. So you will have this thick flowing ossification along the ALL, anterior longitudinal ligament, which looks like candle wax which is dripping. Alright, so that is the appearance you see in DISH. Klippel-Feil is a congenital fusion syndrome wherein the spine, the cervical spine has a lot of fused block vertebrae. As a result, the neck is going to appear shorter. So they have a short neck, they have multiple fused vertebrae, and they have a higher hairline. Okay, so this is the triad of Klippel-Feil. And in Sprengel's deformity, which is a previous AIMS question, you would find that one of the scapula is high riding, and a lot of times it can be connected to the vertebra with a omovertebral bar. Alright, so these are features of all the other options. So now let's talk about angspond. So ankylosing spondylitis, remember, the word itself tells you that there's going to be ankylosis, right? So there's going to be ankylosis, which means that fusion of joints is going to happen throughout the body, and you're going to have spine inflammation, right? So spondylitis tells you that it's an inflammatory arthritis. Now, when I asked you which is the most sensitive investigation or investigation of choice, so before this ankylosis happens or before this spondylitis happens, remember the earliest feature that can be seen is sacroiliitis. So remember, the first manifestation of angspond is going to be sacroiliitis, wherein there is inflammation at the sacroiliac joints, and this is manifested as bone marrow edema. So again, when we go back to our thumb rules, remember bone marrow edema, the diagnosis is made on MRI. The diagnosis, the investigation of choice for bone marrow edema is MRI, particularly the stir sequence. So the stir sequence actually means a fat suppressed sequence. Alright, so this is how we are going to be diagnosing sacroiliitis. Now, eventually, there's going to be fusion which happens, right? So there's going to be fusion, and we'll see that the joints are fused. So in the end stage, we'll pick up ankylosis of the sacroiliac joints. Once the disease progresses to the spine from the sacroiliac joints, we're going to start seeing the inflammatory changes in the spine. So in the spine, remember, the first sign, the earliest lesion you're going to see is near the end plates. Can you see these end plates here, the corners? So these corners are starting to appear sclerosing. Alright, so they are starting to show this whitening, which is called sclerosis. So this is also called as the shiny corner sign. So this is referred to as shiny corner sign, or some people also call this the Romanus lesion. So this actually represents the inflammation which is happening here at the attachment of the annular fibers. Alright, so at the attachment of the annular fibers, you have this inflammation, and remember this, we have discussed this. This is called as enthesopathy, and this is again a very important feature of angspond, wherein at all the ligaments and tendinous attachment sites you have inflammation. Okay, so this is called enthesopathy or enthesitis. Right, and this is something which is a feature of ankylosing spondylitis, and one of that we are seeing here. Slowly, as a reaction to this inflammation, we are going to have vertical syndesmophytes. So this is again going to be new bones which are going to be formed. Can you see? Connecting the intervertebral disc, we are going to have these vertical syndesmophytes which will cause a complete fusion of the spine, and eventually all the ligaments will also ossify. So as a result, you will see that all the joints, anteriorly, posteriorly, everything is fused. The posterior joints are also fused at the level of facet joints, and you are seeing this calcification of the supraspinous interspinous ligaments, giving rise to all of these name signs. So you see this tram track appearance, wherein everywhere on an AP view, you are seeing this fusion. tram track, also called as the dagger sign because of the central ossification, and because it is completely fused like a bamboo, it's also called as a bamboo spine. Going ahead, so now as we discussed, when we find in contrast, when we find this sort of a flowing ossification, IV disc is normal, all the other joints are normal. So when you find this new bone formation along the anterior longitudinal ligament in an older patient, here your prototype patient of Angst-Bond is going to be a younger male who's coming to you with chronic back pain, whereas here it's going to be an elderly male, and this diagnosis is going to be DISH, which stands for diffuse idiopathic skeletal hyperostosis, right? So this is going to be diffuse idiopathic skeletal hyperostosis. And just to contrast it, in the cervical spine with Angst-Bond, based on a previous AIMS question, we'll have that there is this complete fusion of the spine, right? So remember, here you have ALL flowing ossification, this pan joint fusion, young person, this is Angst-Bond, alright? So this is ankylosing spondylitis. Going ahead to our discussion, so what do we find here? Which is the ligament which is ossified? So I'm showing you a CT, and here can you see that the ligament which runs here at the posterior vertebral bodies is ossified, which is the PLL. So we are seeing the ossification of posterior longitudinal ligament, and this condition is called OPLL, ossification of posterior longitudinal ligament, also called as Chapman's disease. So this is also referred to as Chapman's disease. Going ahead, what do we see here? So in this case, you can find that the bone's density is diffusely increased, referred to as sclerosis. So everywhere in the body, you would find that the density of the bones is increased. Plus, this is the hallmark wherein the ligament which is connecting, which is a syndesmophyte connecting the radius and ulna in the middle part, this is ossified, right? So the interosseous ligament getting calcified, you can also have associated dental changes. So all of these are features which suggest fluorosis, right? So this is a finding of fluorosis. This is the hallmark which you have to remember associated with fluorosis, which is interosseous ligament calcification. Now talking about metabolic bone diseases group of disorders. So the first disease wherein we are finding the pathognomic feature here. So what do we have? So here you can notice that the second and third proximal and the distal phalanges, can you see here, predominantly in the radial aspect, near the thumb, the radial aspect, you are finding that there are these resorptions. Can you see this? It looks eaten up, right? So these are the subperiosteal resorptions that you are finding on the radial aspect. This is the pathognomic feature of which disease? This is the pathognomic feature of hyperparathyroidism, remember. So this is the hallmark where you have these second and third fingers, proximal middle phalanges, radial aspect, resorption, eating up of the bone, the high parathyroid levels causing resorption. In the skull, what is the kind of appearance we are going to see? So this is called as the salt and pepper skull appearance, wherein you would find that there are these very tiny resorptions. Do you see that there are these various areas of bony resorption throughout the skull? So this is referred to as salt and pepper skull appearance. Again, what else will we find? So one more feature is the loss of lamina dura. So for that you need to know what is lamina dura. So that is this normal periodontal membrane that you are seeing. So this is the lamina dura, which is this white line. So this lucent line is the periodontal ligament. Just below it, the ossified structure that you are seeing, the white line that is marked by the arrow, is the lamina dura. So in hyperparathyroidism, even this gets resorbed. So you will find that there is no lamina dura. There is no thin white line which is seen, here. So this is called loss of lamina dura, one more feature. Going ahead, what else can we find? We can find these multifocal bony lesions. So what are these multifocal, lytic, irregular bony lesions which are scattered throughout the body in the metaphysis? So these are referred to as brown tumors. They can mimic primary bone tumors, but they're going to be multiple and associated with other findings of hyperparathyroidism, right? So these brown tumors are again basically pathologically. Why are they called brown tumors? Because there is a lot of bleeding which goes into them. They are also referred to as osteitis cystica fibrosa. right? So they form this cystic sort of cavity, there's fibrosis, there's going to be a lot of hemosiderin deposition in them because of the bleeding, which results in the name brown tumors. So this is about brown tumors. Going ahead, what about secondary hyperparathyroidism? So all of these were features that were more commonly associated with primary hyperparathyroidism, which is related to a parathyroid adenoma. In turn, when you have secondary hyperparathyroidism, which means that as a result of a chronic kidney disease, what has happened is because the kidneys are unable to produce calcium because of the 1-alpha hydroxylase enzyme being deficient, so there's going to be hypocalcemic state, plus the phosphorus levels are going to increase. Why? That is because the kidneys are unable to excrete them. So both of these again give a stimulus for hyperparathyroidism, right? It causes parathyroid secretion to get excess, and this is referred to as a secondary hyperparathyroidism state. So here the finding that you'll see in the spine, the hallmark, you'll not just see resorption. You'll see resorption, bone density getting reduced, but in addition you would find sclerosis because there is phosphate deposition as well. There's phosphate retention which gets deposited resulting in sclerosis. So this sclerosis is the hallmark of secondary hyper-PTH. So when you have these alternating bands of sclerosis and reduced density, so sclerosis, osteopenia, resulting in these alternating white and black bands which look like rugger jersey. So this is called as rugger jersey spine, and in the knee and the wrist you will have calcification of various ligaments like the menisci. So this is called chondrocalcinosis. Remember, this is referred to as chondrocalcinosis when cartilage or menisci get calcified. So remember, chondrocalcinosis with two diseases. One that we are seeing, secondary hyperparathyroidism, and the other one I want you to remember is pseudo gout. Alright, so pseudo gout is again because of calcium pyrophosphate deposition. Alright, so it's calcium pyrophosphate deposition. Again, you will see that the wrist, there is a ligament called triangular fibrocartilage. In the knee, you would find menisci getting calcified. So you would see calcification of these two ligaments. Okay, so this is about chondrocalcinosis. Looking at the next disease, what do we see? So here you can see that the skull is markedly enlarged. It's markedly enlarged. Look at the scalvarium, it's thickened, and you are finding these multiple white sclerotic spots which are called as cotton wool skull. And again, you would have this typical description that the person says my hat size is increasing, my head is growing in size, or he could also tell you that I'm having visual loss, I'm having hearing loss because his nerves are getting compressed, cranial nerves are getting compressed, whether it's the optic nerve or the 8th cranial nerve, they're getting compressed at the foramina. So this disease is Paget's disease. So remember, Paget's disease, you have variable phases, you can have sclerotic phase, you can have lytic phase, and you can have a mixed phase. So in the sclerotic phase, you will find these white cotton wool spots, and you would find an increasing hat size which is referred to as the Tam O'Shanter sign. Going ahead, in the lytic phase, you would find that there is this large lytic lesion which is there, right? So this is referred to as osteoporosis circumscripta, a well-defined circumscribed area of reduced bone density. Further, when we look at the long bones, you would find that there is this lysis with an advancing edge, right? So this is referred to as a blade of grass or a candle flame appearance. Alright, so a blade of grass or candle flame sign is the name that is given to this advancing lysis in the long bones. Apart from that, what are the spinal manifestations? So one, because of coexisting sclerosis as well as lysis, you would find that the vertebra looks like a picture frame, right? There is peripheral sclerosis, central osteopenia, which results in a picture frame vertebra, or you can have a diffusely sclerotic vertebra called ivory vertebra. Now, differentials of ivory vertebrae are very important. So, apart from Paget's disease, you would also find them in lymphoma, particularly Hodgkin's lymphoma, sclerotic metastasis. Most commonly, you will see them from prostate in a male, breast from a female. So, these are the common primaries that you need to know. Apart from that, in a case of treated tuberculosis, alright, healed tuberculosis, you can also have this. So in turn, it basically tells you that there's sclerosis, there's osteoblastic activity which is going on. So all of these will be differentials of an ivory vertebra. What would you see in a bone scan? So a bone scan is a nuclear medicine investigation where we use technetium-99M, which is tagged with MDP, methylene diphosphonate. Okay, so this is a compound that we use, which again goes to newborn forming areas. So it picks up newborn formation. So again in Paget's, wherever you have newborn formation, it's gonna go producing the Mickey Mouse sign in the vertebrae, and it can produce the Abraham Lincoln sign wherein there is uptake in the mandible alone. Okay, so these are named signs with bone scan. Just to give you a quick recap, where all do we see Mickey Mouse sign? So when you do an ultrasound of the lower limb, remember at the saphenofemoral junction where you have the GSV coming into the SFV. So this is GSV draining into superficial femoral vein, and you also have SFA. So three of these together make up an appearance of Mickey Mouse. Apart from that, on an antenatal ultrasound, Mickey Mouse or frog eye sign is seen with anencephaly, right? It's seen with anencephaly. On a bone scan, we have just learned it will be seen with Paget's disease. And on the brain MR, slightly lesser heard of, on an axial section, when you have midbrain atrophy in a case of progressive supranuclear palsy, remember on an axial section, the deepened interpeduncular fossa basically makes the midbrain look like a Mickey Mouse. Okay, so this is one more area where we see Mickey Mouse. So this is just a quick summary for you. Going ahead, what do we have here? So looking at the next disease, you are finding these three manifestations. So having a look at the digits, at the phalanges, what do you find? That there is this overgrowth in the distal aspect. Do you see this overgrowth? So this is referred to as the spade phalanx. Okay. Then when we look at the foot X-ray, can you find this gross increase in the heel pad thickness? So there is this grossly distended heel pad thickness. The cutoffs are variably given in different places, but you can remember more than 23 millimeters in female and more than 25 millimeters in male is defined as a cutoff for this increased heel pad. And in the skull X-ray, can you see this marked prognathism, this jaw angle being increased? And plus, look at the sella which is widened. There is this widened sella, the sinuses appear enlarged, the calvarium appears thickened. So all of these features together point to a syndrome which is causing this soft tissue and bony overgrowth. So remember, this is seen in acromegaly. So in acromegaly, because of the increased growth hormone after growth plate fusion, you will have all of these bones, soft tissue, which are all proliferating, giving rise to these features. So these are all features of acromegaly. So looking at the next case, let's say we have a child who is presenting to us with multiple bony swellings, multiple lymph nodes, multiple skin lesions, and we have these radiological features. So in the skull, you have these lytic lesions. The typical feature is they are first geographical, they are large, and they have a beveled margin. So they have that two margins which you can see. So there is this differential destruction of the inner and outer table, which is called as the beveled margins. Apart from that, the spine is showing you what? That one of the vertebrae is completely flattened, it's completely destroyed, which is referred to as a vertebra plana. Remember, the disease that we are talking about is Langerhans cell histiocytosis. It is a multisystemic disorder which affects predominantly children, causes these bony destructive lesions, and LCH happens to be the most common cause of vertebra plana in children. Apart from that, any other lesion like Ewing sarcoma or lymphoma, leukemia, any destructive lesion can cause vertebra plana. Going to the mandible, here you have a floating teeth sign which is described again because of multiple erosions in the mandible. It appears like the teeth are floating. So all of these features describe Langerhans cell histiocytosis. Looking at the next skull appearance, what do we have? We have multiple variable sized, well defined. It looks like we have punched in the skull bone, right? So these are multiple punched out lesions, also called as raindrop appearance, seen with multiple myeloma. Alright, so this is seen with multiple myeloma. One more differential would be what? The other differential is lytic metastasis. So lytic mets, multiple myeloma, both will be the differentials for this punched out or raindrop skull appearance. What about this skull appearance here? So can you see that there is this gyriform sort of calcification that you are seeing in one side of the skull? Again, complete cerebral atrophy. So we are seeing a complete cerebral atrophy with calcification. Tram track calcification is the name given to this. This is seen with Sturge-Weber. So this is seen with Sturge-Weber, particularly when you have a port wine stain, right? So you will have a purple port wine stain. Nevus flammeus is what it is called. Most commonly, where does it affect? So remember, it affects the trigeminal nerve course, most commonly along the ophthalmic branch. So along the V1 is the most common, and in addition, the triad consists of congenital glaucoma. So the patient will come with this triad of calcification, tram track, which leads to refractory seizures with cerebral atrophy. There is port wine stain, there is congenital glaucoma. This represents Sturge-Weber syndrome or neurocutaneous syndrome. Going ahead, what do we find here? So here you can see that the trabecular markings, can you see these diffusely raised trabecular markings giving rise to heron end or crew cut appearance? This is an appearance which is associated with any hemolytic anemia, right? So this is seen with cases of hemolytic anemia such as sickle cell anemia or thalassemia. So this has been asked multiple times, particularly in the FMG entrances, alright? So this diffuse heron end appearance is hemolytic anemia. So here, looking at the next X-ray, what can you find? That here in the skull is showing these diffusely increased convoluted markings, right? Multiple convoluted markings which resemble a copper beaten vessel. So this is called as copper beaten sign, and this is associated with raised intracranial pressure. Apart from that, what are the other features of raised ICP? So when they ask you earliest sign on X-ray in a child, remember, because children do not have sutures which are fused, so they will have sutural widening as a result of raised ICP. So in children, the earliest sign is going to be sutural diastasis. Whereas when we talk about adults, remember, the earliest sign in adults of raised ICP is going to be the erosion of dorsum sella. So the posterior wall of the sella is going to be eroded in adults. So these are findings of raised ICP. Going ahead to the next case, so when I tell you that there is a child who has hepatosplenomegaly with pancytopenia and showing you this diffusely increased density, do you see these bones are so white? So when you see increased density, and also if you look carefully, can you see that every bone has a bone within bone kind of appearance? Look at the spine. Can you see that there is a bone within the bone of the spine? So whenever we have this bone within bone or a sandwich sign, the disease to be considered is osteopetrosis. This is a congenital dysplasia. This is osteopetrosis with this clinical background. Looking at the next case in the form of an MCQ, we have a 65-year-old female presenting with low back pain. You find that the calcium phosphate PTH is all normal, ALP is normal. So whenever you consider metabolic bone disease, everything is normal. What comes to my mind? It is osteoporosis. And when we look at the X-ray, what do we see? We see all the bones. Do you see how bones should have appeared white? They are appearing diffusely decreased in density. The bones are very, very weak, and as a result, because of the body weight, they are all getting depressed. The end plates are getting compressed, resulting in this kind of an appearance that is called as codfish appearance. It's a codfish appearance which is associated with osteoporosis. Can also be seen with osteomalacia, okay, which is a vitamin D deficiency in adults, but more commonly osteoporosis. So now when we talk about osteoporosis, remember the investigation of choice for osteoporosis is going to be DEXA scan. So DEXA stands for dual energy. DEXA stands for dual energy X-ray absorptimetry. Alright, so this is what is DEXA scan. Basically, it measures the bone mineral density. It measures the density in terms of gram per centimeter square. So the two common sites which are used as reference is the femur, right, the femoral neck, and the lumbar vertebrae, which are used to measure the density. So here when we measure the density, it's not given as a value, but we compare it in terms of standard deviation with two kind of population. So first we can compare it with young adults. If we compare the bone mineral density of our patient with a young adult, that reference is called a T-score. That is called a T-score. Remember, young adults wear T-shirts, so T-score. On the other hand, if I compare it with the age-matched person, so whatever is the age of my patient, if I compare the bone mineral density with a normal age-matched individual, that score is called the Z-score, right? So there are two scores in terms of which the DEXA scan can be expressed. Now, what is the WHO scoring? So the WHO scoring, remember, uses the T-score. Alright, so WHO score uses the T-score for their grading. And how does it do it? So as you can see here, from +2 till -1, it is considered normal. From -1 to -2.5, this yellow range that you are seeing, so from -1 to -2.5 standard deviations, it is defined as osteopenia, and anything where the bone mineral density is lower than 2.5, less than -2.5 standard deviation, that is called osteoporosis. Okay, so this is how the WHO scaling is defined. Alright, so this is about osteoporosis. So now looking at the next disease, we have a child who's coming to us with this widening of the joints, predominantly the wrist, ankle is going to be affected. So remember, we're talking about rickets, something again very frequently asked in the exams. So rickets is because of vitamin D deficiency, right? So what are we going to find? Remember, what is going to be the earliest finding is going to be increased growth plate. Alright, so you will find that growth plate is increased, or it can also be expressed as this ZPC, which stands for zone of provisional calcification. So the zone of provisional calcification could be increased. So what happens here is, because there is no vitamin D, because there is no calcium, right, what is going to happen is there is going to be a lot of unmineralized osteoid waiting at the growth plate to get calcium, and the calcium is not there. So all of this unmineralized osteoid is going to accumulate here, resulting in widened growth plate, widened zone of provisional calcification. Slowly, as this further increases, it's going to cause mass effect on the metaphyses. So can you see this metaphyses, which has become very splayed? It has given this sort of a cup here because of the splaying. So this is the finding that we'll see at the metaphyses, where it becomes splayed, it becomes cupped, and there will be this irregularity which is called fraying. So all of these are signs of rickets on an X-ray. Most of the time we'll appreciate it on the wrist or the ankle joint. Eventually, when I start to treat this, what if the patient received vitamin D? What is the first thing that we'll see radiologically? So the first thing is, all of that unmineralized osteoid is now going to get calcium, so it will get deposited and you'll see this white line. So remember, the sign of healing rickets is going to be a white metaphyseal line. So this is a white metaphyseal line that you will see. Sclerosis at the metaphyses is what we'll see. This is also seen. So now remember, this white metaphyseal line is not specific just for healing rickets. It can also be seen in lead poisoning. It can also be seen in treated cases of leukemia, and it can also be seen in scurvy. So scurvy, remember, we'll see a white line. Let's talk about scurvy, but we call it. So do you see this bone? Again, we see the white line. We'll call it the Frenkel's white line. So now, common feature between scurvy and rickets, both of them are going to have bone density which is reduced because the bone is not forming properly. But here, bone is not forming properly because there is vitamin C deficiency, there is collagen which is deficient, there is osteoid which is not formed properly. What are the manifestations? So all of these signs you need to know. So one, the epiphysis will look like a ring. It will have sharp margins called the Wimberger ring sign. You will find these metaphyseal bony projections called the Pelican spurs. You will find this loosened zone above the white line, that's called the Trummerfield zone. So all of these big names are seen with scurvy, and in addition, you can also find subperiosteal hemorrhage like you see here in this case, where there is this hemorrhage below the bones which make it very painful, and that is why scurvy is referred to as a pseudo paralysis state. Alright, so can you see here how there is this subperiosteal hemorrhage? So this is what makes it painful, which is called as pseudo paralysis. So this is about scurvy. Looking at this image, so identify the structure marked by the arrow. So if you look very closely, there is one area which is sclerotic in the center, and then there is one loosened zone which is marked by the arrow. So this loosened zone is what is called involucrum, and this central white is called sequestrum. Alright, so let's discuss these findings. What are these features? So the answer here is involucrum, but we are discussing chronic osteomyelitis X-ray feature, and this is an X-ray which has figured a lot in your exams. So the central white bone that we were seeing here, right, the central white bone, that is called the sequestrum. So remember, white, sclerotic ka S for sclerotic, S for sequestrum. Why is it white? It is the dead bone, the central dead bone which is not getting demineralized. So because it is a dead bone, there is no vascularity, so there will be no demineralization. So that is why it appears sclerotic. Apart from that, the surrounding rim that was marked, which was lucent, is called the involucrum. That's called the involucrum because it represents the granulation tissue. Now, all of this pus in osteomyelitis is going to become too much, and a lot of times there's going to be this cloaca, there's going to be this defect through which the pus comes out. Okay, so this is what we will see as cloaca, and then there will be a draining sinus. So all of these are features of chronic osteomyelitis. Remember, central sclerotic sequestrum, involucrum, cloaca is the hole through which it comes out, and then you have a draining sinus. So this is all about musculoskeletal radiology. So now continuing with thoracic radiology. Looking at the first question here, all of the following form the right heart border except. Now, when we talk about thoracic radiology, you need to talk about chest X-ray, and you need to know the cardiac silhouette on a chest X-ray, right? So, what forms the right heart border, what forms the left heart border becomes very, very important. So, first let's discuss the right heart border. So, remember, when we talk about the right heart border, remember we have three structures, which is right atrium, SVC and IVC which form it, but right ventricle doesn't contribute to the right heart border, but it forms the base of the heart. Alright, so let's discuss the heart borders. So on the right side, on a chest radiograph, which is the right heart border, we have three structures. From the top, superior vena cava, right atrium, which forms the bulk of it, and a small part is formed by IVC. Now the thing to remember here, a caveat that can be put up, is ascending aorta. So ascending aorta can contribute to the right heart border, alright, in patients who are elderly. Alright, so in elderly patients there is aortic unfolding which happens because of loss of elasticity. So remember, ascending aorta can contribute to the right heart border in certain cases, but these are the main structures which will always form the right heart border. When we talk about left heart border, we have these four structures. So from the top you have arch of aorta, which is called as the aortic knuckle. So this is referred to as aortic knuckle. Then we have the pulmonary artery, left atrial appendage, and left ventricle. Note to be made, left atrium doesn't contribute to the left heart border, alright, and the right ventricle contributes to the base, to the inferior part of the heart border, alright. So these are the chambers which contribute to the heart border when we see it on an X-ray. So now when we see it on the X-ray, can you see here how on the right side we have the superior vena cava, right atrium, and a very small portion by IVC. RV is going to form the base, this inferior border of the heart on the X-ray. On the left side here you have the arch of aorta, which is the aortic knuckle. We have the pulmonary artery, the small part formed by the left atrial appendage, alright, or the left auricle, and then you have the left ventricle. So remember, LA doesn't contribute to any heart border. It's not even seen on this frontal projection because it lies posteriorly. So when asked which is the posterior most heart chamber, remember it's going to be left atrium. Alright, so that is located posteriorly. So now the left heart border can also be described in terms of moguls. Alright, so moguls are nothing but the bumps that you are seeing on the heart border. So the first mogul that you see at the superior most aspect is the aortic knuckle, right? It's the aortic knuckle that you see, which is formed by the arch of aorta like we learnt. Then the second mogul is going to be pulmonary artery. Then we have the left atrial appendage, and finally what forms the bulk of the left heart border? Left ventricle and not left atrium. And finally, what is the fifth mogul? So remember, anytime you have an abnormal swelling at the cardiophrenic angle, so this is any cardiophrenic angle mass which can form this swelling. So that forms the fifth bump. Usually you can have hiatal hernia which occupies this position, or you can have a pericardial cyst. So pericardial cyst can also occupy this area. Alright, so going ahead, this is about the heart border. So now just a few one-liners so that we have our concepts in place. So anterior most heart chamber. What is the anterior most heart chamber? They can also ask this in a different way, saying what chamber enlargement obliterates the retrosternal space. So, sternum is anteriorly, behind the sternum you have a lucent space. So, what chamber, if it enlarges, will obliterate that, again asking us what is anterior, right? Or most common chamber injured in trauma, again something which is anteriorly located will be more commonly injured. So, the answer to all of this is right ventricle. On the other hand, which is the posterior most heart chamber, if enlarged, can lead to dysphagia, can lead to hoarseness called the Ortner syndrome, and is visualized best on a transesophageal echo, because through the posterior mediastinum we are looking at that chamber, it's left atrium. Right, so left atrium is your posterior heart chamber. Remember that fact, very important. Now, when we talk about cardiothoracic ratio, remember we measure the dimension of the heart, maximum diameter of the heart upon the maximum thoracic diameter, and this ratio in neonates should be less than 0.6, while in adults it should be less than 0.55. Any increase from this suggests a cardiomegaly and a further workup is needed. So now let's have a look at this X-ray. This is an X-ray which represents the sign of left atrial enlargement. This is again something which is very, very important. So what are the X-ray features of left atrial enlargement? As we know, it's a posteriorly located chamber, so it won't contribute to just a heart border bulge like other chambers would. So what it would do is, can you see here there is this additional density? So this is the left atrium, which when it grows, it will basically protrude into the right heart border, giving rise to a double right heart border sign. So this is again something that we can see where it produces this double right heart border that is visualized. Apart from that, what is this happening here? So when the left atrium enlarges, you'd also have the left auricle enlarging, right? So when the left auricle enlarges, you would have a straightening. You would have a straightening of the left heart border that can be seen. Apart from this, we'll have that the carina gets splayed. There is increase in the carinal angle. Okay, so this is again one finding that when LA grows, it will cause widening of the carina. On a lateral view, remember again the left main stem bronchus gets lifted up, resulting in a sign which is referred to as a walking man sign. Okay, so that's also called as a walking man sign, which is used for left atrial enlargement. Alright, so now looking at the next view here, name the view that I am showing you. So here can you see how the person is assuming a lordotic sort of view such that the clavicles are lifted up. So the main aim of this position, which is called the lordotic view, is to view the apices, to view the lung apices well. So this is also referred to as an apicogram. Alright, so this is an X-ray view which is done to view the lung apex, because otherwise they will be overlapped by the clavicle. This way the clavicle gets lifted. So this is used for apex, or the middle lobes also get evaluated better. Okay. Moving on, anytime you see an opaque lobe on a chest X-ray, how do you approach? Alright, so now very, very important. So when you see the horizontal fissure, that is how you start your approach. So there's an opacified right upper lobe in all of these three X-rays, but all of them have a different diagnosis. So when you see the horizontal fissure is in place, that suggests that there is consolidation. When you have no fissural displacement, trachea is in the midline, this suggests consolidation. One more sign that we will see is when you have this opacity and you will see that the bronchi are air filled and they are visualized separately. This is called as air bronchogram sign. So this is the air bronchogram sign, which is a sign of consolidation. Again, it means that the alveoli are opacified and you are having the bronchi which is patent. When we go back, now we can see that the horizontal fissure is no longer horizontal, but it's actually bulging down. So when you see this bulging of the horizontal fissure, this is called as a bulging fissure sign, and this is seen in a special kind of consolidation which is because of Klebsiella. So this is seen with Klebsiella pneumoniae. Because of a higher virulence, the fissure bulges down. Now the opposite is happening. We are having that the fissure, instead of being horizontal, is pulled up. The right upper lobe is very, very small. It is having volume loss. The trachea is also displaced towards it. So when you have these features where there is volume loss, this is right upper lobe collapse where the fissure is pulled up. Alright, so this is RUL collapse. And if you find that there is a central mass which is causing this collapse, that is called as a reverse S sign, and it indicates that there is a central mass which is a malignancy which is causing this right upper lobe collapse. Okay, so this is what is the reverse S sign in right upper lobe collapse. So now let's have a look at the silhouette sign. So anytime we see such opacity, so right upper lobe was quite easy to figure out which lobe it is in, but for the other lobes it becomes difficult to localize whether it's in the middle lobe or the lower lobe when we see an opacity here because of the overlap on a chest X-ray. So to localize whether it's in the middle lobe or the lower lobe, we use the silhouette sign. So silhouette sign basically means that anytime you have loss of borders, like if you see here, I cannot make out the difference between the consolidation and the hard border. So when there is this loss of border, this is a positive silhouette sign, and it indicates that the opacity is actually in the middle lobe. So when there is loss of borders with the heart, that localizes it to the middle lobe. On the other hand, when you see this, that the heart border is seen separately from the consolidation, it tells me that no, it is not in the middle lobe. Okay, so this is what is silhouette sign, and to fulfill the silhouette sign, you need two things, that the heart and the lesion are in anatomical contact, right? That is what we need. And secondly, they need to have the same density. So any soft tissue on X-ray and any fluid, remember, will have the same density. Okay, so this is the silhouette sign. So let's understand this. So whenever you have a loss of border, you see a chest radiograph and you find that there is loss of border with the right heart, that means that the consolidation is located in the right middle lobe. When you have loss of border with the left heart border, it is localized in the lingula. When it's in the right diaphragm, it means that it is in the RLL, and when it silhouettes the left diaphragm, that means it is in the left lower lobe. So just to see an example, let's look at this MCQ. So here, do you see this opacity? Now, can you make it separately from the left heart border? Not really. So we can see that this lesion, this consolidation is silhouetting the left heart border, and that is why. Where is this consolidation? It's in the lingula. So that is how we use the silhouette sign. And see how diaphragm is seen separately? That means that it's not involving the lower lobes. Alright. So can I say left heart border silhouette sign is negative? No, it is positive. Located in left lower lobe? No. Located in lingula? Yes. Location cannot be commented without CT. This is wrong. We can comment on the location based on the silhouette sign. Right. So this is how the silhouette sign works. So again, if I show you this image, can you see how the lesion is merging with the left heart border? There is a positive silhouette sign that you can see. So again, we can localize it to middle lobe, which is the lingula on the left side. And one important feature on the lateral view to localize would be that any middle lobe opacity would always overlap the heart. So it will overlap the heart shadow like this case. So that is how middle lobe opacities work. On the other hand, lower lobe opacities. Look here. Can you see how there is this opacity and the left diaphragm? This is the right diaphragm. Can you see the left diaphragm separately? No. So this lesion is silhouetting the left diaphragm. And on the lateral view, remember, we can see that it falls behind. It obliterates the spine, and this is what is referred to as the spine sign. And this is when we localize it to the lower lobe. So this is how left lower lobe collapse or consolidation would appear. And when you have this complete flat waist kind of appearance, this is referred to as a flat waist sign, which actually says that this is not a consolidation, it's a complete collapse of left lower lobe triangularly. So this is your left lower lobe collapse. Alright, going ahead, left upper lobe collapse. Remember, left upper lobe collapse is going to be very, very unique in its appearance. So far, right middle lobe, left middle lobe. Both of them will have a similar appearance wherein they silhouette the heart border and they basically overlap the heart on a lateral view. Both the lower lobe consolidation and collapse is going to basically silhouette the diaphragm and fall behind, obliterating the spine. Right upper lobe, pretty evident, but left upper lobe is the unique one wherein you would see this veil-like opacity. Do you see this anterior opacity throughout? So this is described as a veil-like opacity. When you see a frontal projection, you would see this diffuse haziness and there will be this sickle of air around the aortic knuckle. So around the aortic knuckle, we see this sickle or this crescent of air, and this sign is referred to as Luft-Sichel sign. So remember, this Luft-Sichel sign is a sign of left upper lobe collapse. So these are all the collapse signs we need to know. So now looking at the next image here, what do we see? So this is your typical very important sign that you see on the chest radiograph. Can you see these dilated bronchi throughout the lung field? So these are all the dilated bronchi, the cylindrical bronchi that you are seeing here. This is referred to as the tram track sign, alright. So this is referred to as the tram track sign, which is seen with bronchiectasis on the HRCT, which is the investigation of choice. So remember, investigation of choice for this condition is a high resolution CT, wherein you would find that this is the air-filled bronchus. Can you see these dilated bronchi? How do I know they are dilated? So remember, the bronchus and the artery. The bronchus and the artery courses together, and you would find that the bronchus becomes dilated and the artery remains as it is. Do you see this? So that gives an appearance of a signet ring. So this is the artery which is white and this is the bronchus. So this is a high resolution CT which will focus on the lung. So the air appears black. Okay, so you will have this sort of a sign which is called as the signet ring sign. So this is the signet ring sign that you will find with bronchiectasis. Going ahead to talk about aspergillus. So remember, three types of infections of aspergillus. First, when you have an underlying cavity and you have colonization of aspergillus, it's not invading, that is called as a fungal ball. That is called as a fungal ball or an aspergilloma. How would that appear radiologically? So we would see that there is this cavity. Do you see this cavity in the upper lobe? Most commonly in our country, it's because of tuberculosis. It could be because of sarcoidosis or other causes, but most common TB. So because you have a tubercular cavity, aspergillus comes and basically colonizes it, producing this fungal ball, and this produces this crescent of air. Do you see this cavity and a fungal ball, which is the air crescent sign, or the monod or the monad sign? So this is what is called the aspergilloma or the fungal ball. Looking at the next manifestation, when you have underlying bronchiectasis because of some reason, and the aspergillus creates a hypersensitivity reaction, which is usually a type 1, type 3 hypersensitivity reaction, that is called ABPA. So that is a hypersensitivity reaction. Again, the aspergillus is not invading. So this is allergic bronchopulmonary aspergillosis. How will it appear? So we will see that there are proximal bronchiectasis and you will find the white mucus impacted within it. Do you see this mucus within the bronchus, and how does it look? It looks like a finger in glove. So this is the finger in glove sign that is used for ABPA, allergic bronchopulmonary aspergillosis. And on a CT, we would find that there is this high density mucus within it. So this is referred to as high attenuation mucus. So this is how ABPA will appear. Finally, if you have an immunocompromised patient, particularly a patient who has neutropenia, now the aspergillus is going to invade. It will invade into the vessels, it will invade into the bronchi, and this is called as invasive aspergillosis. And how this is gonna appear is basically gonna appear as these multiple nodules. Do you see this? So again, when we look at the MCQ, post hematopoietic stem cell transplant, so an immunocompromised patient with febrile neutropenia, this is one of the most common manifestations that you will see, and we find that there are multiple nodules, isn't it? There are multiple nodules which are having one solid center and a ground glass halo. So this is called as the halo sign, and this is how invasive aspergillus is going to appear. Alright, so this is invasive aspergillosis. So I hope you've understood these three types, very commonly confused. Alright, so this is the halo sign. Now talking about a few more infections. So if you have a history of a child who's just recovered from a viral URTI and develops a consolidation, develops a pneumonia, what is that causative organism? It's likely to be Staph aureus, right? And one typical feature of Staph aureus pneumonia is what we are seeing here, which is called as a pneumatocele. Can you see within the consolidation there is an air containing cavity? So this is called pneumatocele. So one of the important features of Staph aureus, pneumatocele. Going ahead, what do you see? So here we are seeing that there is a cavity with an air fluid level, but it is just a simple air fluid level. So remember, if you see a cavity with an air fluid level, that is indicative of abscess. But if you see that there are various contents floating in it, then it becomes water lily sign. And that basically indicates that it is a hydatid cyst, and these are all the membranes of the hydatid which are floating around. Okay, so this is how hydatid cyst will appear. Going ahead, what do we see here? So here, what do you see? You see the thumb sign, which is basically the inflamed epiglottis bulging into the airway. So thumb sign, remember, will be seen with acute epiglottitis, right? On the other hand, similar upper respiratory tract infection, when you have that the airway basically narrows like this, it forms this steeple that you see on top of churches. This is the steeple sign which is seen with croup. So this is seen with croup or laryngotracheobronchitis, which is basically associated with para-influenza virus most commonly, right? In contrast, epiglottitis, bacterial disease, whereas this is a viral illness. Okay. Now talking about, so remember, two interstitial lung diseases that you want to know about. First one, you are seeing that there are these basal cysts which are stacked one over the other like a honeycomb. So this is referred to as honeycombing. Secondly, can you see these dilated bronchi? So when you see these dilated bronchi getting pulled towards the periphery, this is called as traction bronchiectasis. And what is the third part? You see that there is a lower lobe predominance, there is a peripheral basal predominance. All of these triad are seen in UIP. This is seen in UIP, which stands for usual interstitial pneumonia. So this is the usual interstitial pneumonia pattern that you see of HRCT, and this is also called as IPF by pathologists. Alright, so both of them mean the same thing, where IPF stands for idiopathic pulmonary fibrosis. When we talk about the other ILD, where you have predominant ground glass opacities, do you see there are ground glass opacities and there is this black rim where you have sparing. This is the sparing that you are seeing, subpleural sparing. So this is seen with NSIP. This is NSIP, which stands for non-specific interstitial pneumonitis. Alright, so out of these two, remember, it is NSIP which has a better prognosis. It has a better prognosis than UIP, affects slightly younger patients. Apart from that, if I have to look at this CT more carefully, can you see here? This is the esophagus. This is the esophagus which is dilated and filled with air. So what does this suggest? This actually suggests that there is associated motility disorder, and that strikes a bell that this is likely to be related to connective tissue disorder, which is scleroderma. So remember, interstitial lung diseases very frequently related to connective tissue disorders, and this is what we are seeing here. Okay, so this is your ILD appearance. One more interstitial lung disease that we have, this is the organizing pneumonia. So this was previously referred to as cryptogenic organizing pneumonia, but now just organizing pneumonia is the term used for it. Alright, and what you will see is these peripheral nodules which have what kind of a sign? This is referred to as a reverse halo sign, right? So this is also called as reverse halo or a tall sign, wherein what do you see? So now let's understand halo and reverse halo. So in a halo sign, what we are going to basically see is that there is central solid part and periphery is going to be ground glass, right? It's going to be hazy. The hallmark of which is what? That we already studied, which is invasive aspergillosis. On the other hand, in the reverse halo, you're going to have a central ground glass like you're seeing, and the periphery is going to be solid. Okay, so this is called as reverse halo, and the prototype is organizing pneumonia. Apart from this, I also want you to remember both of these can be seen with COVID-19 pneumonia. Both of these can be seen with COVID-19 pneumonia, and one more recent advance, reverse halo sign, can also be seen with mucormycosis. So pulmonary mucormycosis can also have reverse halo sign. Alright, so these are the signs. So as you can see here, can you see this very large consolidation? And what do you see? Periphery is solid, center is ground glass. So this is a reverse halo, or also referred to as a tall sign, and some people also use the term bird nest. Do you see how this breakdown is so irregular? It looks like a bird's nest. So it is also called as the bird's nest sign, which is associated with mucormycosis. So this is how mucormycosis will appear in the lung. Moving forward, let's talk about COVID-19. So when I show you these 4 patterns, which of these cannot be seen in COVID-19? So here again, when we talk about COVID-19 pneumonia, you need to know typical patterns, atypical patterns, right? So now let's talk about the typical features of COVID-19. So first I want you to remember that the typical pattern that is associated with COVID-19 will be the presence of multiple peripheral based ground glass opacities and consolidations. Alright, so this is the hallmark wherein you have multiple patches of GGOs, which is ground glass opacities, and consolidations predominantly in the lower lobes. However, this is not a criteria. This is the main thing that you want to see. So look here in this image. Can you see that there are these multiple white patches along the periphery? This is how ground glass opacity appears. It's this hazy white thing, but not very white. Alright, so it is white but not as white as consolidation. So this is ground glass opacity, multiple peripheral distribution, typical COVID. When I see this, again, can you see how there are these multiple ground glass opacities scattered throughout the lung? And we can also see these vessels getting dilated, which represents the microvascular sign. So this is one sign which favors COVID-19 pneumonia. What do we see here? This is something we have just studied. What is this sign? So this is a reverse halo, right? This is a reverse halo sign. Again, both halo and reverse halo can be seen with COVID-19. But what do you see here? So here what we are seeing is this tree in bud pattern, right? Can you appreciate how there are these tree in bud tiny nodules? So this tree in bud pattern is seen with centrilobular nodules. And this is the hallmark of tuberculosis. This is the hallmark of any endobronchial spread of infection. When the infection spreads to the bronchus, this is not seen in COVID. This is not seen in COVID-19. This is atypical for COVID. Alright, so just to summarize, when we talk about COVID, we represent it as a score which is called the CORAD score. Right, so it's referred to, you all have heard of it. It is called the CORAD score, which determines the risk of suspicion. How much is my suspicion that these lung findings are COVID changes? Okay, so COVID reporting and data system, just like we have BIRADS, TIRADS, LIRADS, this is CORADS. Okay, so CORADS of 0 means the examination is not adequate. A score of 1 means that I have no risk of suspicion. It's either a normal CT or there is something completely non-infectious like a mass or emphysema. A risk of 2 indicates that the suspicion of COVID is low. There are atypical findings. So what are atypical findings? Tree in bud pattern, like we saw. Centrilobular nodule is again atypical. A single lobar consolidation, like a right upper lobe consolidation, single one, atypical. Lymph nodes, any cavity, any calcification, mass or pleural thickening, all of these are not features of COVID-19. We'll give a score of 2. Then we have a score of 3 and 4 wherein we are not very sure. Alright, so findings are in between. When we go to CORAD score of 5, now the findings are going to be typical. So these are 2 categories you need to know. CORADS 2 wherein findings are atypical, CORADS 5 where the findings are typical. What are the typical findings? So you have multifocal involvement. You have a peripheral distribution. Remember, lower lobe has been removed. Although lower lobe involvement is more common, it's not always needed. Okay, so multifocal, peripheral, round, GGO or consolidation, which are ill-defined. Associated, they can have vascular thickening like we saw. They can have vascular dilatation. They can have a reverse halo sign. There could be a spider web sign. So this microvascular dilatation can be referred to as a spider web, or you could have crazy paving. So crazy paving is basically when you have ground glass opacity plus interlobular septal thickening. This is what is referred to as interlobular septal thickening. Alright, so these are typical features where you give a score of 5, and when the patient is already RT-PCR positive, you give a score of 6. So this is the CORADS grading. So just to tell you, microvascular dilatation sign or prominent vessel within this. So again in this high resolution CT, can you see this vessel getting dilated? So this is the microvascular dilatation that you are seeing, and also note the subpleural sparing. Again, remember the CORAD scoring is given on which modality? It's only given on a high resolution CT. It's not given on X-ray. So remember, it's only given on high resolution CT of the lung. Again, what is the vacuole or the spider web sign? So within the GGOs, you will find these foci of air. You will find these air foci, which is referred to as the vacuolar sign. Okay, apart from that, we've already talked about reverse halo sign being seen. Alright, so both of these can be seen where you have nodules, multiple nodules which have ground glass opacities. And then what is the severity score? So CORADS is not a severity score, it's a suspicion score. When we want to see how much is the lung involvement and we want to give a severity score, there are two kinds of methods. One is out of a denominator of 25, one is out of a denominator of 40, where every lung segment is given a score. More commonly in practice, we use the 25 scheme method, wherein we divide both the lungs basically into the lobes. So in the right lung, we will have the 3 lobes, right upper lobe, right middle lobe and the right lower lobe. And on the left lung, we will have the upper lobe and the lower lobe. So each of these lobes is given a total score in the range of 0 to 5. So every lobe gets a score of 0 to 5 based on the involvement. And then we add it up. We add up the involvement to get a total score of 25. Okay, so if there is no involvement, 0. If there is less than 5% involvement of the lobe, that is 1. 5 to 25, 2, 25 to 50, 50 to 75, more than 75. So this is the kind of score we give based on the involvement of each lobe, add it up, and this is the severity score. When the total involvement is less than 8, it indicates a mild infection, 8 to 15 moderate, more than 15 severe. I want to emphasize here that this is not the score that we use for clinical triage. This is not the score we use for the management guidelines according to AIIMS. Okay, so this is a prognosticating method based on CT. Yes. It is a severity index, yes, but is it used as a basis for management decisions? No, it isn't. So remember, this is not for triage into mild, moderate, severe categories according to the AIIMS management recommendations. Alright, so that is something you need to remember. Now, looking at the next image, what do you see? So bilateral hilar nodes, we are seeing this peripheral calcification called eggshell calcification. Remember the two prototypes here, it can be seen in sarcoidosis, and if you have occupational related history, it can be seen in silicosis. Very rarely in Hodgkin's lymphoma after radiotherapy, it can also show you this. So this is eggshell. Now we talk about this pattern. So this is the crazy paving pattern that we just talked about. So here you have this basal ground glass opacities, and in addition there are these lines which are interlobular septal thickening. So this is the prototype of pulmonary alveolar proteinosis. So this is a congenital disease wherein you have this surfactant deficiency, so this is pulmonary alveolar proteinosis. Apart from that, this can also be seen in a bunch of conditions including COVID-19. So it can be seen in acute phase of silicosis, a rare type wherein you have acute manifestations of silicosis. It can be seen in pulmonary hemorrhage, it can be seen in pulmonary edema. Alright, so this is the crazy paving appearance. So now when we talk about this occupation related history, you would be given the history that this person is related to some occupation like a miner or in the plumbing industry, and you find these manifestations. So here can you see that there are these multiple white plaques which give the appearance of a holly leaf. So this is the calcified pleural plaque that is associated with asbestosis. So now we are talking about the manifestations of asbestosis. You will see these calcified pleural plaques everywhere which give the name holly leaf sign. Remember, in contrast, the ginkgo leaf, frequently confused, ginkgo leaf sign will be seen with subcutaneous emphysema. Okay, so that is related to subcutaneous emphysema. When we talk about this, what do you see? You are seeing that there is a peripheral opacity and the bronchovascular bundle is getting pulled here, which is the comet tail sign that is seen with round atelectasis, that is associated with rounded atelectasis, another feature of asbestosis. In addition, there is one very important manifestation you need to remember. Before that, remember the most common manifestation would be the presence of pleural thickening, which is referred to as pleural plaques that you are seeing as holly leaf one malignancy which is most specific. So when I ask you asbestosis related malignancy, you will ask me, are you asking most common or most specific? So when I tell you most common, remember it's going to be adenoCA lung. But when we talk about most specific, it is going to be mesothelioma. Alright, so how is mesothelioma going to appear? It's going to appear as this nodular pleural thickening. Do you see this nodular pleural thickening? This is how it will appear. So a unilateral nodular pleura with a frozen hemithorax. Normally when we would have pleural thickening, it would cause the mediastinum to be contralaterally shifted. But here there is no mediastinal shift, which is referred to as a frozen hemithorax. And remember, when we do a FDG PET, this is going to be avid. This is going to show uptake on PET. So these are the features of mesothelioma. Going ahead to the next image, a 45-year-old male with cough and dyspnea since 15 days, all are differentials except. So when we look at the images, you see these multiple tiny nodules which are called 1 to 3 millimeter tiny nodules shaped like millets. So this is miliary nodule. So remember, what are all the DDs? Again on the HRCT, can you see these very tiny nodules? These are the miliary nodules which are typically seen with miliary TB. But the other differentials, it can also be seen with histoplasmosis, it can also be seen with metastasis. It represents that there is hematogenous spread, of infection, but this is not seen in COVID-19, right? COVID-19 doesn't have a hematogenous spread. So this is not seen with COVID-19 miliary nodules. It becomes a CORAD score of 2 wherein it is atypical findings. Alright. Going ahead to pleural effusion. So a few one-liners of pleural effusion which are very frequently tested. So most sensitive investigation, remember ultrasound, or if in your options you have CT, that's also one of the acceptable answers. It's very sensitive, but frequently because ultrasound doesn't have any radiation, it scores better. Okay. Now when I ask you most sensitive chest X-ray, it will be ipsilateral lateral decubitus. So you ask the person to lie down on that same side towards the side. So ipsilateral side down, lateral decubitus. Least sensitive chest X-ray, it's going to be a supine position. So when you take an X-ray in supine, that's going to be least sensitive. And what modalities can help us distinguish a simple effusion from empyema, which is an infected effusion? Remember, ultrasound can help with this distinguishing. CECT can help with this distinguishing. Alright, so both of these can help us distinguish. So now let's have a look at the image. So this is how pleural effusion appears on a frontal projection, on a PA view, wherein what is going to happen? So the fluid is going to rise up like this. So when we have a lateral margin which is upwards, this is called as meniscus sign. Remember, the earliest feature on a PA view will be what? This angle that you see. What is this angle? This is the CP angle, which is the costophrenic angle. So this costophrenic angle will not be sharp. It will be blunted. Slowly as effusion increases, you will have this meniscus sign, also called as Ellis's S curve. So this is how pleural effusion appears on a PA view erect film. Now, when I take a lateral view, again, do you see how the anterior and posterior angles, normally they were supposed to be like this. They are also blunted and they are flattened. So this is how it is going to appear on lateral. And when we take a lateral decubitus, we'll see the fluid gravitating down. So in order of sensitivity, this is most sensitive X-ray. After that, we have the lateral view. After that, we have the PA erect view. Alright, so this is how the X-rays are in order of sensitivity. When you talk about the most sensitive investigation, this is how ultrasound will show pleural effusion. So this is the liver, and you can see here that there is this anechoic fluid. So this black anechoic fluid accumulating at the angle and the pleural surface, this is how pleural effusion will appear. Going ahead, distinguishing effusion from empyema. So we just saw how anechoic, purely black effusion will appear. If you find that there is associated pleural thickening, alright, so there is this pleural thickening which is appreciable on the ultrasound with various septations, loculations, that is referred to as empyema. So this is how empyema will appear, and on a CCT. Remember, on a CCT, we will see that there is pleural thickening and enhancement. This is the pleural thickening and enhancement that we will see which is referred to as the split pleura sign. So this is what is referred to as split pleura sign. Normally we will never see the pleura, but when it is thickened, it's enhancing, that is called split pleura sign, and it indicates empyema. Going ahead to pneumothorax. So when we talk about pneumothorax, what is the most sensitive investigation? Remember, anytime you want to see air, it's gonna be CT scan. So CT, most sensitive chest X-ray. It will be a expiratory view radiograph. Remember, for pneumothorax, an expiratory view radiograph is done. Normally, for all practical purposes, a chest X-ray is done in an inspiratory manner. But for pneumothorax, an expiratory view will help. Okay. So, how will pneumothorax appear? It will have this visceral pleural line. It will have this line demarcating the normal lung from the air. And will there be any bronchovascular markings? No, it is this complete blackness that you are seeing without any bronchovascular markings with the reflection of the visceral pleural line, and this is how pneumothorax appears. And when it increases in amount, what can it do? It can cause this contralateral mediastinal shift. It can also cause shock in the patient. So when the patient is in an obstructive shock, that is when we call it tension pneumothorax. So remember, tension pneumothorax is a clinical diagnosis based on the vitals of the patient and not a radiological diagnosis. Okay, so this is how tension pneumothorax will present. Now let's talk about the only two indications where we do expiratory chest X-ray, so that you remember. So expiratory chest X-ray, one is done for pneumothorax and secondly it is done for foreign bodies. When you have foreign bodies which are aspirated by children, again you want to do an expiratory chest X-ray to better visualize it. So these are the two indications of doing an expiratory chest X-ray. Now, what about ultrasound? So, ultrasound can also pick up pneumothorax. Remember, in the EFAST examination that we'll discuss very soon, which is an ultrasound for trauma, we do utilize ultrasound for the evaluation of pneumothorax, right, in trauma patients. So, here we can use the B mode or we can use the M mode. So, in the B mode, which is the standard mode of ultrasound, you would see presence of sliding. So, when you see that lung sliding is present, it is moving, that indicates a normal lung. When you see that the lung sliding is absent, there is no movement of the two layers of pleura, that indicates pneumothorax. When you do M mode examination and you find this, that there are lines and then there is granularity which resembles a beach, right? So these are waves and this is the beach, seashore. This is called as seashore sign. On the other hand, when you just see lines all over, that is called the barcode or the stratosphere sign, again seen in pneumothorax. Okay, so these are the signs you have to remember on ultrasound for normal lung versus pneumothorax. Okay, now what if I see air fluid level? So when you see that the CP angle is blunted, there is this level and now you have air here. So this is what is referred to as a hydropneumothorax. So remember, hydropneumothorax, when you have the blunting of CP angle, when this is the pleural space where you have this. Apart from that, as we have seen in the lung, if I see a cavity with an air fluid level, that is an abscess. If you find that there are these membranes which are floating around there, you think of water lily sign with hydatid cyst. Okay, so that is our approach with air fluid level. Now, when we talk about a few signs, continuous diaphragm sign, remember, is a sign of pneumomediastinum. So, continuous diaphragm sign seen with pneumomediastinum. So, now let's talk about all the signs of pneumomediastinum. Most of the time, pneumomediastinum can occur because of airway injury in cases of trauma, or it can also be seen with esophageal injury. Alright, so in cases of esophageal rupture, which could be Boerhaave syndrome or secondary to endoscopy, we can have pneumomediastinum. So, now what is this sign here? You will see that there is this air fold which looks like a V. This is something which is very, very commonly seen when you have esophageal rupture. Alright, so this Neclerio V sign is again one sign of pneumomediastinum, particularly for esophageal injuries. Apart from that, you will have air outlining the mediastinum. So when it outlines the pericardium inferiorly, that is called the continuous diaphragm sign. You will have the thymus in children being outlined by air, which is called the Spinnaker sail sign or the angel wing sign. Alright, apart from that, you can have vessels which get outlined by air, which is called as ring around the artery, ring around the artery or ring around the bronchus sign, which is also seen with pneumomediastinum. Going ahead, when you see this kind of an appearance wherein you have this lumpy bumpy enlargement, you see these rounded structures at the bilateral hilum as well as the right paratracheum, giving rise to the garland sign, where the lymph nodes form this garland around the heart, or basically it's also referred to as the 1, 2, 3 sign. So 1, 2 and 3 group of lymph nodes, or pawnbroker sign. All of these are suggestive of sarcoidosis. Alright, so this is sarcoidosis, and the staging that we use, chest X-ray classification scheme we use, is called the Scadding classification or the Silsback classification. So this is the Silsback or Scadding classification, wherein you have 4 stages. So in stage 1, you will have lymph nodal involvement. In stage 2, you have lymph nodes plus the lungs which are involved. In stage 3, you have predominantly lungs which are involved, and in the final stage, you just have fibrosis. So these are 4 stages which have been described for sarcoidosis: lymph nodes plus lung alone, and fibrosis. Okay, so now when we do a CT for sarcoidosis, we would see that there are these multiple nodules which are clustering. This is referred to as the galaxy sign. So remember, galaxy sign seen with sarcoidosis, and when we do a gallium scan, we would see that the parotid lacrimal glands will take up the uptake looking like a panda. So we see a panda sign. In the chest, we would see a lambda sign. Alright, so again the lymph nodes taking uptake, giving rise to a lambda sign. Alright, so this is all about sarcoidosis that you need to know. Now talking about this very important diagnosis here, when you have a neonate with respiratory distress and the typical buzzword is used wherein and the baby has scaphoid abdomen, and you see that the chest here is consisting of these multiple lucencies. This means that the bowel loops have herniated into the thorax, and to confirm, do you see this? This is the NG tube which is also going into the thorax. So this tells us that there is herniation of stomach bowel loops into the thorax, and this is a case of congenital diaphragmatic hernia. Alright, and we divide them into 2 types. So one is the Bokdelek type. So remember the mnemonic BPL, below poverty line. So Bokdelek hernia will be through a posterior defect, more commonly on the left side. So left side is more commonly involved, and this is the more common type of hernia seen in a majority of cases, like our case wherein you have the hernia happening on the left side. On the other hand, you can have the Morgagni hernia which occurs on the right side, and usually the defect will be anterior. So this is much less commonly seen. So these are the 2 types of congenital diaphragmatic hernia. Look out for these bowel loops which are going in, so they can cause this contralateral mediastinal shift. Do you see how the heart is completely replaced on the right side? So it leads to pulmonary hypoplasia, it leads to compression of the lung. Alright, so this is very important, congenital diaphragmatic hernia. One more lesion, when you see a nodule in the chest, a nodule in the lung which has fat, which has these stippled sort of popcorn calcification, I want you to think of a pulmonary hematoma. So this is how a pulmonary hematoma will appear, the most common benign lesion of the lung. It was also called as a coin lesion. On the other hand, when you see a nodule which has these spiculated sort of margins, right, a spiculated sort of margins, this suggests that it's likely to be malignant, it suggests a poor prognosis. So when they ask you evaluation of a solitary pulmonary nodule, a nodule in the lung which is less than 3 centimeters, which is not associated with anything else, it's not associated with collapse, consolidation, nothing, it is just a solitary nodule, what will be the best method to investigate? So our main concern here is whether it's benign or malignant, right? So the best investigation is going to be PET CT, because it tells us about metabolic activity. So if it is PET avid, likely to be malignant. If not showing uptake on PET, likely to be benign. So PET CT is the best. If not an option, high resolution CT. Alright. What about the gold standard? So gold standard is always going to be biopsy. So biopsy is the gold standard of solitary pulmonary nodules. Remember, for a peripheral nodule, we would do a CT guided biopsy. So remember here, CT guided biopsy is preferred for a peripheral nodule, whereas a bronchoscopic route, a bronchoscopic biopsy would be preferred for a central nodule. Okay, so this is how biopsy is planned for lung malignancies which are suspected. Finally, when you see so many nodules in the lung, this is given the term cannonball appearance. So multiple nodules can have multiple differentials, but the biggest differential here is metastasis, right? So pulmonary metastasis will be the most common differential. Apart from this, you can have various things like rheumatoid arthritis, Wegener's granulomatosis, septic emboli, which can be differentials, but the most important is going to be metastasis. Alright, so with this we come to an end for thoracic respiratory radiology. We continue with the CVS radiology portion. So the first thing we are going to discuss here is congenital heart diseases, again something which is very frequently tested. So first question that we are looking at here is radiologically pulmonary plethora is indicated by all of the following except. So when we talk about congenital heart diseases, our approach is going to be very systematic. So the first thing I want you to look at in a question is going to be whether a cyanotic patient is mentioned or an acyanotic patient. Second thing will be on the chest radiograph, whether you are dealing with a pulmonary plethora or pulmonary oligemia. This is something which is going to be very important. Pulmonary plethora implies increased blood flow through the lungs through the pulmonary artery. Alright, whereas pulmonary oligemia indicates lesser blood flow through the pulmonary arteries. Okay, do not confuse this with pulmonary venous congestion. Pulmonary venous congestion is something we would see when? It is something when there is increased backflow into the pulmonary veins, which happens in cases of left ventricular failure. Alright, so anytime LVF happens, backflow into left atrium, backflow into pulmonary veins, that results in pulmonary venous congestion. All the findings you will see in pulmonary edema. So a lot of students confuse these two. So now be very careful that in congenital heart diseases, we want to see whether pulmonary arterial flow is increased or reduced. Okay, so pulmonary plethora, increased pulmonary blood flow will be indicated by all of the following except. So descending pulmonary artery diameter more than 16 mm. So this is one criteria for calling something that pulmonary blood flow through the pulmonary artery is increased. Secondly, curly B lines. Now I want you to remember where we see curly B lines. Curly B lines are something that we see in pulmonary edema. These are lines which represent interstitial edema, which is because of the dilatation of pulmonary veins. This is not something that I would see with pulmonary plethora. Remember, these are two different aspects that we have to deal with. Next, diameter of peripheral arteries more than the bronchiole. That is also a correct statement. More than 6 blood vessels in the outer 1/3. That is also a sign of pulmonary plethora. So, a dilated pulmonary artery, peripheral arteries more than the bronchiole, and when you see that in the outer 1/3, usually we don't see bronchovascular markings. Okay, so when you find that there are more than 6 marks, that again indicates that yes, the blood flow is increased. Alright, so this is something which is very important. Now, in the exam, if you are not able to measure 16 mm, can I also say that if the descending pulmonary artery becomes greater than the diameter of trachea? Yes, that is also one thing that you can use as a reference, that it's become more dilated than that of the trachea. Okay, so this is pulmonary plethora. So now we go through the signs of congenital heart diseases that you would see. So the first case that we are seeing, let's talk about coarctation of aorta. So in a case of coarctation of aorta, because there is this persistent narrowing of aorta which is noted, that is visualized on the radiograph as this impression. Can you see that there is this impression that you can see, which is this indentation at the side of the coarctation? This is referred to as the 3 sign. We would see that on the barium swallow, the esophagus is getting indented by the dilated aorta, and then there is this narrowing at the site of coarctation. So this is pre-stenotic dilatation, post-stenotic dilatation, and this is the site of coarctation, which gives it a reverse 3 sign on barium swallow. And one more feature, because of the collaterals, because of the intercostal vessels which will act as collaterals, what we will see is, because these intercostal arteries have become very dilated due to the constant pulsation, we would find that in the inferior rib margins, there would be this irregularity. Can you notice this irregularity here? This is referred to as inferior rib notching. Okay, so this is the inferior rib notching, also referred to as Rusler's sign, that you would see in cases of coarctation of aorta. Alright, going ahead, what is this? This is something that all of you guys know very well. This is tetralogy of Fallot, right? So this is this tetralogy of Fallot, and this typical appearance is referred to as the boot-shaped heart. So in a boot-shaped heart, what is this apex? If I ask you what chamber contributes to an upturned apex, all right? So first of all, what is the heart chamber that normally forms the heart apex? So here what we are seeing is this upturned apex. So remember, anytime you see this upturned apex, it indicates that there is a right ventricular hypertrophy. This is how RVH will present as a boot shape, as an upturned apex. On the other hand, when you have LVH, it usually presents as a down and out apex. The apex usually goes like this. Okay, so this is how we basically make more sense out of the boot shaped heart. Okay, so what are the four parts, components of tetralogy of Fallot is again something you have to know. So one is infundibular pulmonary stenosis. So now tell me, when there's infundibular pulmonary stenosis, what is going to happen to the lung fields? Will there be plethora? Will there be oligemia? So here we are going to be seeing oligemia, right? Because there is pulmonary stenosis, blood flow is going to be reduced. So this is cyanotic plus oligemic. So this is one part, right ventricular hypertrophy, overriding of aorta, and VSD. These are the four components of tetralogy of Fallot which gives rise to a boot-shaped heart. Going ahead, what is this shape of the heart? First of all, we see that the heart is markedly dilated. It almost looks like a box. Plus, how are the lung fields? Are they looking whiter or blacker? If I ask you in a general term, they are appearing blacker, means that there is definite oligemia that we are seeing, right? So oligemia plus a very dilated heart, which is box shaped heart. This is suggestive of Epstein's anomaly, right? So this is Epstein's anomaly that we are seeing here, which frequently results because of maternal lithium intake, right? This is again something that has been tested very frequently. Alright, so this is about Epstein's anomaly, box-shaped heart. Looking at the next case here, again a very typical case wherein you have this figure of 8 sort of appearance. Do you see the snowman or figure of 8? So this is referred to as snowman figure of 8 heart, which is seen in what condition? So this is seen in TAPVC, which stands for totally anomalous pulmonary venous communication. So here, as the name suggests, the pulmonary veins, instead of draining into the left atrium, are gonna drain in the right heart field. Alright, so now if the route that they take is above the heart, alright, it's above the heart, that is called as supracardiac. So the type 1 is referred to as a supracardiac PVC, wherein the case that you are seeing here, you will have this snowman or figure of 8 because the pulmonary veins would join to form this anomalous vertical vein. They would form this vertical vein which connects to the brachiocephalic vein, draining into SVC. So in supracardiac type, the pulmonary veins will go through the SVC into the right atrium. In the type 2, which is a rarer type, it's the cardiac type wherein they drain directly into the right atrium. And type 3, which is the infracardiac type, the one with the worst prognosis, we will find that these pulmonary veins will go and drain into the IVC. Alright, and because of this, they have the highest chance of getting obstructed. So these patients present very early, okay, and they have a very poor outcome. So this is about TAPVC. Remember, snowman figure of 8 appearance. Now, when we don't have a totally anomalous circulation, but we have a partially anomalous pulmonary venous circulation wherein only the right-sided pulmonary veins decide to drain into IVC. Only the right-sided pulmonary veins are going and draining into the IVC. So this gives rise to this sword sort of an appearance. So this is referred to as the scimitar sign. So this is the scimitar sign which is seen with partially anomalous pulmonary venous communication. And remember, this PAPVC condition is also associated with right lung hypoplasia. So we will have associated anomalies of the right lung frequently associated, and together they are called as the veno-lobar syndrome or the scimitar syndrome, alright, also called as scimitar syndrome. So this is the partially anomalous pulmonary venous communication. Going ahead, what do we see? First of all, again you are finding that cardiomegaly is there, superior mediastinum is very narrow, and basically the lung fields, are they plethoric or oligemic? So they are quite wide, right? Can you see a lot of bronchovascular markings? So this is suggestive of plethora with a cardiomegaly which has a shape like there is an egg which is being held by a narrow string from above. So this is called the egg on string sign. So this is the egg on string sign with a pulmonary plethora that is seen with TGA. TGA stands for transposition of great arteries. So what happens here? If this is the RA, this is the LA, and this is the RV, this is the LV, basically the pulmonary artery will originate from. So we'll find that the aorta anomalously arises from the right ventricle and pulmonary artery anomalously arises from the pulmonary artery. That is why there is this complete transposition of great vessels, and remember, this is always dependent on some sort of a septum. Alright, so this will always need a septal defect in order for the child to survive. Okay, so this is about transposition of great arteries, egg on string, pulmonary plethora. Going ahead to this kind of an appearance wherein again we are having this sort of a left ventricular apex. Can you see how the heart is now down and out? This has been referred to as a sitting duck sign. So remember, this sort of a sitting duck sign is seen with what congenital heart disease? It is persistent truncus arteriosus. Alright, so persistent truncus arteriosus, we would see the sitting duck sign. Alright, so now just to summarize, apart from this, there are a few lesser known signs which haven't been tested very frequently. There's something called as Hyler dance that we see on fluoroscopy. So here what we would see is basically that because in a case of atrial septal defect, the pulmonary arteries are getting a lot of blood flow, right? So from the LA to the RA to the RV to pulmonary artery, there's a lot of blood which is going. So that is why we would find that the hilum is bounding. Alright, it's pulsating very strongly, which is called as the Hyler dance. So this is seen in the case of atrial septal defect. What about the gooseneck deformity? Again, this is something that we don't really see in practice. So this is an appearance that is given on a ventriculography. When you do an invasive ventriculography, you would see this narrowing at the level of the outflow tracts, which is called as a gooseneck deformity. This is seen with endocardial cushion defect. So what you would have is a atrioventricular septal defect, and this is frequently associated with Down syndrome, right? So remember, its association with Down syndrome. So this is the gooseneck deformity. So now just to confirm that our one-liners are in place, identify the correct pair. So sitting duct sign seen with tricuspid atresia? No, it was seen with persistent truncus arteriosus, right? So that is where it's seen. Gooseneck deformity is seen with ventricular septal defect. No, it is seen with AVS, the atrioventricular or endocardial cushion defect. Hyler dance with AST, this is correct. Egg on string for PTA? No, egg on string is seen with transposition of great arteries, right? So these are the one-liners that we need to remember about congenital heart diseases and their signs. So looking at a few more heart appearances on the radiograph, what we can see here is that there's this diffuse cardiomegaly. The shape of the heart is maintained, and you're finding that it appears like a water bottle or a money bag, right? So this sign is seen when you have pericardial effusion. So there's a sign of pericardial effusion wherein the shape of the heart, remember, will be maintained. Going ahead to the next sign, so when we do the same sign on a lateral radiograph, alright, so when we look at the same pathology on a lateral radiograph, what we are going to find is this Oreo cookie sign. So just like an Oreo cookie which has black, white and then black, so two biscuits and then cream in between. So somebody with a very good imagination thought of this and saw that here, that you have this black line which represents the epicardial fat pad, you have this outer here which represents the pericardial fat pad, and in between you have a white stripe of fluid. So remember, you know on radiograph that fat is more darker or fat is more lucent than fluid, right? So the black stripes that you are seeing are the fat layers, and in between you have the fluid, hence the name Oreo cookie sign on a lateral radiograph. Okay, going ahead to this question and this pathology, we have a 45-year-old male with easy fatigability and abdominal and lower limb swelling. What is the diagnosis? So when you look at this image, first of all, what is the imaging that we are seeing? So this is an example of a CECT, right? You can see that the bones are white. There's contrast in the heart chambers. Again, just to correlate, what is this posterior heart chamber? Remember, this is the left atrium. What is this heart chamber here? Anteriormost heart chamber. This is the right ventricle. This is the left ventricle oriented towards the left side. Okay, and what do you find? We find here that there is this very hyperdense rim. Do you see this? Which is much more hyperdense than the contrast. So what is this? This hyperdense rim is actually the calcification. So there is calcification around the heart. There is thickening and calcification of the pericardium. So this is suggestive of constrictive calcific pericarditis. Okay, so that will be our diagnosis in this case, where there is calcific constrictive pericarditis. Going ahead, so the same sign, when you have this calcification of the pericardium surrounding the heart, this is referred to as a egg in a cup sign. It's again a sign seen with CCP, calcific constrictive pericarditis. Most commonly in our cases, we will have TB or uremia, or a lot of times post radiotherapy that the patient might have received. You can see this sort of a appearance. Going ahead to the next pathology here, where we want to discuss a very important aspect, which is pulmonary edema. So when you have left ventricular failure and you have congestion which backflows into the left atrium and through them into the pulmonary veins, what are the changes that we will see? What are the changes of cardiogenic pulmonary edema? Alright, so first of all, increased heart size, because the underlying pathology is that of the heart. What you would find is, because the pulmonary veins are now getting a lot of blood, right? So normally the pulmonary veins of the lower lobes are what gets the maximum blood because of gravity. So we would find that on the radiograph, pulmonary veins of the lower lobe are seen, but never the pulmonary veins of the upper lobe. Alright, so the pulmonary veins of upper lobe are not visualized on a normal radiograph. But when I find that there is this redistribution, now the upper lobe veins are also very prominent, this becomes the earliest sign that I can see in a case of cardiogenic pulmonary edema. Slowly, I am going to see these curly B lines. Then we would find that the lungs are starting to become opaque, which is referred to as pulmonary edema per se. And then you would also have pleural effusion, right? So now going ahead to the stages. What are the X-ray findings with the corresponding change in the pulmonary capillary wedge pressure, which is an indirect marker of the left atrial pressure, right? So normally the pulmonary capillary wedge pressure is going to be somewhere around 9 to 12 millimeters. Alright, so as the pressure keeps increasing, as the disease becomes more and more severe, the chest X-ray findings will evolve. So in the first stage, in the earliest stage, when the pressure is somewhere between 12 to 18 millimeters of mercury, the first thing, as I told you, will be what? Will be the redistribution of pulmonary blood flow, wherein the upper lobar veins become prominent, and that is referred to as cephalization. That is called as cephalization, and some people use the term which is called as a reverse mustache sign here. So a reverse mustache sign is frequently used as a term here. Okay, so apart from this, a stag antler sign has also been described for the same finding. Okay, so let's see an image. So here, if you see the zoomed in image of the upper lobe, can you notice these dilated upper lobes which are appearing like a stag antler or a reverse mustache? Okay, so this is that redistribution wherein the upper lobar veins become very prominent. Secondly, when the pressure further increases, now the pressure is further on increasing from 18 to 25 millimeters mercury. Now what is going to happen is interstitial edema. There's going to be interstitial edema that we are going to see, wherein the curly lines become very prominent. Alright, so we have curly lines which become very prominent here. So what are these curly lines? These curly lines are nothing but the thickened interstitium that you are seeing as linear patches on the radiograph. Apart from this, when I do a CT of this patient, again I am going to see that the interstitium, which is the interlobular septum, remember this word, interlobular septum, becomes thickened. So I'm going to see interlobular septal thickening. Okay, so let's see how it's going to appear. So this is all the second stage wherein we see interstitial edema. Alright, so these are changes of interstitial edema. So if you look here, first on the radiograph, we'll see these lines which are the curly B and the curly A lines. So the curly B lines are seen at the lung bases as these horizontal lines. Can you see these horizontal markings? So these are the horizontal lines. One, they are seen at the lung base. On the other hand, curly A lines, they'll be lines which are obliquely oriented. So these are one, not horizontal but oblique. Second, they are around the lung hilum. So they are around the lung hilum. They are the curly A lines. On the CT, look here. Can you find these lines? Can you find these lines which are the interlobular septum? So we know that the functional unit of lung that we see is the secondary pulmonary lobule. So every pulmonary lobule, remember, will have a terminal bronchiole and the alveoli. So this is the radiological unit of lung, which is secondary pulmonary lobule, and what separates them? This is the interstitium. This is the connective tissue which separates them, wherein you have pulmonary veins which run. Okay, so these pulmonary veins, when they get dilated, can you now imagine how these lines are going to appear? So we are seeing these linear opacities which are nothing but dilated pulmonary veins, and this is described as smooth septal thickening. Okay, and slowly as the disease further evolves, everything will get opacified. We'll have these secondary pulmonary lobules getting opacified because of alveolar edema. So now when the pressure becomes more than 25 mm, I'm going to see alveolar edema, right? We will see that now the alveolar opacification begins. There's going to be consolidation. Okay, so this is the final stage wherein we would find consolidations, and these are predominantly arranged around the hilum in a perihilar distribution. So these are perihilar distributed consolidations referred to as Batwing sign. Okay, so this is the Batwing sign seen with cardiogenic pulmonary edema. So now, just to tell you, pulmonary edema, medicine wise, we divide it into cardiogenic, non-cardiogenic edema called as ARDS, right? So now, how to distinguish on the basis of the pattern? So the pattern that we have studied for cardiogenic, we saw that there is cardiomegaly, right? Whereas that would be absent in the non-cardiogenic case, quite obvious. Second, here the opacities, the alveolar opacities or the consolidation is going to be central. It's going to be perihilar, whereas it's going to be peripherally located. Multiple patches of peripheral consolidations will be seen in ARDS. Then when we talk about pleural effusion, that is going to be seen with cardiogenic pulmonary edema, but not so much with non-cardiogenic pulmonary edema. Alright, so remember, these are the changes with pulmonary edema. Talking about the next case here, so we have an elderly male with acute chest pain radiating to the back who presented to the ED. Which of the following is a possible cause of the patient's chest pain? So when we look here at this contrast enhanced CT, first of all, bones are white, vessels are white, it's a contrast enhanced CT. Your eye strikingly goes to this vessel here, which is markedly dilated. So this is the pulmonary artery. Look at this. This is a main pulmonary artery dividing into right and left. This is the descending aorta. The small vessel here which is compressed is the SVC, and what you find is that this is the ascending aorta. This is the ascending aorta which has become very dilated and it has become dissected. It has become dissected into two lumens, right? So you can see one lumen, the other lumen. The one which is appearing whiter has more density of contrast. This is the true lumen. This flap that you see, this is the intima. So in cases of aortic dissection, as you know, an intimal tear happens which flips, alright, which flips and creates a false lumen. So there is a false lumen which gets created in the wall of the aorta. So this is that false lumen. So this is the intima, this is the true lumen, this is the false lumen. You can recognize on the basis of the higher density of contrast in true lumen, and remember, the false lumen will outgrow, it will become larger than the true lumen. Okay, so this is a case of aortic dissection. We divide it surgically on the basis of two classifications. One is Stanford, one is DeBakey. So according to Stanford, you have two, Stanford A and Stanford B, Quite simply, A is anything wherein ascending aorta, A for ascending aorta gets involved. Whereas B is anywhere ascending aorta is not involved, only the descending aorta, right? So as you can see in the schematic, DeBakey has classified into 1, 2, 3 types, wherein in type 1 you can see that ascending plus descending is involved. Type 2 you have only ascending, and type 3 you have only descending aorta. Now management wise, Stanford A is going to be more useful, wherein all Stanford A dissections will get managed with surgery, emergent surgery. The Stanford B can be managed with medical management if no other complications are there. So now when we talk about investigation of choice for aortic dissection, always be very careful, is the patient stable enough to get a CT done? So if the patient is a stable patient, the best investigation is going to be a CT angiography, right? We'll go ahead with a CT angiography, look at the dissection flap. Now, if I tell you patient is too sick to be shifted for CT also, any bedside investigation that we can do to see whether ascending aorta is involved or not, because that is our priority, right? So we can do a transesophageal echocardiogram. Remember, we can do an echocardiograph and again delineate the intimal flap. Okay, so this is about aortic dissection. What about this pathology? So here you can see that this is again an example of a contrast enhanced CT. This is a Doppler image and this is again a contrast enhanced CT. So what are we seeing? First, let's focus our attention on the CT. And at the level of the abdomen, you find that this is the aorta and it's grossly dilated. It's much more dilated than its normal size, and you see this thick wall surrounding it, which is suggestive of atherosclerosis. So this is actually an abdominal aortic aneurysm. Okay, so this is an abdominal aortic aneurysm, and when you do a Doppler, any aneurysm will show you this sign which is referred to as yin and yang sign. Alright, so any aneurysm or pseudoaneurysm, because the blood is flowing within the aneurysm. If this is the aneurysm, the blood is constantly moving around in circles, right? So when we evaluate this with a probe, you will find that in one area blood is towards the probe, in one area blood is away from the probe. So that is why you will have red for towards the probe and blue for away from the probe. So that is why you see this yin and yang sign. Yin and yang, as you know, is a Chinese philosophy which tells you that good and bad go together. Like everything in life is a mixture, and that is what you are seeing in this Doppler sign, red and blue together. Okay, so this is the yin and yang sign that you see with any aneurysm. And what are the danger signs? So when you look at the imaging, this is one of the very big danger signs. When you find that now the lumen is not so symmetrical and regular as you are seeing here, right? This is the lumen, and then I'm finding that there's this large hematoma which is grown, which is containing it, which is draping the aorta. So this is actually suggestive of a contained rupture. That aortic rupture, aneurysmal rupture has already happened, but the hematoma is creating a tamponade effect and containing it. So this sign, guys, is referred to as a draped aorta sign. So this is referred to as a draped aorta sign, wherein you will see that the lumen is surrounded by this hematoma here. Okay. Going ahead to this next pathology, when you have a patient with acute chest pain, dyspnea, alright, and you find that there are certain historical factors which are telling you that either the patient had lower limb pain and swelling, or the patient had other signs and symptoms which point you to DVT, such as immobilization or a long haul flight or some hypercoagulable state, then what do? So here, remember the approach, the clinical approach. First, you want to determine a clinical score which is referred to as the Wells score or the modified Wells score that we use. This is a clinical score to determine that how likely is pulmonary embolism. So when you determine the score and the likelihood is low, that you are not very so clinically you are not suspecting pulmonary embolism, you would go with a D-dimer. So remember, in cases of pulmonary embolism, D-dimer is the screening investigation of choice. It is something which has very high sensitivity, but specificity is very low, right? So we can start with D-dimer. If D-dimer comes out positive, then we go ahead with the investigation of choice. or if the modified well score is much high and you are suspecting pulmonary embolism, you would go ahead with investigation of choice, which is what? Which is a CT pulmonary angiography. So remember, pulmonary embolism, CT pulmonary angiography is the investigation of choice. Okay, so this is how we manage, and this is the CT pulmonary angiogram that I am showing you here, wherein it's just like a CCT, but we time it in such a way that pulmonary artery gets the maximum contrast. So this here is the pulmonary artery that you can see, and both the pulmonary arteries here are having these filling defects. Can you see that there are these gray filling defects? So this is suggestive of the emboli. These are the thromboemboli that you can see here. Okay, so remember, CTPA, investigation of choice for pulmonary embolism. With this, we come to an end for CVS radiology. So now starting with the neuroradiology section. Here the most important topic that we'll be focusing on is head trauma, and you get always a certain question from the section of head trauma. So please pay particular attention to the first thing that we're going to discuss, which is head trauma and extra-axial blood collections. Before we jump into extra-axial blood collections, I just want to give you an overview about head trauma. So when we talk about head trauma, the thumb rules that we've already gone across, remember, the investigation of choice and the initial investigation, the best investigation that you will have for any patient with head trauma is going to be a non-contrast CT. Alright, but there is one exception to this, wherein NCCT might underestimate the injury or might even be completely normal. But there is one condition in which NCCT might underestimate the injury or might be completely normal, and that is diffuse axonal injury. So remember, for DAI, our investigation of choice becomes MRI. Alright, so this is one thumb rule that I want you to know at the outset. We use various indication criteria such as Canadian head CT rule, Nexus rule, NICE guidelines. So there are a whole bunch of guidelines about when to do the non-contrast CT, like we have discussed in our head trauma section. So now starting with the appearances of what will be the various pathologies and how they appear. So starting with extra-axial blood collections, 2 question marks means it's been highly frequently repeated topic. Alright, so here the main difference we need to understand is between extradural hematoma and subdural hematoma. So here in this non-contrast CT that I am showing you, we have a rare patient wherein both the EDH and SDH can be noted in the same patient. So what are we seeing here? On the right side, there is a right extra-axial hyperdense hematoma. So when I say that it is hyperdense, it is whiter than the surrounding brain, it means that it is acute, right? So we are dealing with a case of acute hemorrhage because it is hyperdense. That is the first learning point. Second, how is the shape? So when you look at the shape, a biconvex shaped or a lens shaped hematoma. On the other hand, when you look at the left side, this is a crescentric hematoma, again which is hyperdense, means they are both acute hemorrhages, right? So first note the shape, but remember, do not rely solely on the shape. That is what I have seen a lot of students do, that they rely solely on the shape, and even if it goes a bit here and there, we don't know what to do, right? So now you have to first rely on the clinical background that's been given to you, wherein in a case of acute EDH, you would have significant trauma, underlying fracture is usually noted. The patient will tell you that he has something called as lucid interval, wherein he lost consciousness, regained it again, and now he has lost consciousness again. So that brief period of regainment of consciousness is referred to as lucid interval, which is a feature of EDH. On the other hand, in SDH, you will get a history of trivial trauma. Frequently in elderly, you will get the history that the patient had a fall in the bathroom. Alright, so you will have a relatively trivial trauma. What about the source? So here the source is arterial. Most commonly the middle meningeal artery is what is involved here, whereas here it's usually a venous bleed, wherein cortical veins do bleed. Alright, talking about the most common site. So remember, when we talk about most common site, here it's going to be the squamous temporal bone, which is usually fractured, which is at the site of the pterion. Again, remember, pterional fracture, we have middle meningeal artery running there. That's why the relation. Whereas here it's mostly along the cerebral convexities, as you can see. Now coming to the most important feature, remember EDH. it is loculated like this, it is lens shaped like this because it cannot cross the sutures, right? Because the dura is attached to the sutures and is an extradural hematoma, this will not be able to cross the sutures, except for 10% cases wherein you have associated sutural fracture, it might cross. Can it cross the midline? Yes, it can cross the midline. Alright. On the other hand, SDH is a complete opposite, wherein it can cross the sutures because it's below the dural attachment, but it cannot cross the midline because of the attachment of the forks. Right. So this is why it doesn't cross the midline. So these are very, very important points. More important, in fact, than the shape per se. Okay. So that is how you approach these questions, and they are so frequently asked that you just can't miss this topic. Going ahead, what are we seeing now? So again, you can notice here that there is a hematoma which is not crossing the sutures. It is relatively biconvex in shape, so I can say that this is an EDH. Now, is it acute or is it chronic, or I cannot comment. So if we look carefully, there are hyperdense areas, there are hypodense areas. So when there are these white plus gray or hyperdense plus hypodense areas within the same hematoma, that suggests that there is an active ongoing bleed. Alright, and this sign is referred to as the swirl sign. So this is the most important swirl sign that we want to learn about. And what does it indicate? It means that there is active bleeding which is going on. It gives a poorer prognosis to this EDH and also becomes an indication for decompressive surgery. Alright, so this is how a swirl sign appears, wherein you have areas of gray plus white within the bleed. Going ahead to the next topic. So when we look at this case here, first of all, what do you think? Is it an acute hematoma or a chronic hematoma? So we can see that this is hypodense, this is not acute. So this is a chronic hematoma. Now, based on the shape, what do we feel? Is this limited by the sutures? Not really. This is crossing the sutures, not crossing the midline, crescentric shape. This is indeed SDH, and you also see an associated linear fracture here which is seen, right? So this is an example of chronic EDH. Going ahead, when you see hyperdensities within the basal cistern, so this is referred to as the basal cisterns, which are called as the star of death appearance. So this is the star of death that you can see, which is the star shape, this is the stellate shape that the hematoma assumes at the level of basal cisterns, and you also see these linear punctate hyperdensities in the sulcal spaces. So this is basically indicative that there is now acute hemorrhage within the subarachnoid space. So this is how acute subarachnoid hemorrhage is going to appear. So remember, overall, when we consider the causes of SH, most common cause is going to be trauma, followed by aneurysmal rupture. So a case of non-traumatic SH, aneurysm rupture, but in cases of trauma, overall it trumps the aneurysm as the most common leading cause of subarachnoid hemorrhage. Alright, so remember, this is what is acute SH. What about this? So here you can see that this is the level of the bilateral lateral ventricles, the body of the lateral ventricles, and you see that instead of CSF, there is hyperdensity here, right? So this is suggestive of intraventricular hemorrhage, which is hyperdense, hence acute intraventricular hemorrhage. What are these? So can you see that within the brain you are seeing these multiple heterogeneous hyperdensities surrounded by these gray areas which suggest surrounding edema. So when you see these hemorrhagic foci within the brain, this is intracranial, and you have surrounding edema, this is how contusions appear. They can be of two types. They can be hemorrhagic or they can be non-hemorrhagic. So what do you think is this type? This is indeed the hemorrhagic type. So when you see these hyperdensities, it is hemorrhagic. If you just find the edema, that is a non-hemorrhagic contusion to the brain. And most important question, where in the brain do we find these contusions most commonly? So most commonly these are located at the frontotemporal lobes. Alright, so at the frontotemporal lobes is where you would find these, because at the skull base, here in the basifrontal location, anterior anterior and medial temporal lobes, we are going to find that there are a lot of bony projections at the skull base, like the sphenoid wing, like the petrous apex, which will cause this impact with the trauma. Anytime there is head trauma and there is impact, what's going to happen is these bony projections will strike against the brain, and that might lead to these contusions. That is why these are the favored areas for the contusions. Remember this concept. And also one more point about this is, a lot of times they will be associated with Coop counter Coop injury, right? So what happens in Coop counter Coop injury is, if you have direct trauma here, right, you will also have associated trauma because of counter Coop mechanism, because of striking back diagonally opposite to this lobe. Alright, so this is how usually Coop counter Coop injury presents. Going ahead to the most important case that you will be getting in your exams, wherein you have the history that there's a high energy trauma, a road traffic accident which has happened. The patient has a poor GCS score, alright. So neurologically, patient is not doing so well, patient has a poor GCS score. But when you go ahead with the non-contrast CT, either it appears normal, or you are seeing very tiny hyperdense foci, or petechial hemorrhages might be the word that they might use. So how do they appear? Do you see these very tiny little white spots which are predominantly at the gray matter white matter junction, right? So this is the most common site of diffuse axonal injury. So this is the shearing of the axons resulting in their injury, which results in tiny microbleeds. Okay, so remember, so CT is not sensitive to pick up diffuse axonal injury, and as we have discussed, what is the investigation of choice to pick up diffuse axonal injury? It is going to be MRI. So MRI is the best investigation. This remains the exception to head trauma, wherein MRI becomes a better investigation than CT. So which sequence on MRI? So here I want you to remember that a gradient T2 sequence, which might be referred to as T2 star, or they might give you SWI, which stands for susceptibility weighted imaging. So this sequence basically will pick out all the areas wherein the iron, the hemosiderin, is deposited and show them as these black foci that we call as blooming. So these are referred to as blooming foci. Alright, so this is the sequence of choice which will pick up these tiny hemorrhages. And is there any staging system that we use for diffuse axonal injury? Yes, so there is the Adams staging that we can use, wherein stage 1 to 3 the prognosis becomes poorer, the severity keeps increasing. So the first stage we will have these petechial hemorrhages at the gray matter white matter junction. In the stage 2 the corpus callosum gets involved, and in stage 3 you have shearing of axons, white matter injury in the brainstem tracts. Alright, so this is how Adams staging is done for diffuse axonal injury. Remember this typical presentation, it's very important. Going ahead to the next case, so what do we find here? This is again a CT scan, and you can see that there is this air which is accumulating in the anterior aspect of the brain and the frontal lobe here. Can you see how the frontal lobe is tethered like a mountain? So this tells you that the brain is under pressure, the brain is under tension. Alright, so based on the shape which looks like a mountain, it's been called as Mount Fuji sign because of these tethered cortical veins, and the diagnosis in this case is going to be tension pneumocephalus. So remember, pneumocephalus is frequently associated with sinus injury, right? So paranasal sinus getting injured or mastoid air cells getting injured, if they are fractured, there will be this air which is coming into the brain. So you always have to rule out these fractures in any case of pneumocephalus. Going ahead to one very important case scenario. So next, talking about a very important case scenario wherein, so after trauma you have the history that there is pulsatile proptosis. Alright, so very typical history which suggests a diagnosis of carotico-cavernous fistula. So there is a fistulous communication between the carotid artery and the cavernous sinus. So we have the internal carotid artery which runs through the cavernous sinus, which is called as the cavernous segment of ICA. So if there is a tear there and it communicates with the cavernous sinus, this is the carotico-cavernous fistula. So now we have an artery which is leaking into the cavernous sinus. So the cavernous sinus is going to be congested. So the first CT sign that I will see is that the cavernous sinus appears congested, right? It is increased in volume on the ipsilateral side. Now, because it is getting too much arterial blood, it is going to send that blood across to its tributaries, which is the superior ophthalmic vein. So, can you see here how in the right orbit you can see this dilated venous structure? So, this is the dilated superior ophthalmic vein that you will see in the case of caroticocavernous fistula on the CT. When I ask you what is the gold standard, remember the gold standard is going to be a digital subtraction angiography. So when we do a digital subtraction angiography, so this is the internal carotid artery, this is the cavernous segment, you will find that there is this leak, there is this leakage of the contrast into the cavernous sinus, alright. So you would see the direct fistula, so it has the highest accuracy, plus it has therapeutic potential, alright. So remember, it is the gold standard because we can put in a balloon here, we can put in a coil and block that tear, block that fistulous communication. Alright, so these are salient features of CCF that you need to remember. Now, let's talk about brain tumors. In general, when I ask you about brain tumors, what is the investigation of choice? Remember, it is going to be contrast enhanced MRI as we have learned in our thumb rules, right? So, it's going to be contrast enhanced MR. Now, let's talk about the most important tumor. You need to know the imaging features too. So, this happens to be the most common benign tumor in adults, right? So, what is the most common benign tumor in adults? Talking about meningioma, right? So, meningioma, the imaging features are going to be very important. So, when we do a contrast enhanced MR, what do you see? You see a very hypervascular mass. So, remember, it is going to show a lot of enhancement. Where is it located? Can you see that this is the fox cerebri and it's located along the fox. So, it is going to be along the dura. So, can I say that it is dural based? Yes. Then, what is this very typical feature? Can you see how this mass has a dural tail? This is very important. So, it extends along the dura because that is the origin, right? So, meningiomas, remember, originate from the arachnoid cap cells. This is also a question that can be asked. So, they arise from the arachnoid cap cells and they have this dural tail. These are the features you will find on MRI. Some more important features that you can find on CT. So, we know that CT is better to pick up calcification. CT is better to look at bony changes, right? So, here what do you find? This is a case of meningioma where you find that the bone is expanded. So, CT feature is going to be hyperostosis when the bone is expanded. Secondly, you can also find calcification in a case of meningioma. When you go ahead and do a DSA, again you get a few questions. So, on DSA being very hypervascular, you will see a sunburst or a spoke wheel kind of pattern of enhancement of the vessels, and you would also find that the contrast comes in very early, goes very late, and this reminds us of a mother-in-law. So, that is why this interesting name where it is called mother-in-law phenomenon, wherein because of hypervascularity, contrast will come in very early in the arterial phase and it will be retained in the tumor, alright. So, it leaves very late. So, this is the mother-in-law phenomenon. So, these are all the possible questions that they can put up to you for meningioma. Going ahead to the next important tumor, what do we see here? So, when you look at this MR here, can you notice this very heterogeneous mass here which has some hypo enhancing areas, some enhancing areas, and you find that it has this typical appearance called the ice cream cone appearance. So, this is described as the ice cream cone sign. One more area where we see the ice cream cone sign, remember on a CT, a normal CT of the middle ear, you would find that between the malleus and incus, between the maleo-incudal joint, you have the ice cream cone appearance which gets formed. Coming back here, so what is this tumor and why is it having this shape? So, if you notice, this is the pons, these are the two cerebellar hemispheres. So, this is a tumor of the CP angle, and when it enters the internal auditory meatus, it tapers, alright. So, this is how basically the CP angle schwannoma will appear. So, this is the typical sign of a vestibular schwannoma or a cerebellopontine angle schwannoma, wherein the cone is basically going to be the tumor in the CP angle and it tapers when it reaches the internal auditory meatus. Alright, so remember the most common nerve that it arises from is going to be the inferior vestibular nerve, right, as we study in ENT. So this is about CP angle schwannoma. Remember, neurogenic tumor, it's going to be very heterogeneous in its appearance, and we remember ice cream cone sign. When you see bilateral of these tumors, it becomes diagnostic of what syndrome? So remember, bilateral vestibular schwannomas is diagnostic of neurofibromatosis 2. So now looking at the next case here, this is a very typical image that has again been very frequently tested. So if I tell you that this is a child who's complaining of visual field defects, this is a clinical background that's been given to you, and what you notice is that there is a supracellular mass, right? So when you see a supracellular mass in a child, always look out for what is this. So on the CT, can you see that there is this coarse calcification in the mass? So one feature, calcification, very important. Second feature, what do you notice here? We see that there is a cystic component. So the mass is actually cystic with presence of calcification. If we do an MRI for this patient, we would find that there is T1 hyperintensity, right? There is T1 hyperintensity, which is because of the presence of wet keratin that you see histopathologically, and we know that protein appears T1 hyperintense. Okay, so these are all the features that you would see in a craniopharyngioma. And which histopathological type of craniopharyngioma will show us all of these features? It's gonna be the adamantinomatous type. Alright, so adamantinomatous type of craniopharyngioma will show us these features. Okay, so remember all of this is very typical appearance of a craniopharyngioma. So this is how craniopharyngioma appears. So now when I tell you that this is the MRI of a child, and what we are seeing here is in the location of the fourth ventricle. Can you notice that in the fourth ventricle here, we are seeing that there is an expansile mass. So when you see a posterior fossa tumor or a fourth ventricle tumor, two possibilities we need to consider. One, it can be a medulloblastoma. The second possibility is that of an ependymoma. Now it's very difficult to distinguish them all the time because they have a lot of overlapping features. Both of them occur in the fourth ventricle, both of them occur in children, but there are a few clues that we can use to distinguish. So first, in the age group, remember medulloblastoma more common in the younger children in the first decade, whereas in the second decade ependymoma will have a higher predisposition. Apart from that, medulloblastoma, remember, will be slightly more homogeneous. Alright, it will be more hypercellular and it will show more diffusion restriction because it is more hypercellular. On the other hand, an ependymoma is going to be more heterogeneous with the presence of calcification, hemorrhage within it. Okay, apart from that, when we talk about the location within the fourth ventricle, medulloblastoma is more common in the roof, whereas ependymoma is more common in the floor of the fourth ventricle. So these are the various features that you can use to distinguish. Remember, both of them can produce drop metastasis. So drop metastasis are metastasis from the tumor which will go and outline the spinal canal. So when you have spinal metastasis, they are referred to as drop mets. Going ahead, the most common benign tumor of children. So when I asked you this question, again in the infratentorial region, so most common benign tumor in children is this tumor, which is pilocytic astrocytoma. So this is a WHO grade 1 tumor, alright, which presents as this very typical cyst with mural nodule. Can you notice here how there is predominant cyst and then there is a central nodule which is attached to the wall. So this is referred to as a cyst with mural nodule, and when we do a contrast enhanced MRI, what would you find? You would find that this is the tumor which is not showing any enhancement, and this is the enhancing focus within the tumor, which is the solid nodule. So when you find this typical cyst with mural nodule in the cerebellum, remember, independently in a child, pilocytic astrocytoma. So apart from that, one more thing to be kept in mind. When you find that it's an adult, it's a case of a syndrome wherein you are having associated pheochromocytoma, you are having associated clear cell RCC. I want you to think of hemangioblastoma. So cerebellar hemangioblastoma will also appear as a cyst with mural nodule in a case of von Hippel-Lindau syndrome. So in this case, we want to rule out VHL, chromosome 3p mutation. Alright, so this is something I want you to remember. With cyst with mural nodule, child in the cerebellum, juvenile pilocytic astrocytoma. In an adult, think of hemangioblastoma. Alright. Going ahead to this next tumor, which is the most common malignant tumor in adults. So what is this typical appearance? This is where a very aggressive, do you see how heterogeneous it is, how necrotic is the center? Only the periphery showing this enhancement, which is very irregular, very infiltrative. So this appearance, when the tumor crosses the midline through the corpus callosum invasion involving the contralateral lobe, this is referred to as the butterfly appearance, and this is seen with glioblastoma multiforme, now referred to as glioblastoma, right? So this is glioblastoma. Again, it has a high predisposition to cause drop metastasis and cross over to the contralateral side. WHO grade 4 tumor, very poor prognosis, right? So this is about glioblastoma. So now we want to talk about stroke. So here, remember, when we talk about stroke or any patient who presents to you with acute irreversible focal neurological deficit, it is stroke unless mentioned otherwise. And the initial investigation of choice, the first thing you want to do in such patients is going to be an NCCT of brain. Now NCCT of brain is predominantly to distinguish the ischemic type of stroke versus the hemorrhagic type of stroke, wherein we know that acute hemorrhagic stroke is going to be hyperdense on a non-contrast CT. Ischemic stroke can show us certain features, but it might be normal in early cases as well. So our main aim of doing the non-contrast CT, remember, is to pick up this acute hemorrhage. But when the examiner will ask you a very specific question, that what is the best investigation to pick up ischemia, or to pick up an ischemic stroke, what is the most sensitive investigation? Then you say that it is MRI. So MRI is the most sensitive sequence to pick up ischemia, predominantly the diffusion weighted imaging sequence. Alright, so remember, this is the most sensitive sequence for detecting ischemia. So let's see, how will NCCT show us an ischemic stroke? So if there are to be signs of ischemic stroke, remember, it might be normal, but what will be the subtle signs that you can pick out in a case of ischemic stroke? So first of all, in the vascular territory which is affected, for example, if you see here, can you see that this is the territory which is affected? So this corresponds to the middle cerebral artery territory, wherein you are seeing that there is this hypodensity. The gray matter white matter differentiation gets lost. This is because of the edema. Alright, so there will be edema in that particular vascular territory, and if it is an MCA stroke, you would also find that I can't really make out the basal ganglia. So that differentiation is also lost. So the signs we would see is a blurred basal ganglia sign. You would see that the gray matter white matter differentiation is lost, and an insular ribbon sign. So again, when we go to the location of the Sylvian cistern, you would have the edema of the insular cortex here. So that is again referred to as insular ribbon sign, wherein the insular cortex becomes edematous in a case of MCA territory stroke. Again, if you can see an acute thrombus, so a lot of times the MCA, because of the presence of acute thrombus, can appear hyperdense, and this is called as hyperdense MCA sign. Okay, so these are the various signs which will be describing ischemic stroke on a non-contrast CT. So when we talk about venous sinus thrombosis on a contrast enhanced CT, can you see this? So this is called a CT venography, wherein we would find that within the enhancing venous sinus, you would have this area of filling defect. So when you find this triangular area of a filling defect, that is called as the empty delta sign. So this is referred to as an empty delta sign, which is a filling defect within the which sinus? Within the superior sagittal sinus. So this is the area of the superior sagittal sinus which is not showing us enhancement suggestive of thrombosis. If we do a non-contrast CT, I would actually find that here the thrombus is appearing hyperdense. Just like we saw with the MCA wherein the acute thrombus was hyperdense, here again we would find that the thrombus is hyperdense, and that is also been referred to as a cord sign. Okay, so these are two signs that we will see, wherein the CECT will show us an empty delta while NCCT would show us that hyperdensity, which is the thrombus per se. Going ahead to the next case. Now when we talk about acute hemorrhage, how will it appear? So as we have seen with trauma also, acute hemorrhage is going to appear as this hyperdensity. So here can you see this hyperdensity within the basal ganglia in the gangliocapsular location. So this is the caudate nucleus, this is the lentiform nucleus on the normal side, and you can see that in the outer aspect, in the lateral aspect of lentiform, which is the putamen, you are having this hemorrhage here. So this is occupying the putaminal region. So now when I ask you the most common cause of acute hemorrhage in elderly, remember it's going to be hypertension. Hypertension is the most common cause, and the site that it involves the most commonly is the one that you are seeing here, which is the putamen. Most common cause in young, remember it is one, AV malformation. Alright, so arteriovenous malformation rupturing is the most common cause of hemorrhage in young adults. And one more cause is going to be drugs like cocaine. Alright, so drugs like cocaine will increase the sympathomimetic action and it can lead to hemorrhage. So these are two common causes of acute hemorrhage in the so these are two common causes of acute intracranial hemorrhage in young patients. Going ahead, so how would arteriovenous malformation appear, that we call as AVM? So as the name suggests, it is an abnormal communication between the artery and the vein via these dysplastic cluster of vessels that is referred to as nidus. So this is called as nidus, which is the hallmark of an arteriovenous malformation. And when these dysplastic vessels rupture, it will lead to this acute intracranial hemorrhage that you are seeing here, which is frequently going to be lobar. Alright, so unlike hypertensive hemorrhage, it won't be subcortical, but it will involve the cortex wherever we see the cluster of vessels. So when we go ahead with a CT angio, you would find that there is this abnormal nidus of vessels. Do you see this multiple cluster of vessels which are very abnormal? So this is how AV malformation will appear. Remember one additional point, that we use a Spetzler-Martin grading for this AV malformation, which involves the size of the AV malformation, the draining vein, and the type of brain area that it involves. So that is called as whether eloquent cortex is involved by the AVM or not. So depending on these, we give it a grade, which is Spetzler-Martin grading. When I ask you what is the gold standard investigation for AV malformation, remember it is going to be digital subtraction angiography, which is DSA, and the hallmark that you would find. Again, do you see this? This is the internal carotid artery, and you see that there is this abnormal cluster of vessels, which is the hallmark called the nidus, and you see that it's draining into the deep venous sinuses. So this early opacification of veins, these nidus, is the hallmark that tells you that this is indeed AV malformation, and this is a very, very important image for your exams. Going ahead to the next image. So now looking at this MRI image, this is a gradient image wherein can you see this very hypointense heterogeneous sort of a lesion? This is called as the popcorn lesion of the brain. So remember, this is a popcorn lesion which is a cavernoma. Alright, so this is the cavernous angioma or a cavernoma, which is a vascular malformation of the brain. Alright, so this is cavernoma. When you get this typical history of a neonate who presents with a high output cardiac failure, and you hear the presence of an intracranial bruit, and this is the CT angio that has been provided to you, you find that there is this large venous structure, abnormally dilated vein that you are seeing, which is draining here into the straight sinus. This is basically the vein of Galen malformation. Alright, so this is very, very typical, multiple times asked question, vein of Galen malformation, which is actually the presence of an arteriovenous fistula. Alright, so this is actually a misnomer wherein it's not a malformation, there is no nidus, but congenitally. Alright, you would have an intracranial AV fistula between the arteries and the vein, and because of that this vein of Galen becomes very dilated. Okay, so this is because of an intracranial AV fistula, and this is the dilated vein of Galen that you are seeing here. So remember this typical case scenario, this midline dilated vascular structure which gives you a bruit because of this fistulous communication between artery and vein. This is a vein of Galen malformation. What is this sign? So we are seeing a DSA image, and you can see here that this is the ICA, and here you can see that the ICA is completely replaced by these multiple collaterals which give it an appearance of a puff of smoke. So this is the puff of smoke sign, and the disease that we are discussing is indeed the Moya disease. So this is Moya disease which shows us the puff of smoke sign. Staging system for this disease, remember, is going to be a Suzuki staging. So you can just remember that a Suzuki staging is used for this. And as far as there's a superficial temporal artery, middle cerebral artery bypass. So a bypass communication is performed between these two so as to exclude this abnormal stenotic area. So remember, Moya disease, wherein you see this appearance which is puff of smoke on the DSA image. Going ahead to infections now. So now we discuss a few important brain infections. So when we see this MRI here, this is a T2 weighted MRI, we see that the CSF is white. What do you notice? We see that there are these multiple, this is starry sky appearance that you are seeing, and there are these multiple lesions which have a T2 hyper intense signal intensity. So can I say they are cystic? Yeah, and they have a very important feature wherein all of them show this scolex in the center. So this is the hallmark of neurocysticercosis. So this is how neurocysticercosis appears, and there are 4 stages that we have in the evolution of NCC that is described as the Escobar staging. So remember, we use the Escobar staging for neurocysticercosis. So now talking about the various stages of neurocysticercosis according to the Escobar staging. So the first stage is going to be the vesicular stage, wherein you find that there is no edema. We are just seeing the cyst and the scolex. We are seeing these lesions, but there is no edema. So when there is no edema, remember, the patient might be asymptomatic. So here there could be no clinical features. When you give contrast, there will be no enhancement. Going on to the next stage, now when the cyst basically ruptures, you will have surrounding inflammation, you will have surrounding edema, and you will have enhancement on post-contrast images, and this is when the patient will come to you with focal seizures or generalized seizures if you have multiple lesions. Okay, so this is the second stage, which is the active stage, which is the colloid vesicular stage. In the third stage, when the cyst is starting to die, we have the dying larva here, which is called the granular nodular stage, wherein now the edema starts to reduce, enhancement starts to reduce, patient can still be symptomatic, but slowly the healing calcification is starting to appear. So here, can you see these multiple ring enhancing lesions? So this is how NCC will appear, as multiple ring enhancing lesions. And finally, in the inactive stage, we will have complete calcification. So again, there's going to be no edema, no enhancement, patient will be asymptomatic, and all you would find is these multiple hyperdense spots, which are these calcified cysts. Alright, so this is the inactive stage, which is the 4th stage of the disease. Now let's have a look at the next infection, very important for our setting, wherein we find that there is a triad on a contrast enhanced MRI in the patient suspected to have meningitis. I find that there are these thick basal exudates. Do you see this enhancement at the basal cisterns, reminding us of the star of death appearance we had seen with SH? So this is basically again these thick basal exudates which have collected. So when you have the basal exudates, we have the circle of Willis which lies here. So do you think there can be associated vasculitis? There could be associated ischemic infarcts? Yes. So this is why you have vasculitis and infarcts which can be associated, and because of CSF flow being hindered here, you can also have hydrocephalus. So this triad of findings is very typical for tubercular meningitis. So this is the triad of TB meningitis. When we talk about tubercular parenchymal lesions, or I talk about tuberculomas, one of the biggest differentials is going to be neurocysticercus, because both of them present as ring enhancing lesions, right? Both of them can be present as ring enhancing, which is peripherally enhancing lesions. So how to distinguish? First point, tuberculoma is going to be very T2 hypointense, whereas NCC we saw was T2 hyperintense with a central scolex. When we do MR spectroscopy, so you got a question based on this in the AIMS entrance. So I'm just telling you about this. If we do an advanced modality called spectroscopy, we would find that there's a lipid lactate peak that you see in a case of TB. So this is the only thing you need to know, that a lipid lactate peak would favor a tuberculoma. And the location, while NCC is more common in the grey matter white matter junction, remember TB, tuberculomas will be more common around the brainstem, and they would show conglomeration because of presence of caseous necrosis. They would be merging into one another. There would be this conglomeration that you would see. So this is about distinguishing tuberculoma from NCC. Now let's talk about a very important scenario where you have a case of HIV/AIDS and you have a space occupying lesion. So based on the buzzwords, based on the important words that I am telling you, we can reach the diagnosis. So when you see that bilateral basal ganglia is involved, there are target lesions wherein again you have ring enhancing lesion with this central target here, ring enhancing lesion, and on the MR spectroscopy you have a lipid lactate peak. I want you to think of toxoplasmosis. Alright, so when we go ahead to see the image, can you see that there are these bilateral basal ganglia ring enhancing lesions with this central enhancement? This is toxo. Again, you have a history of bilateral basal ganglia involvement with a T2 hyperintense lesion. The buzzword is going to be soap bubble lesions, and you also have increased opening pressure if there is associated meningitis. So here I am talking about cryptococcus, right? So remember, cryptococcomas or cryptococcal infection will present as these multiple T2 hyperintense soap bubble lesions on the MRI images. And finally, when you have a periventricular solid enhancing lesion, alright, which shows diffusion restriction, which shows a choline peak. So on MR spectroscopy, a choline peak indicates that there is a tumor, there is cellularity, alright. So this is a feature that is seen with lymphoma. So this is a feature of CNS lymphoma, alright. So this is how it will appear, a solid solitary enhancing tumor in the periventricular location. So this is a primary CNS lymphoma typical appearance. So this is how we approach cases with HIV/AIDS. Talking about the next set of images here, so very typical image on a flare sequence, we find that there are these perpendicular T2 hyperintense bands radiating in the periventricular location. This is referred to as Dawson fingers, and this is very typical of multiple sclerosis. Apart from that, we'd also find that on a contrast enhanced MRI, this asymmetrical involvement of the optic nerve. So you can also find optic neuritis, and remember the investigation of choice for optic neuritis, contrast enhanced MR, wherein you find this enhancing thickened optic nerve. Going ahead to this very important case scenario where you will be given this history that the patient had hyponatremia or the patient was a chronic alcoholic, and we had a vigorous correction, a rapid overcorrection of that hyponatremia that would result in osmotic demyelination syndrome. So you would find that in the pons, in the central pons, there is this hyper intensity because of demyelination. This was previously called as central pontine myelinolysis, but now it's referred to as osmotic demyelination syndrome, and this sign of the central pons getting affected is called the trident sign or the batwing sign. Okay, Talking about the next sign here, when we see that the midbrain is hyper intense and shows this face of panda sign, you have this clinical picture of Kieser-Fleischer rings. We are talking about Wilson's disease. So remember, face of panda, midbrain, Wilson's disease. When we see this kind of an appearance wherein the midbrain is stretched, you see that the superior cerebellar peduncles are stretched like this. The fourth ventricle is dilated. This is suggestive of a molar tooth sign, and this is seen with a syndrome called as the Joubert syndrome. So this is associated with Joubert syndrome. When we see this kind of an appearance of optic nerve, wherein the optic nerve is seen separately, but there is an enhancing soft tissue around it, as you are seeing in the left orbit here, this is called as the tram track sign, and optic nerve is seen separately. So the diagnosis here is going to be an optic nerve meningioma, and remember, optic nerve meningioma is associated with NF2, neurofibromatosis 2. So I want you to remember for NF2, Miss Me is the mnemonic. So we have multiple inherited 3 tumors. Schwannoma, as we have seen, the ice cream cone appearance. There can be meningiomas, there can be ependymomas. Alright, so all of these tumors are associated with NF2. On the other hand, when you see this kind of a tumor involving the optic nerve, where it's a fusiform dilated mass, optic nerve is not seen separately. This is an optic nerve glioma, and optic nerve glioma, in contrast to the meningioma, will be seen with neurofibromatosis 1. Alright, so this is what I want you to remember. Finally, when we talk about not the optic nerve but the muscles, do you see how the extraocular muscles here, the medial rectus is expanded but the tendinous insertion is spared? So this appearance is called the Coca-Cola sign, and this is associated with thyroid ophthalmopathy. And remember, the order of appearance, involvement of the muscles can be remembered by I am slow, wherein the first muscle to be affected is inferior rectus, then middle rectus that you are seeing here, superior rectus, lateral rectus, and finally the obliques get affected the last. So this is how thyroid ophthalmopathy appears, giving rise to this Coca-Cola appearance. And one thing to remember here, if you don't have this tendinous sparing, 1DD will be inflammatory pseudotumor. Alright, so inflammatory pseudotumor is one differential for eye muscles, extraocular muscles becoming bulky like this, but you won't have the typical Coca-Cola sign. So this was all about neuroradiology, a brief capsule of the most important topics that we have taken. So now continuing with the GI radiology portion. Let's start with the first image, which is very frequently repeated in the exams, which is that of a diverticulum which is being shown on a barium swallow image. Alright, so there's a barium swallow. You would be given the history that this is an older elderly male patient in his 50s, 60s who's complaining of recurrent regurgitation, halitosis. So what is the likely diagnosis? So now when we look at this is the cervical esophagus, and you can notice here that there is this outpouching. This is a posterior outpouching. You can see the vertebral bodies here, right? So we are seeing that it is posterior and it is a lateral outpouching. Alright, so if we look at an AP projection, you would find that it's a lateral outpouching as well. So a posterolateral outpouching from the cervical esophagus. Remember, we are talking about Zenker's diverticulum, right? So you know that Zenker's diverticulum is a false diverticulum. This is not true. All the layers of the esophagus are not going to be herniating out. So this is a false diverticulum, and it occurs between the two parts of inferior constrictor, that is above the cricopharyngeus and below the thyropharyngeus. So if you notice here from the barium swallow, can I get an inkling of this same fact? Yes. So if you look here, this is the narrowest part. So this is the cricopharyngeus, and you are seeing that this is the outpouching above it. Alright. So this is the typical feature of Zenker's diverticulum: cervical, posterior, lateral, and it's a false diverticulum. In contrast, you have a Killian-Jameson's diverticulum, which is the polar opposite of Zenker's, wherein it occurs below the cricopharyngeus and enterolateral. Alright, so this is an anterior diverticulum which arises below the cricopharyngeus. Alright, so do not confuse the Killian-Jameson's diverticulum with this Killian's dehiscence. This space where the Zenker's diverticulum protrudes out is called the Killian's dehiscence, but Killian-Jameson's diverticulum is different. Alright, going ahead, when you see the circumferential narrowing on a barium swallow, this is referred to as a ring. Alright, so remember it's going to be circumferential and usually it will be asymptomatic, but if it causes a lot of narrowing, it can cause symptoms, it can cause dysphagia, particularly to solid food, and this is referred to as a steakhouse syndrome. Alright, so this is the steakhouse syndrome, wherein if you take solid chunks of steak or any sort of solid large chunks can get stuck here, and that can result in dysphagia. Alright, now there are two kinds of rings. One is the B ring, which occurs at the G junction, and the second one is the A ring, which occurs slightly proximal to it. Alright, so if you see this is a G junction, this is a Schatzky B ring, which is most common. Alright, and it's associated a lot of times with hiatal hernia. Alright, so it's associated with the protrusion of the G junction above the diaphragm, as you can see in this case where this is the diaphragm. You can also see a component of hiatal hernia. Alright, so now talking about the next case, which is a diagnostic differential of a ring, which is called an esophageal web. So when you have this typical history that there's a female complaining of dyspnea on exertion, or a female with iron deficiency anemia, right, then you think of a triad involving esophageal web. So a web, remember, is not a circumferential narrowing, it's a mucosal web. It's a mucosal shelf-like structure which arises from the anterior esophageal wall. Frequently this is located in the cervical esophagus, and the triad with which it is associated, that is iron deficiency anemia, esophageal web, and atrophic glossitis that you are seeing here, this is referred to as the Plummer-Vinson syndrome. This is the Plummer-Vinson syndrome, also referred to as Patterson-Kelly-Brown. So these are the two things you want to remember, and also remember here there is a higher risk of hypopharyngeal CA. There is a higher risk of hypopharyngeal carcinoma that is there associated with this esophageal web. So here in this barium swallow, you can see that at the lower esophageal sphincter there is a smooth tapering that you are noting, and rest of the esophagus is markedly dilated. So when you have two patients who are coming off complaints with dysphagia, one patient telling you that I have dysphagia which is more with liquids than solids, or he's telling you that the dysphagia is equal with liquids or solids, and there's one person who comes to you telling that my dysphagia is more when I take solid food, but liquids I am able to manage. So what does this tell you? So when we talk about such a dysphagia wherein solids can pass through because of the pressure but liquids are more worse off, this is suggestive of a functional obstruction. This is suggestive of a functional obstruction or a motility disorder, right? On the other hand, when it's solid more than liquid, it tells you that there's a mechanical obstruction, there's a mechanical narrowing that you are dealing with. Combine it with the image, when you find a smooth tapering at the distal esophageal junction, this is typical for achalasia cardia. On the other hand, when you find that there is this irregularity, there is shouldering of the proximal esophagus, this is suggestive of carcinoma. Two eponymous names you need to remember. This is smooth like a bird beak, so this is called the bird beak sign. This is very irregular, likened to a rat's tail, so this is the famous rat tail sign, right? So this is how we approach these two very commonly asked questions. Going ahead, when you see this kind of an appearance wherein you are seeing a lot of contractions happening within the esophagus, assuming the shape of a corkscrew, this is suggestive of diffuse esophageal spasm, right? So this is diffuse esophageal spasm. Remember, for all motility disorder, achalasia, diffuse esophageal spasm, nutcracker esophagus, now called as hypercontractile esophagus, investigation of choice is going to be what? It's always going to be manometry. And also a better answer here would be a high resolution manometry, and the classification scheme is the Chicago classification that we use for the motility disorders. So this is the corkscrew sign. Going on to the next image, a 6-week-old baby presents to the ED with severe dehydration. Ultrasound is done and this shows the following. So what are you seeing here? So this is the liver on the ultrasound. This is the liver, and you can find here that this is the pyloric muscle. Can you see that the pyloric muscle is markedly thickened? So when you see an increased length of the pylorus with thickened muscles, this is suggestive of congenital hypertrophic pyloric stenosis, and the procedure that we do for this is called Ramsted's pyloromyotomy. Alright, so that is the correct answer. A LAD procedure, remember, is done for malrotation, whereas Swenson and Soave, as you have learnt in surgery, are useful for Hirschsprung disease. Okay, so now talking about CHPS or IHPS. So this is congenital or infantile hypertrophic pyloric stenosis, where the pylorus undergoes hypertrophy, the muscle, and so because of this, every time that the child feeds, he will have projectile non-bilious vomiting, right, because of gastric outlet obstruction. So this is the typical history that you will have. The child is always hungry, child is very malnutrition, very weak. Okay, and remember, investigation of choice to see this hypertrophic muscle is indeed the ultrasound that you are seeing in front of you, and we use a criteria to determine the length and the transverse diameter of the pyloric muscle, wherein a length of more than 16 millimeters and a transverse diameter of more than 4 millimeters will be the criteria to call it a hypertrophic pyloric muscle. Again, if you do an X-ray counterpart of this, what will you see? You will see a hugely distended stomach. This is the NG tube which is projecting into the dilated stomach, indicating that there is a gastric outlet obstruction, and the most common DD you want to rule out in a child is going to be CHPS or IHPS, which presents as a single bubble sign. Moving on to a few more bubbles, when you see a double bubble sign, that indicates that now this is the stomach and this is the proximal duodenum which is dilated, and there is an obstruction here. So there are three causes that you want to remember for this, which are described as LAD. So remember, the most important one with D is going to be duodenal atresia. So when there is atresia of the duodenum, you'll have this upper obstruction, which is very commonly associated with Down syndrome, remember. Apart from that, even annular pancreas can present this. When annular pancreas causes duodenal obstruction, you can have this. Or when there are LAD bands, when you see LAD bands which are associated with malrotation, you can also have a duodenal obstruction at this point. So these are the three causes of double bubble sign. Going ahead, triple bubble sign means that now the obstruction is a bit more distal. So this is typically associated with jejunal atresia. Alright, so this is the triple bubble sign, where you have three bubbles, three loops of bubbles which are dilated here. Now let's talk about intersusception. So what happens in intersusception, as you have studied in pediatrics, is that there is telescoping of one bubble loop into the other. As you can see, the most common is ileocolic intersusception, where the terminal ileum will telescope into the cecum. So the loop which goes in, which telescopes, is called the intersusceptum, and the one which is the recipient, that is how I remember, the one which is the recipient is the intersuscipiens. Alright, so what is the most common age group of presentation? Remember, this typically occurs around 6 to 8 months when the weaning typically starts, and that is when the Peyer's patches, which are nothing but lymphoid follicles, will proliferate, and they will act as a lead point. They act as a lead point which will pull this bubble loop inside. Okay, in adults typically there will be a polyp or there will be a malignancy which acts as a lead point pulling this bubble inside. Okay, so always in adults we need to rule out a lead point before treating this intersusception. Okay. So what are the various signs? These images are very frequently tested. So on the X-ray you would see that there is this crescent which is formed when the bubble loop telescopes like this. Or if you see it in a cross section, you can see that there are two rings which are seen, referred to as the crescent sign or the target or the donut sign. So when we do an ultrasound for this patient, you would find that this is the outer bubble loop and this is the inner bubble loop which has gone in, and we are taking a section through it, giving rise to the target or the donut sign. And if you look at it on a sagittal plane, alright, you would find that again this is the outer bubble loop and this is the inner bubble loop with this hyperechoic mesentery. Alright, so the mesentery also gets pulled in along with the bubble, so that is what appears hyperechoic, and that gives rise to the pseudo kidney sign, because this looks like a kidney with the outer cortex and the inner medulla. Alright, so these are all the signs that we would see with intersusception. Going ahead, what is the gold standard investigation for intussusception, something very, very important. So if you find that there are no danger signs, there is no signs of perforation, there is no sign of mucosal necrosis, you go ahead with a barium enema, or in turn you could also do an air enema, or you could also do a saline enema. Alright, so all of these procedures can be done, which is also called as hydrostatic enema. So barium and air will be done under X-ray, while saline enema will be done under ultrasound guidance. So all of these enemas basically will involve injection of the respective substance per rectally, and we follow it. Like here I am showing you a barium enema, and so here we find that this is the sigmoid colon, this is the descending colon, this is the splenic flexure, and you see this crescent, or you see this claw getting formed. Do you see this claw here? So this is the crescent sign or the claw sign that you are seeing in this image, and once the intussusception starts to occur, do you see this sign? This sign is actually called the coiled spring sign. So all of these signs will be seen on intussusception, and this actually shows that the reduction is happening. So when we give this pressure through all of these substances, the telescoped bowel loop basically will be reduced because of the pressure, because of the hydrostatic pressure, and that is why it's the gold standard, because it is diagnostic plus therapeutic, right? So remember, this is very, very important for intussusception. So now in this image where we have done an upper GI contrast study, again the history that would be provided to you here would be that of a child who is presenting with intestinal obstruction, presenting with bilious vomiting, and you did an upper GI contrast study, and this is what we find. So what do you see here? This is the esophagus, this is the stomach, and you can find here that from this point onwards there is this twisting which is going on, which is called the corkscrew sign. Plus, what do we see? This is the duodenum, this is the DJ flexure. DJ flexure normal location, remember, it has to cross the midline. It crosses the midline at the level of L1. When it doesn't do that, that is a barium criteria of malrotation. Very, very important. Alright, so when the DJ flexure is in the midline, not crossing the midline, it is not at the level of L1, that is suggestive of malrotation. And when you see this corkscrew motion, this will suggest that in addition to the malrotation, now there is midgut volvulus. So this is a sign of midgut volvulus, wherein the entire midgut will be completely tortuous. It will be volvuling around the mesentery. Alright, so this is a sign of midgut volvulus. Again, if you want to see the CCT counterpart of it, can you see how the mesenteric vessels are swirling around like this? On the Doppler also, can you see the swirling of the mesenteric vessels? So this is again referred to as the whirlpool sign, that is a sign of midgut volvulus. Going ahead, what is this image? So a newborn with failure to pass stools for 48 hours, barium enema image is shown. What is the diagnosis? So on this lateral image of the pelvis, can you see here that this is the rectum and this is the dilated sigmoid colon. So what we find is that there is a definite transition zone, right? So till here it is narrow and then it becomes distended. This is very typical for Hirschsprung disease. So let's discuss. So this is the narrow rectum and this is the dilated sigmoid colon. Normally, when we talk about recto-sigmoid ratio, remember rectum is the most dilated portion in our GI tract. Okay, so this ratio normally always has to be more than 1. If I find that rectum is narrow and sigmoid colon is more dilated, the ratio goes less than 1, which is a feature of Hirschsprung disease. And the second feature that we discussed is transition zone, that we'll see, wherein the bowel loop goes from an undilated state to a dilated state at one particular point, which is the transition zone, which marks that it is this segment actually which does not have the ganglion cells. So in Hirschsprung disease, what we have is that the neural crest cells have a failure to migrate. So there are no ganglions here, resulting in a functional obstruction. That is why there is no peristalsis here, there is no movement here. So there is a state of obstruction here, and as a result the proximal bowel loop dilates. So keep in mind that the dilated bowel loop here is actually having normal ganglion. It's the narrow part that you are seeing here which is aganglionic, right? So remember this is Hirschsprung disease, transition zone, recto-sigmoid ratio reversal. Going ahead to this, what is this investigation? So when you see this inverted sort of an appearance, this is invertogram, and this is an investigation that is done in cases of anorectal malformation. Remember though that investigation of choice for anorectal malformation to evaluate what kind of an anomaly is there is going to be MRI, alright, but an initial good investigation to say whether it's a high ARM or a low ARM which changes the management would be invertogram, wherein we see that how high is this dilated bubble loop reaching up to with respect to a few lines, alright, and that is called as invertogram. So now we talk about this case here where a 9-year-old boy comes with a decreased appetite and abdominal pain around his umbilicus. The parents think he doesn't want to go to school and that is why he is making excuses, but he now starts to have sharp pain in his right lower abdomen. So very typical scenario where the pain radiates from the umbilicus to right iliac fossa pain. We are definitely thinking of acute appendicitis, and when we have the ultrasound, what do we see here? So on the ultrasound, can you see this tubular channel here? So this is a dilated tubular duct that you are seeing, which is blind ending. This is suggestive of an inflamed appendix, and the criteria is that this AP diameter should be more than 6 millimeters, right? So this is suggestive of a acute appendicitis. Alright, so for acute appendicitis, remember these are the features you are looking out for acute appendicitis. So these are all the features we are looking out for. Before that, remember the technique we use is referred to as a graded compression technique of ultrasound, wherein we'll keep increasing the pressure slowly over the right iliac fossa in order to displace the overlying bubble loops and get a better visualization of the appendix. Alright, so what you would see is that there is a tubular channel that you are seeing. There will be no peristalsis, it won't be compressible, there would be tenderness, and the AP diameter is more than 6 millimeters. A lot of times at the end of the appendix here, you would also find that there is a fecolith. There is something called as a stone which could be obstructing this appendix leading to appendicitis, which is a fecolith. So these are the features of acute appendicitis. Now let's go to the very important topic of pneumoperitoneum or perforation. So when I ask you what's the most sensitive investigation for pneumoperitoneum, remember any air containing pathology, most sensitive is always going to be a CT scan. Most sensitive, X-ray. Remember, it's going to be chest X-ray, PA view in an erect position, alright. So you ask the person to stand and take a chest X-ray. Most important point. Most sensitive abdominal X-ray, if I ask you, then you tell me abdominal X-ray, erect view. But if the patient tells you that the patient is too sick to stand, patient cannot stand, so we can't take any of these erect views, so we can just do a decubitus view. What kind of decubitus view? So we know from the basic concepts of X-rays that air is black, whereas the soft tissue is going to be a different density. So when I can see the free air against the liver on the right side, that would be a better diagnostic tool rather than see it against the stomach, which anyways has air, right? So that is why we want the right side to be up, we want the left side to be down, so that the air rises up against the liver. Is this making sense? So that is why what we do is left side down, so we call that left lateral decubitus. So we do a left lateral decubitus view in cases of pneumoperitoneum. Alright, so that is what is the investigation that you will do when the patient is too sick to stand. Going ahead, so this is what the pneumoperitoneum will look like on a CT scan when the free air will rise up, right? So the free air will rise up anteriorly, and this is how pneumoperitoneum appears. So going ahead, this is how a left lateral decubitus view appears. That is where we will be seeing the liver here, and this is the free air that is rising up against the liver. Talking about a few important signs. So this is the football sign that was asked in the last FMG exam, wherein you would see that there is air outlining all the abdominal organs, right? So this is the football sign which is seen in a supine position, but you need a lot of air, right? So this is seen in cases of massive pneumoperitoneum. When you have this kind of a sign wherein the air rises against the central tendon of diaphragm, can you see this foci of air here? That is referred to as the cupola sign when the air rises below the central tendon in a supine position. This is the regular sign that you see in pneumoperitoneum, wherein air will be outlining the inner as well as outer aspect. So this is the normal air within the lumen, and you find that there is air outside the lumen also. So the bowel wall becomes very well delineated. So this is called as the regular sign. So these are various signs that you can see. Apart from that, a lot of times you can see the falciform ligament sign, you can see the triangular ligament. So all of these ligaments, when they are seen because of the air outlining them, these are also referred to as signs for pneumoperitoneum. Going ahead, what is pseudo-pneumoperitoneum? So when you find air under the diaphragm, but in addition you find that there is hostrations, there is presence of these hostrations, this is suggestive of an anatomical variant wherein the colon actually interpositions itself between the diaphragm and liver. So this is because of colonic interposition between the liver and the diaphragm, and this is referred to as Chilaiditi syndrome. So remember, this is just an anatomical variation. So do not mistake this for a pneumoperitoneum, and you can distinguish it on the basis of these haustral folds. Okay. Going ahead to intestinal obstruction. So now talking about obstruction. So features of large bowel obstruction on X-ray. So out of all of these, remember, dilated bowel loop with haustration is a feature of large bowel obstruction, whereas when you see valvulae conniventis or central loops or string of Pearl sign, these are all features of small bowel obstruction. So when we talk about small bowel obstruction versus large bowel obstruction, so when you see these complete folds, can you notice these complete mucosal folds extending through the lumen? These are called valvulae conniventis or valves of Kirkring, and they are a feature of jejunum. Alright, so these are seen in the jejunal loops, whereas when you see these incomplete folds like this is a feature of large bowel wherein you see these haustrations, right? So when you see complete mucosal folds, we are thinking of small bowel obstruction. When you see these haustrations, we are thinking of large bowel obstruction. In addition, when you see that there are these centrally dilated bowel loops with multiple air fluid levels, this is referred to as the step ladder sign. Alright, and this is again a feature of small bowel obstruction. When you find that there are not multiple air fluid levels, but I am seeing that there is a rising air foci pattern which is suggestive of a string of Pearl sign. This is also a feature seen in small bowel obstruction. It's just that the fluid in the bowel is so much because of the obstruction that there is not enough air to form the air fluid levels. So the only foci of air which are remaining will be rising up like this, and this also gives you a hint that it's again indeed obstruction but in a fluid filled bowel. Alright, so this is also a sign of small bowel obstruction. Now when I show you this image, what do you think? Is it large bowel? Is it small bowel? Before that, we need to learn about the rule of 3-6-9. What kind of a dilatation do I say that it is obstruction? So for that, more than 3 centimeters is needed for a small bowel obstruction. More than 6 centimeters, we need to call it large bowel obstruction, and to call a cecal loop dilated, we need to call it more than 9 centimeters, right? So this is about the 3-6-9 rule. Coming back to this X-ray, what do we find? We find that indeed the large bowel loop is dilated in the periphery. And how do I know? We can see these incomplete haustrations. So you can see it's dilated up to the descending colon, and here there must be the site of obstruction. So this is the example of large bowel obstruction. Looking at this image now, what can you see? So here you can notice that there is a very typical coffee bean sign that you can see here, which is suggestive of sigmoid volvulus. So this is suggestive of a sigmoid volvulus wherein you see that there are 2 bowel loops, there are no haustrations. This is a case of sigmoid volvulus. So let's understand and then come back to the question. So when we compare sigmoid volvulus with cecal volvulus, there are few features that you need to keep in mind. Which out of these two will have a clockwise rotation? Remember, C for cecal volvulus. So cecal volvulus will have a clockwise rotation, while the sigmoid volvulus will have anti-clockwise rotation. Second point, sigmoid volvulus will find a ahostral tube. So can you see here that the bubble loop which is dilated doesn't show any haustray, but here you can find the presence of these haustrations. Third thing, you will see two bubble loops which are distended here, whereas there is a single loop which is distended. Here the background would be that of an elderly patient with chronic history of constipation, whereas here the risk factors for cecal volvulus include pregnancy and pelvic surgery. So here the sign that you see when a single dilated haustral bubble loop with overlying dilated small bubble loops, right? So the proximal small bubble loops would get dilated here, whereas in the cecal volvulus you would find that it's the proximal large bubble loop which gets dilated, right? So that is one more feature. So this is referred to as the C sign, whereas here you use various terms such as the coffee bean sign or the Fremantle sign or the bent tube sign or the northern exposure sign, because a lot of times this can reach to cover the liver as well as the spleen. Alright, so that is the northern exposure sign. Coming to the management. So remember, the management of choice for sigmoid volvulus is going to be endoscopic detorsion. So it is not an indication of surgery. An endoscopic detorsion will suffice, whereas in cases of cecal volvulus, surgery is usually needed. Alright, so now let's look at this. So all of the following are true about sigmoid volvulus except endoscopic detorsion is the treatment of choice. This is true. Ahostral loop, this is also true. Anti-clockwise rotation more common, this is also true, but a higher risk in pregnancy is seen with cecal volvulus. So this is the false statement here. When we do a barium enema for a patient with sigmoid volvulus, because there is rotation, because there is a volvulus which is happening at this point, you would find that the rectum kind of tapers proximally, which is called as the bird of prey sign. So this is again something which is associated with sigmoid volvulus. Now let's talk about inflammatory bowel disease and the imaging counterpart. So now talking about inflammatory bowel disease, let's talk about Crohn's. So all of the following are associated with Crohn's disease except anti-mesenteric border saculations. This is something which is seen with Crohn's. Creeping fat, comb sign, again we'll see these are signs of Crohn's disease, but when you talk about lymph nodes, remember always necrotic nodes are always a feature of tuberculosis, right? Whereas in Crohn's we would find non-necrotic nodes, right? We wouldn't find presence of caseous necrosis in the case of Crohn's disease. So now let's see the features of Crohn's disease, wherein the most common site of the bowel to be involved in a case of Crohn's disease, remember, is going to be the terminal ileum. And the kind of involvement you will have would be transmural, right, where the entire bowel wall gets involved. You will have skip areas which are involved, and any part of the gut from the mouth through the anus can be involved. So what will we see? Anywhere where you have inflammation, you would see a stricture. So can you see this long segment of terminal ileum which is narrowed here? This is referred to as the string sign of Cantor. When you see in the early stages, there will be the ulcers which develop. So if they ask you which is the earliest sign of Crohn's disease, remember it's the presence of aphthous ulcers. So when the aphthous ulcers basically will combine and form these serpiginous ulcers, they will have this cobblestoning sort of appearance, and also the mesenteric fat will proliferate, giving rise to this creeping fat appearance. Alright, so that is also something which is seen. And in the chronic stages, you would find that because of the stricture, the anti-mesenteric side, so this is the mesenteric side, you would find that the anti-mesenteric side actually forms these sacculations. Alright, so anti-mesenteric sacculations would be noted. So these are all features of Crohn's disease on a barium study. So when you look at the CCT findings, you would note that there are features of inflammation wherein the mesenteric vascularity increases so much that it appears like a comb. Do you see this? This is the inflamed bowel loop, and there's so much mesenteric hyperemia in the vasa rectae, giving rise to this comb sign. And You might also find, because there is transmural involvement, you would know from path that fistula, alright, so fistula, abscesses, all of these are more common with Crohn's disease. So you can have bowel fistula, enteroenteric fistula, which communicate like this, giving rise to a stellate sign. So all of these clumped bowel loops appear like a star, giving rise to the stellate sign. So all of these are features of Crohn's disease. On the other hand, when you see this, that there is a continuous involvement starting from the rectum involving the entire bowel loop, so no skip areas, hostrations are lost, and you are finding this diffuse granularity in the colon, this is suggestive of ulcerative colitis, right? So this is suggestive of ulcerative colitis. The earliest finding that you would see here is the presence of this mucosal granularity, alright, and eventually what would you see? You would see that there is basically complete loss of hostrations, giving rise to a pipe or a lead pipe appearance, alright. So a pipe stem or a lead pipe appearance is seen in continuous disease where there is loss of hostrations. So remember, a very bad complication of UC, it's toxic megacolon. So when you have a patient presenting with fever, with diarrhea, with worsening of symptoms, you do the radiograph and you find that the bowel loop is first of all ahostral, plus you find that there is dilatation more than 6 centimeters. Remember, 369, large bowel 6 centimeters. This is suggestive of toxic megacolon. Very, very important question, and this becomes a surgical emergency. So remember, ahostral loop plus 6 centimeter dilatation, that is toxic megacolon. Now, let's talk about the differential of inflammatory bowel disease, which is ileocecal junction tuberculosis. So, remember, the most common site of GI TB is going to be the ileocecal junction, which gets affected. Alright, so what we would find in a lot of cases of ileocecal junction is that the IC junction gets pulled up. Can you see this pulled up ileocecal junction? Because of the fibrosis which sets in, and the ileum becomes narrow, which is also something that we saw in Crohn's disease, wherein we use the term string sign of Cantor. But if you drop the Cantor and you use the string sign, it is seen in tuberculosis, and overall this gives rise to this appearance called gooseneck deformity. In addition, you would also find that there is the gaping of the IC junction which is seen. There are motility issues. So all of these signs are also described, which is called the Sterling sign. Okay, so this is about ileocecal junction TB. Now, let's look at a few other named signs in GI. So, here you can see that this is the bowel loop, and you can see this mucosal projections which are thumb-like. So, this thumb printing sign is associated with colitis, predominantly ischemic colitis. Alright, so it's been described more with ischemic colitis, but it can be seen with any colitis cause. Alright, so this represents mucosal edema. It represents mucosal edema within the bowel wall, which presents as these thumb-like projections. When we look at this appearance, what do you find? That in the transverse colon, so this is the transverse colon wherein you are seeing this diffuse thickening of the wall with contrast tracking into the walls. This is basically suggestive of pseudomembranous enterocolitis. Alright, so this is pseudomembranous colitis. You would have history that the patient has been admitted on antibiotics for a very long time. So this is Clostridium difficile associated colitis, and the sign is referred to as accordion. So accordion is a harmonium like musical instrument, right, wherein you have these various tracts. So because of that, the name is accordion sign. So now let's talk about the FAST examination. Okay, so now we are talking about extended FAST, which is the first investigation that you would do in patients who have blunt trauma abdomen. Remember, this will be the initial investigation in any patient with blunt trauma abdomen. Alright, so this is EFAST, which stands for Extended Focused Assessment using what? Using sonography in cases of trauma. So remember this full form, it has been asked way too many times for you to get it wrong. So this is basically a focused ultrasound that we are using in trauma, and our main aim is to identify the most severe conditions. One, hemoperitoneum. Second, pericardial effusion, pneumothorax and hemothorax. Alright, so when we are looking out for When we are looking out for hemoperitoneum and pericardial effusion in these 4 areas, that was the original fast. When we do an extended fast, which is done nowadays, we also evaluate the lungs for pneumothorax and hemothorax. Alright, so first we keep the probe in the subxiphoid area in the epigastrium in order to evaluate the heart. Alright, so this is the first step. Then you place the probe in the hepatorenal pouch or the Morrison's pouch between the liver and kidney to look for hemoperitoneum. Next, you place the probe between the spleen and kidney in the splenorenal pouch, and finally in the pelvis to look for hemoperitoneum. And you place the probe in the intercostal spaces on both the sides to look out for pneumothorax. So this is the protocol of EFAST. So now when you look at such an image where this is the liver, this is the kidney, and you notice that there is this free fluid in between the two, this is suggestive of a positive fast, right? So this is presence of free fluid, remember, anechoic fluid, that is what we are seeing here. But one more question that was based on a recent AIIMS exam: what are the limitations? When would EFAST not be as good in picking up the findings? One, it would not be able to pick up RP injuries or retroperitoneal hematoma. So it is not sensitive because we are not focusing here, right? It's a very focused ultrasound where we are looking at 4 points. Retroperitoneum is not one of them. So RP hematoma will not be picked up. Diaphragm tears, not sensitive. Mesenteric and bowel injuries, a lot of times these injuries will not have associated hemoperitoneum but will have pneumoperitoneum, and that is something that might not be picked up on ultrasound. And 2 patient related factors. So if the patient has associated subcutaneous emphysema, we know air is the enemy of ultrasound. It will not allow the sound waves to go deeper, right? So that is something that hinders the visualization of fast, and that is why the limitation of subcutaneous emphysema. On the other hand, if the patient is obese, right, morbid obesity, again we get a poor window to visualize and fluid might be missed. Okay, so these are the 2 limitations of EFAST. If done under a trained hand, 50 ml, we can pick up as much as 50 ml fluid, but on an average, remember, 50 to 100 ml falls the sensitivity of fast, wherein this much amount of hemoperitoneum can be picked up by a fast examination. Alright, so remember this. Now let's talk about liver. So we have a 35-year-old female presenting with fever and right upper quadrant pain, and this is the ultrasound of the liver that's been shown. This is the hyperechoic diaphragm, and you find that within the liver there is a cyst, right? There is this anechoic lesion, but is it a simple cyst? No, you can find here that there's a membrane which is floating. So there's a typical hydatid cyst which shows you this water lily sign. So there's a water lily sign, detached membrane in case of a hydatid cyst. Alright, so this is a very frequently tested image. Remember this, and we use 2 kinds of classifications for hydatid cyst. One is the WHO classification, and the older one was called as the Galbi classification, right? So just remember these names and this appearance. When we talk about a hepatic abscess, again we would find that there is an anechoic lesion, but there is various debris here. Can you see that there are these various echoes inside it, which is suggestive of debris, which is a sign which is seen in hepatic abscesses. Alright, so this could be an amoebic abscess, or the other differential would be that of a pyogenic abscess. Remember, amoebic abscess usually single, whereas pyogenic usually would be multiple. Apart from that, the clinical features that we would find, if I aspirate it, an anchovy sauce pus would again favor that of an amoebic abscess, whereas also presence of associated ulcers in the intestine would go in this favor, while if the patient is in sepsis, that goes in the favor of a pyogenic abscess. Going to the next sign that you are seeing here on the ultrasound, you can find these dilated channels which have this central dot. The same finding we see on the CT, wherein you can find that these are the biliary radicals which are markedly dilated with a central dot. So this central dot sign is seen with Caroli's disease. Alright, so this is the Caroli's disease, which is a type of choledochal cyst, right? So choledochal cyst type 5, right? So in the 5th type of choledochal cyst, when you have intrahepatic involvement, alright, you have this central dot sign which represents the portal radicals. So these are the portal radicals that you have within the dilated biliary radicals. So this is Caroli's disease. This image wherein you've been given a cholecystectomy specimen, very typical. You're finding that there are these GB calculi which are not radio opaque, but they have this trapped air within it, right? So this is a trapped air which has been given the name of Mercedes-Benz sign, seen in cases of gallstones, right? So there's a sign of gallstones on X-ray. The point to remember, what is the investigation of choice for gallstones? So remember, investigation of choice, because we saw that most of them, 90% of gallstones are not going to be radio opaque. They are going to be best evaluated by ultrasound. Alright, so for gallstones, investigation of choice is ultrasound. And what will you see? So this is the gallbladder that you can see, and within it, this is this hyperechoic calculus with this posterior acoustic shadowing. So this posterior acoustic shadowing is a feature of gallstones. Alright. Now, when we talk about complicated gallstones, we have to talk about acute cholecystitis, and investigation of choice is again gonna be ultrasound. Alright, for acute cholecystitis. But if they ask you which is the most accurate investigation, it is the HIDA scan. So remember, theoretically it's the most accurate but not used in practice. So when we do a HIDA scan, we will see that there is non-visualization of the gallbladder. Normally when the HIDA gets excreted from the liver, you would see opacification of biliary radicals, gallbladder, and then the intestine. But here, because the gallbladder is inflamed, you would just see either a rim of it, or you would see a complete non-visualized gallbladder. Because of the inflammation, it doesn't take up the HIDA. So that is the feature that we'll see on a HIDA scan. On the ultrasound, which is the investigation of choice, you would find that this is the gallbladder and it has this thickened wall. Can you notice this thickened wall here? And in the neck is this calculus which is showing this posterior acoustic shadowing. So you would see an obstructive calculus if present. You would see a thickened wall more than 3 millimeters in thickness, and when you compress that area with the ultrasound, there will be tenderness, and that sign is referred to as the sonographic Murphy sign. So this is the counterpart of the clinical Murphy sign that you guys know. So all of these are features of acute cholecystitis. Alright. In contrast, when we compare this finding with that of a calculus, here there is a non-dependent polypoidal structure with no shadowing. So this is how a gallbladder polyp will appear. Remember, this is not a calculus, it's not dependent. A calculus would be in the dependent location with posterior acoustic shadowing. So now let's talk about this sign here, which is the comet tail sign, wherein you are seeing that from the GB wall there are these various artifacts that you are seeing like a comet tail. This is a feature of GB adenomyomatosis, right? So this is seen in gallbladder adenomyomatosis, wherein you see this artifact is the comet tail sign because of the accumulation of these cholesterol crystals within the wall of the gallbladder, right? So in adenomyomatosis, within the gallbladder wall, you would have these hypertrophied RA sinuses, alright, which will have accumulation of these cholesterol crystals that give rise to this artifact. Okay, so remember this comet tail sign. Again, a very important image that we are seeing here, wherein the wall of the gallbladder is calcified. This appearance is called as the porcelain GB, and the importance is that it is pre-malignant, right? So it is pre-malignant in nature, and that is why it warrants a prophylactic cholecystectomy, and this is how it's gonna appear. What about this image? So here you can see that there is this diffuse artifact, there's this diffuse dirty shadowing from the gallbladder. You are not visualizing anything here, right? When we look at the CT, now we come to know why there is this poor visualization. Again, air is the enemy of ultrasound. We find that there is air in the wall of the gallbladder. This is suggestive of emphysematous cholecystitis, right? So this is emphysematous cholecystitis that you are seeing on the CT image here. Finally, what is this sign? So, this is an MRCP image, a magnetic resonance cholangiopancreaticography, wherein you can see this is the gallbladder, this is the CBD, these are the intrahepatic radicals which are markedly dilated, and this is the main pancreatic duct which is also dilated. So, when you have double duct CBD as well as MPD dilated, that's because there is an obstruction here, right? So, this is associated with periampullary masses. So, any mass here that is obstructing the flow of both the ducts resulting in their dilatation, that is what is referred to as a double duct sign. Alright. So, this is about periampullary CA. So, this was our discussion on GI radiology. So, now let's continue with genitourinary radiology. Here, we will be focusing on the renal and the urinary tract aspect of things as well as some gynae obs imaging. Alright, so let's begin. So, first we want to start with the most frequently tested things, which are the IVP images and signs. Alright, so you need to have a very quick overview of all of these images and what is the diagnosis in all of these conditions. Okay, so as you can see, this is an IVP image. You see an abdominal X-ray and you see that there is contrast within the pelvic calyceal system, the ureters, and at the distal end of the bilateral ureters, what do we find? We find that there is this dilatation, right? There is this cystic dilatation that you are finding at the distal ends of the ureter, which is referred to as a cobra head or the adder head appearance, and this is seen with uretrocele. Alright, so uretrocele, as the name suggests, there is a dilatation of the distal end, alright, of the ureters. Now, this can be a simple uretrocele wherein you have a single system on both the sides and you have this uretrocele like is in this case, or you can have an ectopic uretrocele. This is seen with duplicated systems, alright. So, when there are duplicated collecting systems and you have an upper pole and lower pole, remember it's the upper pole moiety, alright, it's the upper pole collecting system or the upper pole ureter which undergoes this ectopic insertion and this uretrocele formation more commonly, alright. So, that is the ectopic type of uretrocele. Alright, so these are the two types that we see. This is the cobra head or the adder head appearance. When we look at this kind of an IVP appearance, wherein the kidneys are not located in their normal location. If you see here, they are all, first of all, they are both medially rotated. Do you see that they are trying to meet each other at the inferior pole? Does it look like that? Yeah, hence the name flower vase or shaking hand calyces. So, that is why we use the term shaking hand calyces or flower vase appearance for this sign here, where the inferior pole of the two kidneys appears to be very, very medially oriented. Apart from that, you also find that the kidneys are lower. So, relatively, if you were to draw the kidneys here, we can see here that they must be fused in the midline. And what is the condition we are talking about? So, we are talking about a horseshoe kidney. This is the most common fusion anomaly that we have in the kidneys, wherein the inferior poles are fused and this fused segment is referred to as the isthmus. Alright, so if we look at a CCT image here, can you see how this is the inferior pole which is fused, and if you look carefully, there will be a vessel, an artery which is seen in relation to it. And what is this artery? This is the inferior mesenteric artery. So, what happens is when this fused kidney, this fused horseshoe kidney is trying to ascend up, alright, it's trying to ascend up embryologically. As it does, the inferior mesenteric artery basically will be blocking its ascent. So, if they ask you where is the isthmus located, remember it's most commonly at the L3 level. Alright, so this is about the horseshoe kidney. A few complications I want you to remember. So, because of the medial orientation of the ureters, there's higher chances of ureteric obstruction, there's higher chances of stasis which might result in UTI as well as calculi formation. Apart from this, there is higher incidence of trauma, alright. So, in cases of trauma, there is higher incidence of injury to the kidneys here because of the more medial location here and its impact against the vertebral column. So, this is horseshoe kidney. When we look at this image here, you can see that there is a drooping lily appearance, right. So, this is the typical drooping lily sign that we see with duplex collecting system. So, in cases of duplicated collecting system, what you would find is that there is something called as a Wiegert-Mayer law, right. So, let's revise that law that we study in pediatrics. So, the Wiegert-Mayer law is what has been described. here, wherein you have an upper pole collecting system and a lower pole collecting system, both of which have their own ureter. Now the kind of complications they undergo will be different. So the trick to remember here is vowels stick together. So everything that starts with a vowel will be seen with the upper pole. So the upper pole is more prone to undergo obstruction. O for obstruction. Second thing, it is more prone to undergo ectopic insertion, like we were just seeing. It is more prone to undergo uretrocele formation. If they ask you, where will it open with respect to the trigone? Remember, it will open inferomedially. So all of these things, can you see so beautifully in the schematic? There is hydronephrosis because of obstruction. It opens inferomedially in an ectopic location, and there is this dilatation, there is a uretrocele. On the other hand, the lower moiety opens superolaterally, right? Superolaterally, and it undergoes the complication of reflux. So there will be higher incidence of vesico-ureteric reflux in the lower moiety. So this is the Wiegert-Mayer law. So now when the upper moiety becomes obstructed, it loses the function. Basically, we would see that here the upper moiety is non-excretory, it is obstructed, whereas the lower moiety here appears as if it is drooping down. Alright, so this is a drooping lily sign which suggests a duplicating collecting system. Going ahead to the next IVP appearance, here you can see the splaying, right? Can you see the splaying of the pelvic calyceal system on both the sides, which is given the name spider leg sign, and this is seen in autosomal dominant polycystic kidney disease. So in this condition, when you have multiple large cysts which completely replace the renal parenchyma, the pelvic calyceal system is going to be splayed between all of these cysts. Alright, so because of the splaying of the pelvic calyceal system, we get this sign. One more name I want you to remember here is the Swiss cheese appearance. So Swiss cheese appearance will be seen in the nephrographic phase. Alright, so if I take an early phase in the IVP image, that is referred to as the nephrographic phase, when the renal cortex is basically having the contrast, you would find that because of the presence of these cysts, there are these filling defects within the nephrogram which give rise to the Swiss cheese sign. So both of these are signs that we see in autosomal dominant polycystic kidney disease. And on ultrasound, what will be the counterpart of this condition? We'll see that the entire kidney, we are having these multifocal cysts, innumerable cysts that you can see in both the kidneys. So both the kidneys will be enlarged, irregular outer margins, multiple anechoic cysts, which is the autosomal dominant polycystic kidney disease. You would have an adult patient who comes to you with these symptoms of renal failure, which is gradually progressing. Now when we look at this IVP image, you can see that there is this paintbrush appearance, also referred to as a bouquet of flowers appearance, and this is seen in medullary sponge kidney. Alright, so in medullary sponge kidney, wherein you have this sort of calcification in the medullary pyramids, along with the contrast that is getting excreted, it gives you this striated sort of paintbrush like appearance. So this is medullary sponge kidney. Looking at this IVP image, here you can see that both the ureters are medially deviated. This sign is referred to as the maiden waist sign, where there is medial deviation of the ureter, and this is seen in cases of retroperitoneal fibrosis. Now retroperitoneal fibrosis can have a variety of causes. It can be primary, which was previously referred to as Ormond disease, but there can be various secondary causes, out of which multisystemic IgG4 related disease is something which is very important. It can be post radiotherapy, or it can be seen with various drugs. One drug that I want you to remember here is methisergide. Alright, so methisergide is notorious for causing retroperitoneal fibrosis. There are various causes of RPF that we need to rule out. So now when we see that the kidney is hydronephrotic, the proximal ureter is dilated, and then there is this acute curvature, there is this acute medial deviation giving rise to a J-shaped or a hook-like ureter. This condition is seen in retrocaval ureter. So this is when the ureter actually passes behind the IVC in an anomalous manner. So this is an anatomical variation that actually leads to hydronephrosis, ureteric compression. Is this because of a ureteric anatomical variation or IVC embryology which goes wrong? Remember, this is because of an abnormal IVC embryology that the ureter actually courses behind the IVC. Alright, so this is about our retrocaval ureter, the J-shaped or the hook-like ureter. Now, coming to the next sign here. So now when you see in the location of the papillae that there are these necrotic sloughed of papillae that you are seeing within the renal calyces, this is referred to as signet ring sign. Some people also like to call it a ball on T because it has this ball on T sort of a shape, or it can appear like a lobster claw. So all of these signs are seen with papillary necrosis. Various causes of papillary necrosis, remember, they can be associated with NSAIDs or analgesics. It can be seen in infections like renal tuberculosis. It can be seen in sickle cell anemia, diabetes mellitus. So all of these can be the various causes of papillary necrosis. When we look at this image, what is the investigation that is being shown to us? So here you can see that, so this is the male anterior urethra that you can see here. So when we talk about the anatomy of the male urethra, there are 4 parts that you need to know. So this is the distalmost part, which is the penile urethra, and here when it takes a bend, can you see this curve and then it tapers to form this? This is the bulbar part of urethra. The penile and bulbar urethra together make up the anterior segment of urethra. When I go further distally, this is basically the prostatic segment. So this is the prostatic urethra, and this narrowest part, which corresponds to the urogenital diaphragm connecting the prostatic urethra with the bulbar urethra, is the membranous urethra. So the prostatic and membranous urethra together make up the posterior urethra. Alright, so this investigation wherein we are seeing that it's the anterior urethra which is markedly distended, this is RGU, which stands for retrograde urethrogram. So what we do here is we cannulate the external urethral meatus and inject contrast. So because it's retrograde, hence the name, and we are seeing it basically for the anterior urethra, alright, which will be the maximally distended part here. Remember, it's the investigation of choice for urethral injury. Anytime any urethral trauma is suspected, the first thing you have to do before inserting a Foley's catheter is an RGU to rule out urethral injury. Very, very important. Going ahead, when we see this RGU image, what do you find? We find here that this is the penile urethra which has these irregularities, and at the junction of the penile and bulbar urethra, you find that there's this complete stricture. There's a complete narrowing which is called a stricture. So remember, RGU, investigation of choice for anterior urethral strictures. Alright, so you can pick up these strictures on the RGU like so, where there will be this persistent non-dilated segment. What about this investigation? So this is a MCU or a VCU, which stands for a micturating or avoiding cystourethropography. Okay, so here what we do is, first of all, a Foley's is put into the bladder. So the bladder is catheterized with the Foley's, and up to 300 to 400 ml of diluted contrast is injected through the Foley's into the bladder. Once the patient tells you that, okay, now I am having the sensation to void, my bladder is maximally distended, we stop injecting, we remove the Foley's. Then under X-ray exposure, the patient is asked to void. The patient is asked to pass urine. So what is going to happen is, you will have the bladder which is maximally distended, and once the patient starts to pass urine, the posterior urethra, the anterior urethra, everything becomes distended. So remember, this is how the investigation is performed, and it is the investigation of choice for 2 main pathologies, both of which are 3-letter words. Alright, so simple MCU is 3-letter. The 2 pathologies where it's the best investigation for are also 3 letters. So first is VUR, which is vesico-ureteric reflux, wherein when the patient is voiding, Along with the contrast in the urethra, you start to see that now the ureters are also getting the contrast back. So there is vesico-ureteric reflux which is picked up, and secondly, a congenital obstruction cause, which is posterior urethral valves, wherein you would find that the posterior urethra is markedly dilated and the anterior urethra is not getting a lot of contrast because of this valve, which acts as a one-way valve and one-way obstruction to the passage of urine, presenting as obstructive uropathy. So let's see the images. So here in an MCU study, what do you find? We find that along with the bladder, there is this gross distension of the ureter, there is gross hydronephrosis, there is ballooning of the calyces. So when you see such severe reflux, when the kidneys are ballooned out, grossly tortuous, this is called as grade 5 vesico-ureteric reflux. Alright, so there are various grades. Moving on to the next pathology here, what can you see? So this is an antenatal ultrasound wherein you are finding that this is the dilated bladder and this is the posterior urethra, which gives rise to this keyhole sign appearance. So this basically suggests that there's some sort of obstruction here which is leading to this abnormal dilatation at this level. Now the investigation of choice. So what are we suspecting? We are actually suspecting posterior urethral valves, right? And remember, the best investigation for this is going to be a micturating cystourethrogram, wherein this is the bladder and this is the posterior urethra, which is grossly distended, and then you find here after the valves, the urethra is so thin, it's so tapered, right? So this is suggestive of posterior urethral valves. Now let's look at a few named bladder appearances on the same slide so that we can be done with them at the same time. When you see this vertically oriented Christmas tree bladder with multiple such diverticulations, you also see the presence of vesico-ureteric reflux. This is suggestive of a neurogenic bladder. This is suggestive of neurogenic bladder. When you see that the bladder is compressed, assumes this teardrop or a pear-shaped appearance, that means that something is compressing it extrinsically. So this is seen in cases of extrinsic compression through various masses, which could be diffuse masses like pelvic lipomatosis, or it could be because of a hematoma such as pelvic hematoma in cases of trauma, or any other mass. So it basically suggests that something is diffusely compressing the bladder from outside. When you see this fetal skull appearance, wherein on the CT image you see that the bladder wall is showing calcification, this is seen with schistosomiasis infection. So remember, peripheral wall calcification seen with schistosomiasis. So now talking about the next pathology here. So now let's discuss genitourinary TB. So as you know, kidneys are the most common organ to be affected amongst the genitourinary system, and it's never a primary infection, alright. So it's a hematogenous spread most commonly from the lung, that is the route that the TB bacilli will take to reach the kidney. Now in the kidney, they again through the circulation, they'll get filtered by the glomeruli and then they'll be going into the collecting tubules. So because of this, the earliest changes that they'll do will be to the collecting system, right? So when they are excreted into the collecting system, which is the pelvic-calyceal system and the ureter, they'll cause inflammation, which appears as irregularity, that will be followed by fibrosis, which acts as a narrowing and a stricture. So that is the pathophysiology of how TB works. So what you will find actually is, what is the most sensitive investigation? Remember, it is going to be IVP. So IVP is the most sensitive investigation, but if they ask you which is the investigation of choice, which can tell you an entire extent of the disease, answer should be CT urography. So the earliest finding actually that we can pick up on IVP is the presence of moth-eaten calyces or irregularity of calyces because of the erosions caused by the TB bacilli. So you would find that the calyces become quite irregular. In the end stage, you would see there are various strictures such as infundibular strictures. Calyces become very irregular in shape. So when you cannot find any calyx, a calyx has gone missing because there is no excretion because of infundibular stenosis, that is called phantom calyx. So all of these appearances you start to see once the disease progresses. The entire ureter can become very narrow, which is referred to as a pipe stem ureter, and the bladder can become very small in capacity, which is referred to as the thimble bladder. So this is the thimble bladder that you can have here, and the patient, remember, will present to you with increased frequency with dysuria because of this very low capacity bladder. In the final end stage, what you can find actually because of severe infection is that the entire kidney gets completely calcified. It appears like a cement filled kidney, which is called as a putty kidney, with absolute loss of function, and that is why it's referred to as a autonephrectomy, that this complete loss of function and this calcification that we find here. Going ahead, in this image, if I give you the history, there's a sick patient in sepsis and we find this kind of an appearance. We see that in the renal fossa, there's complete air which is tracking. This is suggestive of emphysematous pyelonephritis. There's a polymicrobial infection, mostly because of gram-negative organisms. It has a poor prognosis and the patient will frequently be in sepsis. The first thing you have to do is drain it, alright, so put in a pigtail, drain it out. If needed, nephrectomy will have to be performed if the sepsis is not controlled. So this is emphysematous pyelonephritis. Now let's go and talk about a few important gynae-obs conditions. So the first thing we want to see here is polycystic ovarian syndrome. So in PCOS, there's a typical appearance you see for both the ovaries, where the ovaries are increased in volume. They are very bulky, more than 10 cc in size, with the presence of these multiple follicles. So there are multiple small follicles. Do you see that? Multiple peripheral 2 to 8 millimeter follicles, which are more than 12 in number. And can we find any dominant follicle? No, there's no dominant follicle which has enlarged, and that explains why the cycles are anovulatory here, right? So because there are no dominant follicles, anovulation will be the most common pathophysiology in PCOS, and the marker will be that this is the central stroma. This is the central stroma which is increased in volume as well as echogenicity. So this happens to be the most specific feature of PCOS, alright. So remember this is how bilateral polycystic ovarian syndrome will appear. Bulky ovaries, peripheral small follicles, stromal echogenicity increased, no dominant follicle. On the other hand, when you find that there are these multiple large follicles which are noted in both the kidneys, right? There are two possibilities. One is ovarian hyperstimulation syndrome. If the clinical background gives you the history of IVF or any treatment for IVF and patient comes to you in a hypotensive state, alright, you find ascites, pleural effusion, always think of ovarian hyperstimulation syndrome. One more differential will be theca lutein-cis. So theca lutein-cis, remember, are seen in relation with molar pregnancy, and you would see that when you image the uterus, you would find this multifocal cystic lesions, right? So you'd find these multiple cluster of grapes or a snowstorm appearance wherein there are no fetal parts but just cystic contents. Alright, so these are the two differentials when you find multiple large follicles in both the ovaries. When you look at this appearance here, so now looking at some anomalies, you can find that the cranium is not there, so there is acrania, and when you look at the face, you can find here that the eyes appear very prominent because of the absence of skull here, and you see this dysplastic brain. So this is called as the frog eye or the Mickey Mouse sign, alright, and this is seen with anencephaly. So anencephaly, remember, happens to be the earliest anomaly that can be detected, right? So it's an earliest congenital anomaly that can be detected as early as the first trimester 11-week scan. So this is anencephaly. Now we have two other anomalies that we want to discuss. In this image, you can see that this is the fetal abdomen, and you are seeing that the bowel loops are herniating outside. They are not enclosed by any membrane. It is seen on the right of the midline. So this is gastroschisis. On the other hand, when you find that there is this membrane filled outpouching which is in the midline, the cord inserts at the apex. Even solid organs can go along with this sac, and associated anomalies are more common. This is omphalocele. Right, so when you see the herniation of contents from the abdomen, these are the two possibilities, and this is how we distinguish them. Talking about the signs in twins, again very frequently asked. So when you see that there are two babies here and they are separated by this membrane, we know for sure that it's diamniotic. Now, is it monochorionic or dichorionic? So when you find, so if this is the placenta here that you are seeing, and you find that there is a widening here, right? The intertwin membrane first of all is thick, alright. So this membrane is thick, more than 2 millimeters, plus there is this separation here where both the placentas are entering. So this is a phenomenon that we see with dichorionic diamniotic pregnancy. So this is seen with DCDA, which is referred to as twin peak or lambda sign. On the other hand, when you find that this is the intertwin membrane, which is, so again this makes it diamniotic, but this intertwin membrane is very thin, it is less than 2 mm, and look at the insertion, perpendicular insertion. So here there is sharing of the chorion, sharing of the placenta. So this is seen in monochorionic diamniotic pregnancy, referred to as the T sign. Alright, so this is about the twin pregnancy signs. Looking at the next image here, a 45-year-old female presenting with abnormal uterine bleeding. Ultrasound is shown here. What is the likely diagnosis? So this is the uterus, this is a transvaginal sonogram, and you can see that there is a hyperechoic lesion in the endometrium which is having this stalk. So this is referred to as the feeding vessel sign. So remember, this feeding vessel sign is seen with endometrial polyps. This is the hallmark of an endometrial polyp, wherein you have this feeding vessel visualized on the Doppler imaging. Now talking about breast imaging. So when I ask you mammography, what is the view that we take? Remember, there are two views, one of which is MLO view, which is mediolateral oblique, and the second one is referred to as a craniocaudal view, which is CC view. So these are the two views that we take. So craniocaudal view and MLO. When I ask you where is more breast tissue covered, it is the mediolateral oblique view. How to identify? So look out for the pectoralis muscle. This is your MLO view. This is the craniocaudal view. Alright. Now let's look at a few salient features. So when you see a well-defined rounded mass, clinically very mobile, very well defined, we are talking in terms of fibroadenoma. And when you see this white coarse calcification, that is referred to as the popcorn sign, we know that this is a fibroadenoma. So this is associated with fibroadenoma, particularly one which is involuting. Alright, so it's in its involuting resolving phase because of the calcification. When I ask you about breast implants, what is the investigation of choice? Remember, it's going to be MRI, right? So it's going to be MRI, and this is one very important sign on MR you need to know, wherein anytime there is an intracapsular tear of breast implant, intracapsular rupture of breast implant, you would see these various lines within the implant which are referred to as the linguini sign or the teardrop sign or the keyhole sign. All of these names are used for the intracapsular rupture of breast implant. So with this, we finish genitourinary radiology. Next, we continue with nuclear medicine and radiotherapy. From this particular section, although it's a very large chunk, in fact, these are MD branches by themselves, both of them independently, but you do not get a lot of questions from them, and the kind of questions which come are usually straightforward one-liners. So that is what our main focus would be here, to get those direct questions correct. Alright, so now let's quickly look at an overview of the various nuclear medicine tests that we have and what are the applications. That is usually the questions which we get from this particular topic. So technetium-99 MDP, very important, wherein MDP stands for methylene diphosphonate, and this goes to any area where there is newborn formation. That is the whole concept. So I want you to remember that technetium-99 MDP or a bone scan would be positive for any site when newborn is forming, such as any osteoblastic metastasis, right? So bony metastasis, if there is a fracture, if there is osteoarthritis, if there is Paget's disease, all of these conditions will have a hot spot wherever you have this MDP getting taken up. Remember here one very important fact, because there is no newborn formation here in multiple myeloma, it shows a cold spot, a very frequently asked topic. Going to the HIDA scan. HIDA scan again is a compound that is excreted from the liver into the bile ducts, and then it passes into the bowel loops. So when we do not see the opacification of bowel loops, we know that there's something wrong with the biliary radicals, right? So this is used for the diagnosis of extrahepatic biliary atresia. but it's not a very good positive predictive value test, but a more suitable test to rule out extrahepatic biliary atresia, in the way that if I see the HIDA agent passing into the bowel loops, I know that EHBA is unlikely, so that becomes ruled out. So it's a good test to rule out EHBA. Apart from this, remember, this is also used for acute cholecystitis and is also used for bile leaks. Alright, for acute cholecystitis, HIDA remains the most accurate. For bile leak, it is the most sensitive. So remember these one-liners about the HIDA scan. Talking about the technetium-99 sestamine scan, it is used in two places. One is to look for parathyroid adenoma. It is the most sensitive investigation to localize a parathyroid adenoma, and you would see here also that it is used for a cardiac scan that will be looking. Technetium-99 sulfur colloid scan goes to any cell which has reticuloendothelial system components. So one liver tumor that shows uptake with this is fibrous nodular hyperplasia because of presence of Kupffer cells. So remember, in the liver, FNH shows uptake with sulfur colloid. It can also be used to identify occult abscesses, and it is also very useful for picking up accessory spleen. Alright, so for picking up spleninculi, this is again a very useful investigation. Technetium-99 pertechnate, most important, used for Meckel's diverticulum. It can also be used for a thyroid scan. Remember, it can also be used for a thyroid scan in our country in place of iodine 123, which is very rarely available. And also remember, one salivary gland tumor which shows an uptake with pertechnate is going to be the Warthin's tumor. Alright, so Warthin's tumor in the salivary gland shows an uptake with the pertechnate scan. Technetium labeled RBC is useful for GI bleed. It remains the most sensitive investigation to pick up GI bleed, but has very poor localization. Alright, so it doesn't do very well in localizing the site of the bleeding, but it's very sensitive to pick it up. So then coming on to technetium tetrophosphine, sestamine and thallium scan. These are all myocardial perfusion studies. Alright, so they evaluate the perfusion to the heart and they detect ischemia. Alright, so they detect ischemia as a cold spot. So wherever is the ischemia, the perfusion will be lowered and that appears as a cold spot. On the other hand, we have a pyrophosphate scan. This is an infarct specific scan. So wherever is the infarcted tissue, pyrophosphate will bind to it, giving rise to a hotspot. So this is used as an infarct scan. You can remember it as pyro means fire and it shows a hotspot where there is infarct. Coming on to the HMPO SPECT, this is a scan which evaluates CNS perfusion, cerebral perfusion. So this can be looked So this can be used to look out for focal seizures. Alright, so to know where the seizure focus is originating from. It can also be used in brain death to confirm that there is no blood flow to the brain, and it gives a sign called as the hot nose, in which we will not see any intracranial uptake and it appears like everything is accumulated around the nose, giving rise to the hot nose sign. DAT-SPECT is an advanced modality, something for the Central Institute exams, where this is a sensitive test to pick up Parkinson's disease. Alright, so this DAT stands for dopamine transporter. So this is used in cases of Parkinson's disease. Now looking at the various PET compounds and also few recent advances as far as the PET studies go. So 18 FTG PET, remember this is the standard FTG PET that we use to pick up metastasis. So it's the investigation of choice to always evaluate metastatic disease in any sort of primary malignancy. Sodium fluoride PET, remember it's the best investigation. It's the best investigation to pick up bony metastasis. Alright, so it is the best for bony met sodium fluoride PET. All of these are recent advances, particularly for Central Institute exams. Choline PET, PMSA PET are now being used very frequently for prostate CA evaluation. DOPA PET, remember again showing dopamine and its precursors basically. So this is very useful for evaluating pheochromocytomas and paragangliomas. The C11 Pittsburgh compound BPET, this is a recent advance which is useful for Alzheimer's disease. Alright, so this is useful in Alzheimer's. Methionine fluorothymidine PET are being used nowadays for brain tumor evaluation, and mesopet. So as we've discussed in radiotherapy, oxygen is a very potent radiosensitizer. Alright, so anytime you want to see are there any areas which are hypoxic in the radiotherapy field, we can evaluate it using this mesopet. So this is actually used for hypoxia imaging. Alright, so that we know if the radiotherapy will be effective or more oxygen needs to be given. So remember, mesopet used for hypoxia imaging before planning radiotherapy. Now looking at the images, so what you see here are diffusely the bones basically. So this is how a normal bone scan appears. If there is any increased uptake, that would appear as a hotspot in that particular focal bone. What we see here, so in this case when we see that there is this increased hotspot along the sacrum, this is the typical Honda sign where you see this H like the Honda. So this is the Honda sign that is used for sacral insufficiency fracture. So this is seen as a hotspot in cases of sacral insufficiency fractures. Going ahead, this is when we see that all the bones diffusely are appearing as hotspots. So there is diffused uptake by all the bones, and you see that the kidneys are not visualized. This is referred to as a super scan when everything is showing up as a hotspot. This can be seen, one, when there is renal failure, that the kidneys are unable to excrete out the compound. Second, metabolic bone disease, wherein all the bones throughout the body are going this rapid turnover. Again, we will see a super scan, and in cases of diffuse mets, all the bones are involved by metastasis, we can see this super scan. Very important question. So what is this test that we are seeing here? So if you look carefully, this is the HIDA scan, this is the gallbladder that is being excreted, and these are the bowel loops which are progressively getting opacified because of the passage of HIDA. So this is the HIDA scan, and now when I see that in a child who is having neonatal jaundice and I can see that there is bowel loop opacification, can I exclude out the possibility of extrahepatic biliary atresia? Answer is yes, that when there is passage of the HIDA compound into the bowel loops, it excludes the presence of extrahepatic biliary atresia, and that is why it has very high negative predictive value. Going ahead, so if I show you this scan, that there's a liver tumor which shows a hotspot. What is this scan that we are seeing? So this is a technetium labeled sulfur colloid scan, right? So there's a sulfur colloid scan, and the tumor here is going to be a fibrous nodular hyperplasia which appears as a hotspot because of Kupffer cells. Looking at this question, infant with brown stools, child looks normal, and a radionuclide study is performed which is showing us uptake in the stomach, and there is this abnormality in the right iliac fossa which is showing uptake, which is nothing but a Meckel's diverticulum. Because it has the presence of gastric mucosa, it will appear as a hotspot and it will bind to technetium 99M per technate, right? So this is the per technate scan which will be positive in cases of Meckel's diverticulum. What is the modality shown in this image? So when you see this background CT and areas of uptake, this is nothing but a PET CT. This is how a PET CT will appear. And how does the PET CT work? So remember, the concept behind a PET CT is described as an annihilation coincidence principle. So what does this big word mean? So anytime we inject this compound, which is 18-fluorodeoxyglucose, 18-fluoride is the positron emitter, and the deoxyglucose is what is going to take it to the hypermetabolic malignant cells. So anywhere there are malignant cells, they are going to be taking up this deoxyglucose and in turn the entire 18-FTG compound. Now what they are going to do basically is inside the cell because of glycolysis, and we know that malignant cells rely on anaerobic glycolysis, right, which is called the Warthin effect. So this is the Warthin effect wherein the malignant cells are relying on anaerobic glycolysis and they take up this deoxyglucose and form it. The hexokinase will act on it and it will convert it to 18-FDG phosphate. Right. Now this phosphate has entered the malignant cells but it cannot leave it, and the glycolysis will not continue with this compound. So all of this FDG is phosphorylated and it's accumulated amongst the malignant cells. Now, the positron emitting radionuclide, which is our 18 fluoride, will do its job and emit out the positron within the malignant cell. And we have loads of electrons which will combine with this positron. So, positron and electron will combine, matter, antimatter. This reaction basically is called as annihilation, and it results in the release of this very high energy gamma ray 180 degree in direction to one another. So, two gamma rays 511 keV in energy are released in 180 degree opposite direction. And when we go to our PET scanner, we would find that only when the detector will detect that simultaneously 180 degree apart, two equal energy gamma rays are being detected, the principle. So, now when we go to the PET scanner and we find that these two gamma rays are reaching the detector at the same time, this is counted as an uptake, and this is called as the coincidence principle. So, you have annihilation when positron electron meets, and then you have coincidence in terms of the detector. So, this is the concept of the PET scan. And one thing you need to remember, always check the random blood sugar before doing the PET, because if this is deranged, our whole Warden effect, everything falls apart, alright. So, you will not have this selective uptake by the malignant cells if there is glucose derangement in all the cells, alright. So, that is something which is very important. So, now talking about the concept of the PET scanner. So, when we have the 18 fluoride deoxyglucose which is being injected into the cells, they will be selectively taken up by the malignant cells because of the Warburg effect. Because these cells are relying on anaerobic glycolysis, they are hungry for this glucose that we are injecting. The moment the glucose goes into those cells, it gets phosphorylated for glycolysis and it is trapped. Alright, so all of this deoxyglucose in the form of a phosphate is trapped because the glycolysis cannot proceed further, and now the 18 fluoride, which is the positron emitter, will come into play. So, it emits out the positron which combines with the electrons, and when this reaction happens, matter antimatter, there is a release of a huge amount of energy in the form of two gamma rays which are 511 kilo electron volt each in 180 degree direction opposite to one another. So, when this reaction happens, the PET scanner detector will detect them at the same time, and this whole concept is referred to as annihilation coincidence circuit. Alright, so this refers to the fact that there is annihilation when electron positron combine, and the coincidence that both these rays must be detected at the same time. One thing to be kept in mind, remember, so always check the sugar, the glucose in the patient before doing a PET scan in order to make sure that the sugar is well controlled. Otherwise, the selectivity of uptake by the tumor cells is under question. Alright, so that is why we always need to ensure that the patient, if he's a diabetic, the diabetes is well controlled. Now, looking at this question here, so identify the incorrect pair. Sodium fluoride PET for bone mets, this is correct. Choline PET is not for endometrial but for prostate CA, so this is incorrect. PMSA PET is again used for prostate. Dotanoc PET is again a recent advance which is very useful for neuroendocrine tumor. Alright, so if you hear the word Dotanoc or Dotatate or Dotatalk, all of these basically are the same thing, wherein we use octreotide analogues. Alright, so octreotide analogues are used here for detection of neuroendocrine tumors. One neuroendocrine tumor which is not sensitively picked up here is going to be insulinoma. So, remember, the exception is insulinoma. C11 methionine PET is useful for brain tumors. This is correct. So, this is about the nuclear medicine section, and now we begin with the radiotherapy aspect of things. So, now let's talk about radiotherapy. So, the first thing we want to talk about is types of radiotherapy depending on the mode of administration. So, the first thing that we use most commonly is called external beam radiotherapy or teletherapy, wherein the source is away from the patient. On the other hand, brachytherapy, as the name suggests, the source is close to the tumor. Alright, so this can be of three types. One is the endocavitary type, which is frequently used in cases of CA cervix. Second is the interstitial type, where if this is the tumor, the radioisotopes are embedded within the tumor site. This is used very frequently with prostate CA. The third one is a mold brachytherapy, when a mold is created. This is used for superficial tumors like eyelid tumors, penile tumors, lip tumors, wherein the mold in the shape of the organ is created and the radioisotope is placed as a mold on the tumor site. Finally, we can have a systemic mode wherein we give oral or IV injection of the radioisotope and it goes and binds to the tumor site. This is used as iodine 131 for thyroid malignancies. We can use samarium and strontium for bone metastasis. Phosphorus 32 can be used for polycythemia vera. So, all of these are systemic radiotherapy agents. Now, when we talk about the agents per se for radiotherapy, what are the particles or the rays that we use? First of all, gamma rays, which were the oldest agents that were used. And what is the source of the gamma rays? They came from the radioisotopes, right? So, long acting radioisotopes like cobalt 60, cesium 137 were the most common sources of gamma rays that were being used. But now the most common source, remember, is X-rays. Alright, so X-rays and electrons both can be produced by a machine called LINAC, which stands for a linear accelerator. Protons are very rarely used. They are produced by a machine called cyclotron, which is not available very routinely, right? So, protons are produced by cyclotron. Now, you had a question of Bragg's peak is seen with. So, remember, Bragg's peak is a property of protons wherein if we look at the dose depth curve, alright, how the particles, different particles will behave as the depth to the tumor site increases. So, if this is the skin and this is how deep we go into the soft tissues, this is the depth and this is how the dosage of the particle acts, or where is the maximum impact of the radioisotope. This is how we can plot it. So, when we talk about protons, alright, they have a special curve wherein their peak occurs very deep into the tissue. This is referred to as Bragg's peak. Alright, so this is called the Bragg's peak, which is seen in protons, and that is why it is very useful for deep seated tumors, right? Does it make sense? Because it is not causing any harmful effects to the superficial structures. It is very useful for deep seated tumors such as clival chordomas. This is also a previous year questions. Very useful in children, again, to save them from the damage to the surrounding structures. Apart from that, when we talk about the other agents, remember, if we talk about electrons, electrons again have a very low lying action. They only act superficially. That is why electrons frequently are used for cutaneous malignancies like cutaneous T-cell lymphoma, also called as mycosis fungoides, or they can be used for intraoperative radiotherapy. Alright, so they can be useful for intraop radiotherapy. On the other hand, the gamma rays and the X-rays have a very predictable action wherein their effect keeps decreasing as we go superficially. Alright, so this is how gamma rays and X-rays will behave. So, this is the dose depth curve. Going further ahead, looking at a few images. So, this is how a LINAC machine appears, a linear accelerator. This image here shows you, again, you can read the word proton here. This is how a cyclotron appears. Looking at the various modes, so here you can see on the X-ray that these are the radioisotopes, radio-opaque isotopes, which are embedded within the prostate, right? The shape kind of gives it away. So, this is a type of brachytherapy. So, this is a brachytherapy within the prostate. These are molds which have again been created for mold brachytherapy, whereas this one will be the interstitial type of brachytherapy, right? Wherein we embed them within the prostate gland. What is this procedure being shown here? So, this is referred to as remote afterloading. So, anytime, let's just assume we are doing an interstitial brachytherapy for prostate CA. If the operator will embed those radioisotopes himself, he will be exposed, right? He'll be exposed to the radiation. So, in order to save that, what we can do is take this fixed grid and put in empty cartridges. So, we put in empty cartridges or empty pellets, and after that, after we have done that, everybody leaves the room and a robotic device will place in the radioisotope. This is referred to as a remote afterloading, where the loading of the radioisotope is done remotely. Alright, so this technique is used for brachytherapy. Remember, this is a previous year question. Alright. Going ahead to a few half-lives that we need to remember. So, now starting with the important half-life. So, very quickly we'll revise this table. So, 18-FTG has a half-life of 110 minutes. Alright, this is a compound used for PET scan as we just discussed. Technetium-99, just invert the 9. It has a half-life of 6 hours. Again, very useful for nuclear medicine scans. Iodine, let's bring all the radioisotopes of iodine together. Remember, iodine 123, the shortest isotope, will have a T-half in hours, rest of it will have it in days. So 123, you take out the 1 and 3, it becomes 13 hours. For 124, just take the last digit, it becomes 4 days. For 125, just do 12 into 5 equals 60. It has a half-life of 60 days. Whereas iodine 131, you just add the numbers and now 3 is left out. So you take 3 again. So it gives you a sum of 8 days. So this is how we can do some bit of math and remember the half-lives of iodine. Phosphorus 32, 192, again you group them together. You bring it into days and 2 plus 2, the last 2 digits, we make it 4 and I write 4 here. Now time for some more math. So 3 minus 2 equals 1. So T-half of phosphorus 32 is 14 days while 9 minus 2 equals 7. So the T-half of iridium 192 is 74 days. Cobalt 60, a question mark there because it's the most frequently tested half-life and you must not get it wrong even if you forget all the other math that we are doing. Cobalt 60, 5.2 years. Cesium 137 has a half-life of 30 years, a very long half-life for both of these. Gold and yttrium, both of them have a half-life of 2 days, while the longest half-life, radium 226, the oldest compound, remember, place a 1 and then just make this opposite. So 1622 years is the half-life of radium. So these are all the half-lives that you need to memorize. I hope this is simple now. Just fill this table up one more time and I think you should be good right before your exam. So now let's talk about radio sensitizers and radio protectors. So oxygen is the most potent radio sensitizer and one of the reasons why that is so is because one of the mechanisms by which radiotherapy acts is free radical generation and oxygen is a must for that. Alright, apart from that, remember all the chemotherapeutic drugs that you know of, particularly 5-fluorouracil, gemcitabine, are particularly more potent, but any chemotherapeutic drug or anti-cancer drug is again a radiosensitizer except for one drug which is cyclophosphamide. Alright, so except for cyclophosphamide, everything else is a radiosensitizer. Going on to radioprotectors, remember amifostin is a radioprotector except that it doesn't cross the blood-brain barrier, alright. So except for the brain, it can protect any organ. Apart from that, all the antioxidants, because free radical generation is one of the mechanisms, I want you to remember that antioxidants will be radioprotectors. So vitamin A, C, E, pentoxifylline, zinc, all of these will be radioprotectors. Apart from that, GM-CSF, so granulocyte monocyte colony stimulating factor, all of these are radioprotectors. Now let's talk about the list of the most sensitive and the least sensitive answers to various questions. Alright, so when asked the most sensitive cell type, remember it's going to be the undifferentiated cells which are very rapidly dividing, while the well-differentiated cells which are not dividing or are quiescent are going to be radio-resistant. This is called as the law of Burgoni. So this is called as the Burgoni's law. When we talk about the organ, think of the pelvis. Alright, so most sensitive organ, remember, is going to be the gonads, where constantly the cells are dividing, while the least sensitive is the vaginal epithelium. Alright, so remember the vaginal epithelium, very well differentiated, it's radio-resistant. Blood cell, the largest nucleus, so hence most sensitive. Lymphocyte, something which doesn't have a nucleus, answer will be platelet for least sensitive. Cell cycle phase, most sensitive is going to be the G2M phase, while the least sensitive is S phase. Very, very frequently asked. When talked about the tissue, remember the most sensitive tissue is going to be the hematopoietic tissue. Again, rapid division is happening constantly, while the CNS or the brain is the least sensitive tissue that we have. Ocular structure, lens, we know cataract is a deterministic side effect, is the most sensitive tissue, while the sclera will be the least sensitive. When talked about the retinal layer, a controversial topic, most sensitive is going to be the vascular endothelium. Alright, so retinal vascular endothelium is most sensitive, while least sensitive is going to be retinal pigment epithelium followed by ganglion cell layer. Alright, so these are the various questions that can be answered from this single table. Now let's talk about the list of radiosensitive and radioresistant tumors. Again, two mnemonics that we remember. Radiosensitive tumors, remember Wilms. So, Wilms tumor in children, Ewing sarcoma, lymphoma and leukemia. So, all your small round blue cell tumors, undifferentiated tumors will be radiosensitive. In the elderly, multiple myeloma, S for seminoma. So, all of these are radio sensitive. When we talk about radio resistant, remember the mnemonic HOMP. So, HCC, RCC, radio resistant, osteosarcoma, melanoma and pancreatic CA. All of these are radio resistant tumors. Stereotactic radiosurgery, also called as gamma knife, is used for all of the following except vestibular schwannoma. It is one indication. Trigeminal neuralgia, yes, when it's refractory to carbamazepine drugs, we can use SRS. AV malformation, yes, first line will be DSA, but if this is not responsive, there's recurrent AVM, we can do gamma knife. But tuberculomas, remember, it's a medical management. Gamma knife radiotherapy has no role in it, infection. Alright, so when we talk about stereotactic radiosurgery, we are referring to gamma knife. So here we basically use this helmet which was discovered by the scientist who was called Lars Lexell, and based on his name this is referred to as the Lexell frame, wherein you provide the frame XYZ coordinates, and here this is the source of the cobalt 60 which will be given at a high dose in a very high precision manner to that exact coordinate of the tumor. Alright, so here we can deliver very high dose of radiation precisely to the tumor and avoid harmful effects to the surrounding organs. Okay, so this is the principle of a gamma knife. Remember the applications: vestibular schwannomas, pituitary adenomas, refractory trigeminal neuralgia is one application that we have seen in the options. Solitary brain metastasis, we can use gamma knife. Apart from this, vascular lesions like glomus lesions, alright, or AV malformations, we can use gamma knife. So these are the common indications of using gamma knife, and remember cobalt 60 is used as the source of the gamma knife here. Then let's talk about prophylactic craniospinal. Now let's talk about prophylactic craniospinal irradiation. So this is very useful for small cell CA lung, a very poor prognostic tumor which has very high propensity for metastasis. So we give prophylactic radiotherapy to the brain spine axis. Apart from that, ALL, again a tumor in children which has a very high scope of these micrometastasis, hence prophylactic irradiation is given. Apart from that, also remember medulloblastoma, a fourth ventricular tumor in children, wherein we give this, and all the other tumors which cause drop metastasis. So what are drop metastasis? Look at this contrast enhanced MRI. You can see that there is this enhancing deposits. There are these various enhancing deposits around coating the spinal cord which are referred to as drop mets, and this appearance is called as sugar coating. In German, this is referred to as Zuckerguss. So some people also like to use the term Zuckerguss sign here. This is something which can be seen with a lot of brain tumors, most marked of which is medulloblastoma, ependymoma, glioblastoma multiforme, all the undifferentiated, rapidly dividing tumors such as leukemia, lymphoma, germinomas. All the blastomas and the germinomas will show this drop metastasis. Apart from that, any tumor which is within the ventricles like choroid plexus papilloma or a choroid plexus carcinoma, because carcinoma will have metastasis, you can have these drop metastasis. Alright. Now let's talk about a few important one-liners that can be tested from radiotherapy. So, most common side effect of radiotherapy. Remember, this is erythema. Erythema is a deterministic side effect most commonly seen. Most common RT-induced malignancy. The answer to this is going to be leukemia. Most common brain tumor after craniospinal irradiation. Remember, it is meningioma which occurs in the brain, and the most common endocrine deficiency to occur after craniospinal RT, remember, is going to be growth hormone deficiency. Alright. Apart from this, most common RT induced thyroid malignancy, it's the papillary CA thyroid which is most common and the most common bone cancer. Ironically, it itself is radio resistant, but it occurs after radiotherapy, is osteosarcoma. So now coming on to the final slide, 5 R's of fractionated radiotherapy. So remember, the 5 R's include repopulation. So when we divide the radiotherapy into fractions, remember we are trying to repopulate normal cells so that they get a chance to basically repair, the normal surrounding organs get a chance to repair, but the disadvantage is that the tumor cells will also repair. So we can't have the breaks as very long, we can't have the breaks exceed 48 hours. So repopulation affects normal as well as tumor cells. Reoxygenation. This is what is very important. We know that oxygen is a radiosensitizer. So if there is ischemia, if there is ischemic necrosis because of radiotherapy, we want to give the area, we want to give the tumor time for the oxygenation to happen again so that radiotherapy can be effective. Alright, so this is again 1 hour. Repair, we want the normal cells to undergo repair in that break. Redistribution, if there were cells which were in the G2M, there were also cells which were in the S phase, which is relatively radio resistant, right? So I want these cells to go to G2M phase and become radio sensitive. So because of that, the redistribution of cycle happens. This is called as redistribution. Apart from that, the 5th R is called radio sensitivity, wherein we take into account all the radiosensitive aspect of various tissues. So these are the 5 R's, whereas the radiation recall here is actually a side effect of chemotherapeutic drugs. The side effect particularly seen with anthracyclines, wherein you have radiation recall. So the site which had received radiotherapy, following which you got the chemotherapy, will again start to show signs of erythema, inflammation, you know, the symptoms which happened at the time of RT. So this is called as radiation recall syndrome. So these are all the salient features that we had to learn about radiotherapy and all the important aspects. So I hope you guys make the most of this rapid revision. We have covered almost the entire syllabus in this amount of time, and I hope this gives you some benefit as a last moment revision, and hopefully you'll get all the questions from this. So that is my hope for you guys, and wishing you all the best. Thank you so much.